Okay, so good morning, everybody. My name is Olivier Bertrand, and I'm very honored today with my good friends Zoltan and Zol to welcome you for this, let's call it the first FFR workshop. So I want to be quite short, but I mean, maybe you can wonder why, as part of a radialist meeting, we want to discuss about FFR. I mean, the reason to me, and it will summarize my thought about this. Last year, I was invited at ESC FFR meeting with all the most famous, I would say, FFR people around the world. And I was a bit shocked because we certainly could discuss the indication, the benefit, the clinical advantages of FFR. And I was listening to Nico Pales, and I fully agree with everything he was saying, until the minute I could see that when he was moving to the PCI, I could see the large 7 French guiding catheter from the femoral approach. And I was thinking, oh my God, I mean, we have solved the peri-procedural risk, we managed the same-day discharge, reduce the cost, so we're going to also manage now the indication and the management prior PCI. In the overall improvement of patient care, as you can guess. So I guess you will all agree with me. And now we'll just let Zoltan and Zol welcome you in Budapest.
Just some words about Budapest. Budapest is the capital of Hungary. Everybody knows it has nearly 2 million inhabitants, and the industrial area is bigger. It has 3 millions of people. It's a Celtic city. It was the capital of the Pannonia Inferior, and Arpad lead Hungarians occupied this Arpad basin, and it became the capital of the Kingdom of Hungary. And now we are here in the middle of Europe. We Hungarians are real pioneers, real horsemen, and real radialists. So welcome here in Budapest. I give some words to my friend Zsolt Pirot, who is the co-organizer of the Congress. Thank you very much.
Ladies and gentlemen, good morning. On behalf of the local organizers, it is my pleasure to welcome you all here. As you have seen, that the program is quite tight. So, of course, all the speakers are kindly asked to keep their times, and the audience is kindly asked to interact. So please feel free to ask questions. There are no stupid questions, and I think we will learn a lot by the end of the day. So please enjoy it here, enjoy in Budapest, and enjoy the whole meeting, not only the FFR workshop, but also AimRADIAL. And thank you very much for coming all over.
Okay, so now we're going to start with the first challenge of this meeting, which I've already known quite a few. I mean, I guess many of you arrived yesterday, and as you know, we had a bomb alert, and we had to stay outside for 4 hours. So that's the first one. The second one is a little bit more sad. I mean, the first speaker is my friend, Rosaire Mongrain, and he had a very significant family issue over the weekend, so he could not show up. But he still wanted to be part of us, and I think it's obviously very important to understand some of the basics of fluid mechanics and physiology. And so he will give his perspective as an engineer from Canada, and he will be doing his talk by Skype.
So, can I start now? Can I start? Oui. So, first of all, ladies and gentlemen, I wanted to be in person in Budapest, but as Dr. Bertrand just said, I had like very important serious event in my life, and so I had to stay in Montreal to manage this situation. I would like to thank, before starting, Dr. Bertrand for inviting me for this event. As he said, I'm an engineer, I'm a biomechanicist, and so today I will talk briefly about the biofluid mechanics and fractional flow reserve, but from a biomechanicist perspective. So I will not repeat what you already know about fractional flow reserve, so I'm going to go right away into the heart of the topic. So as you all know, the assessment of stenosis has evolved from purely geometrical anatomical characterization using ratios of diameters or areas to a more functional assessment from which we have examples from the Gould equation and the Bolson, the Brown models, and many others have proposed elaborate additional models. The reason why I selected this particular model is because it's quite useful, but also reflects very important physical and mechanical aspects related to the functional assessment. So through stenosis, as you all know, we have a pressure gradient, delta P, and expressed in terms of the flowing speed or the flow rate, we clearly see in this model two contributions. First, a viscosity contribution, which is proportional to the flow itself. Viscosity, we know is direct. I mean, this is directly proportional to the dynamic viscosity of blood. So this is a viscous thermodynamic irreversible process. And we have a kinetic term. We see V squared, which is the kinetic energy. And this is in fact reversible, but in the immediate vicinity, in the post-kinetic region, we have energy which is stored in this kinetic form, which eventually would recover more downstream of the stenosis. I put this mark here so that those who know about the Taylor series expansion would realize that this in fact corresponds simply to the two first terms in a Taylor series expansion, assuming that the pressure gradient is a function of the flow Q, flow rate Q. More elaborate models can be obtained if you generalize this function to Q, dQ dt, and other parameters. So this again, I'm pretty sure that you all know the definition of FFR, which is simply the maximum, which is the ratio of the maximum flow in presence of a disease to the maximal flow in healthy condition. This is flow ratio. This is why it's called fractional flow ratio. But it is impractical to measure flow, as you all know, and we, transform this ratio into a pressure ratio by using an hydraulic model. So the hydraulic model that we all know is with this simplified model here, where you have the aorta and the aortic pressure. I'm pretty sure you all know. The stenosis, the flow through the stenosis, the stenosis distal pressure, and the venous pressure, and the myocardial bed hydraulic resistance. So this we all know. So this hydraulic model then simply transform the Q in terms of the ratio of a gradient of pressure over a hydraulic resistance. So referring to this model, we have as the numerator PD minus PV over the myocardial bed resistance in presence of a disease, and PA0 minus PV over the myocardial bed resistance in a healthy condition. So this requires a conceptual jump. The conceptual jump is to, as I just said, replace the measurement of flow by the measurement of pressure and the assessment eventually of a resistance that, as we're going to see and as you already know, that we eventually are going to try to remove. So this conceptual jump is in fact an analogy, is taken from an analogy between hydraulic and electrical circuit. This is a very important thing to realize, because in electrical circuit there is no notion actually of viscosity. And viscosity in the fluid is actually over the entire volume of the fluid, whereas in the electrical circuit, the resistance is actually very localized. And this has very important consequences in terms of the assessment of FFR, as we are going to see very soon. So in this simplified ratio that we have not yet simplified further, we have essentially 5 parameters. PA0, the aortic pressure, PD, the distal stenosis pressure, PV, the venous pressure, and the 2 myocardial bed resistances given in their physical units. So, first simplification is that we are going to, as you know, get rid of the venous pressure by simply saying that it is small. So small means, like for most of the cases, ranging from, let's say, almost 0 to 5 millimeters of mercury. And so in most of the cases, it will correspond to a 0.01 or 0.02 digit in the FFR computation. So in that particular case, as we know, when the venous pressures can be neglected, then the above definition simplifies to simply PD over resistance divided by PA0, the aortic pressure over the myocardial bed resistance. So, however, the FFR is a ratio, and being a ratio, it's very sensitive to its denominator, and so we have to be careful about this PV being neglectable. So it was reported. As I said, I'm a biomechanicist, I'm not a cardiologist, but I know that it was reported in the literature that the venous pressure can sometimes be significant, for example, in hemodialysis patients. The other simplification, of course, is to remove the myocardial bed resistances by referring to the relation between the coronary blood flow and coronary perfusion pressure, which or the autoregulation of coronary blood flow based on perfusion pressure. And the FFR calculation then is further simplified by assuming that the diseased and the healthy myocardial resistances become equal under induced maximal hyperemic condition, of course in the absence of microvascular disease. So, interestingly, when you look at the curve, we realize that in a certain range of coronary perfusion pressure, the relation between the coronary blood flow and the coronary perfusion pressure is essentially linear. And this is based on that linearity that we can eventually, and the minimization of the resistance, that we can, should I say, cancel out the ratio. It's not that it is neglected, it is actually simply mathematically canceled out. So this particular curve is important to this notion of canceling out the myocardial bed resistances. So then we end up with our very well-known definition of FFR, which is simply PD over PA0. So we might think that this simple ratio is a simple thing to assess, but in fact it should be noted that that first of all, the linear relationship that is implicitly used between the coronary blood flow and the coronary perfusion pressure is directly related to the resistance itself. So in that particular curve, the higher the slope of the curve, the lower is the resistance. So based on this property, then we also know that the hyperemic condition will bring a lower resistance, in fact, than the maximal physiological dilation. So then it kind of makes sense, even from a biofluid perspective, that we can neglect those myocardial bed resistances. So for a biomechanicist, the problem is not about those myocardial bed resistances, but more about PD, the distal stenosis pressure. So this is in fact linked to the implicit conceptual jump in using hydraulic models. So hydraulic models is essentially a lump modeling of a more general modeling of the flow, which is fluid mechanics. In going from fluid mechanics to hydraulics, we neglect complex local phenomena in the immediate vicinity in the post-stenotic region, which is related to complex phenomena like separation, vortices, recirculation, turbulences. And all of this essentially would be lumped to a resistance value R and one single value PD, which is an oversimplification, I mean, as I said, from the perspective of a mechanical engineer. This would be something that we don't do. We do right away fluid mechanics all the time. So that's why people like Charles Taylor derive the heart flow models, because Charles Taylor is a biomechanicist, and he, I think, was, should I say, trusting more fluid mechanics than a lumped modeling. So here are examples of complex phenomena of recirculation and flow separation in the throat of a stenosis. Secondary flows in curvature and bifurcations combined with separation, and all of these phenomena create what we call in engineering dynamic pressure gradients. So those dynamic pressure gradients, which are linked to the V squared or the Q squared in the Gould equation, would eventually be recovered, but somewhat downstream, a bit more downstream past the stenosis. So then the PD, we can ask ourselves, where should we measure? Where should we put the pressure sensor downstream in the stenosis? Well, an engineer would reply to that we need to determine this position based on fluid mechanics. So, from a biofluid perspective, to answer this question, we refer to the notion of what we call in engineering velocity field recovery. In other words, the engineer is asking himself, where does the flow become undisturbed past the stenosis? We have equations that were derived based on fluid mechanics, and one of them is the Boussinesq equation, which relates the length needed for the recovery of the velocity field divided by the diameter of the vessel, which is proportional to the Reynolds number. The Reynolds number is a ratio of the this kinetic terms divided by viscosity, which is given here. It's a simple ratio. And that particular ratio, this Reynolds number, assumes values ranging for coronary artery, let's say around 250, 300, 500 to 600 for mid-range stenosis, and above 1,000 for severe stenosis because of the small jet coming out in a severe stenosis. So if we compute then the Boussinesq equation, which is a simple multiplication for this case, and so we take a mid-range stenosis, we realize that the velocity would be fully recovered 10 centimeters downstream of the stenosis. So this is, let's say, impractical because of all the side branches and so on. So in practice, we always, I mean, you guys, I suppose, always compromise and position the sensor a bit less downstream than 10 centimeters. So, as a result, because you compromise the position, because you have no choice, then the measurement of PD is affected by a certain error that I don't know, I did not compute its value, due to local dynamic pressure gradients. So again, I emphasize this notion of local dynamic pressure gradients in the post-stenotic region. So it should be noted that these dynamic pressure gradients are very sensitive to geometry changes. And those geometry changes can be induced by the presence of wires, catheters, wall deformation, side branches, and other situations like other proximal stenoses. So it should also be noted that the higher the velocity, then the higher the problematic of dynamic pressure gradients. In fact, for a fluid, the notion of a resistance is linked not only to its viscosity, but also to the flow dynamics. And this was also implicitly included in the Gould equation. Because if we go back to the Gould equation that was mentioned at the beginning, the pressure gradient is expressed as a viscous term proportional to Q and a kinetic term proportional to Q squared. Now, if you factor, using the same hydraulic model, if you factor Q, then you realize that you can define a resistance to the stenosis itself, which is dependent on the flow. So this was already taken into account in the Gould equation, the dependence of the flow on the hydraulic resistance of the stenosis itself. So what about IFR, instant flow reserve? So based on all that I've said, in general, the flow velocity is higher, and for the IFR as a technique, and the pressure is lower. And then based on what I've just said, principle, this results in lower microvascular resistance, which is good. But in our case, as I mentioned for a biomechanicist, the problem is not the microvascular resistance, but it's PD. So in the case of IFR, a biomechanicist would be a bit more nervous for PD because it is associated with higher velocities, and so would be associated with more dynamic pressure gradient effects. So meaning that PD would be potentially a bit more sensitive to measure in the post-stenotic region in the case of IFR. So, in summary, for a biomechanicist, the measurement of FFR we need to realize when we do for a mechanicist, when we perform the computation of FFR, we need to realize that the transition from a flow-based measurement to a pressure-based measurement requires an hydraulic model. This is a non-trivial thing to do. To use an hydraulic model is a strong simplification of fluid mechanics. Neglecting venous pressure may not always be a precise thing to do. The equality of the myocardial bed resistances is an assumption, but seems to be a good, acceptable one. The measure of distal pressure PD can be potentially problematic for several reasons, in particular, of course, all the dynamic pressure effects. And from a biofluid point of view, the measurement of PD could be a bit more, let's say, problematic with IFR, given the higher velocities and the associated higher dynamic pressure effects. Thank you very much. I'm not hearing the...
Rosaire, tu m'entends?
Oui, oui.
Okay. So I just, is there any question? Because Rosaire will have to obviously get some sleep afterwards. I have a practical question, Rosaire, since obviously it's a tough presentation anyhow for cardiologists in the morning. But
I'm sorry.
No, it's okay. I mean, we knew it. I just have a practical question in terms of, and it's very important we understand the different mindset of doing physiology as compared to just using a tool and pushing on a button to have a value. I think that we have to pay some effort to understand what is beyond this. But watching your presentation, I was just wondering, of course, there is always a discussion among the positioning of the distal pressure wire, which obviously is important. But on the other hand, depending of the size of the guiding catheter you're going to put on the proximal part, I would say that it's quite obvious from your perspective that if you create some obstruction on the proximal part by the guiding catheter or the diagnostic catheter, and so you will reduce the proximal pressure, and you're going to just confuse everything. Are you okay with that, Rosaire?
No. I think I completely agree with what you just said. That it is obvious, and we can easily quantify from a biomechanics point of view the effect of obstruction, like even guide wires. But the catheter would obviously be a significant impact. In my view, it needs to be assessed. But I think, in my view, it would be a significant impact. It cannot. I don't think it can be simply just neglected
Okay.
Rosaire, it's Colin Berry speaking. Thank you for a very eloquent presentation. It was very educational. So I have a question about the influence of venous pressure on hyperemic indices. There's a literature on that, as compared to resting indices. And given that resistance is not minimized under resting conditions, I wonder if variation in venous pressure might have a greater contribution to the variability that we know is associated with resting metrics as compared to hyperemic metrics.
Yes, I fully agree with this statement. I was just before the presentation, I was using a back of envelope doing ratios. I did not mention it, but no, what you say is, I mean, I totally agree. I did the ratios. I did not want to, because they were, I mean, they're convincing. I mean, it's not difficult to actually take numbers and realize that, you know, but no, I agree. As I said, when I mentioned that I find the current assumption of the canceling of the myocardial bed resistance makes sense, it is in comparison with the other hypotheses. The other assumption and hypotheses are more, in my opinion, probably have more impact than this notion of ratio. But it's my personal understanding.
Thank you very much.
Yeah.
Okay, Jose. So again, we are very appreciative of your time, and now I think it's time for you to go to bed. And,
yeah, maybe.
We will continue with Dr. Johnson, who will now go to the practicalities, very important in the cath lab.
Okay.
Thank you, Jose. Bye-bye.
Okay, bye-bye.
All right, good morning, everybody. It's a real pleasure to be here. Thank you for the invitation. These are my disclosures, nothing that specifically relates to what I talk about. What I'm going to be doing is, as was mentioned, a practical introduction to how you do these kind of FFR measurements. And actually, Rosaire and I didn't plan this 100%, but it's interesting to see how much crosstalk there is between some of the biomechanical components that he brought up and how that impacts our ability to do these measurements. After all, you can see that the guidelines give FFR a very strong recommendation, but they don't tell you how exactly to do it. So let's go through that step by step, and then we'll also answer some very practical questions that come up. So the first step is almost so obvious that it doesn't need mentioning, but just like any intracoronary procedure, you need to get all the equipment ready, you need to anticoagulate the patient, you need to give IC nitroglycerin. There's this wonderful YouTube video. There's lots of stuff on YouTube, but this one's fun. You can go watch Mort Kern show us how to do an FFR. And so I'm going to show a couple slides taken from his excellent video. The first step, once you're handed the wire, is that you need to flush it. And the reason you need to flush it is both to lubricate the wire and also to get rid of any bubbles that might adhere to the sensor. Those can interfere with the pressure measurements. The second step, and you'll see what he's done here, is he's put the wire right next to his fluid-filled catheter system. And the reason that he's done that is because you need to zero things, and those need to be at the same level. And the concept here is that you need to have the pressure sensors to have the same zero. 1 second, let me see if I can find. Yeah. So you can see here in green, that's the patient. Red is the heart. The little orange dot is where the catheter sits in the coronary artery. And if you need to have the pressure transducer at a different level, what that does will introduce some amount of difference between the two zeros. And so that's the important reason to have them right next to each other when you do these zeros, just as you do for any other pressure measurement. It varies a little bit among the different consoles as to how that happens, just programmatically, but that's the concept behind zeroing. After you zero, you need to put the wire into the Y connector, and then you need to shape the tip. These have a soft radio opaque coronary tip, and so you need to make that into whatever shape in order to instrument the vessel. And then you put the wire into the catheter and you put it out the tip. So here you want the pressure sensor to be just outside the guiding, and at that point the signal that you get from the catheter should be equal to the signal that you get from the wire, and that's called equalization. You can see here that in some cases a small amount of pressure difference may exist between those two, and when you hit the equalize button they become equal. Now, Mort is pointing his finger to an important issue on this thing. What do you do with the needle introducer? Do you have it in or do you have it out? it's important for you in your own cath labs to understand what the influence is of the equipment that you use. So for example, here on the left-hand side, you can see a very small needle introducer, and when it's put in, it only introduces a few millimeters of mercury difference, whereas on the right-hand side, a larger needle introducer can introduce a higher pressure gradient, maybe about 10 millimeters or so of pressure loss. So you need to figure out in your own cath lab what the effect is of the needle introducers that you use. If it's only a millimeter of mercury or two, you can neglect that and leave it in for the whole case. My tendency in my own practice is to take out the needle introducer all the time because ours tend to introduce a larger amount of pressure loss. So once you understand it, then you can make the same consistent decision on where you put the needle. And after you do that, you hit the equalize button. By equalize, we mean that we want to have identical PA and PD waveforms so that the ratio is 1. Some of the manufacturers call this normalization, but the concept is that you want the catheter and the wire to give you the same value. So you have the same 0, you have the same pressure when you're in the coronary artery. Those are the components of getting the wire ready. Now you need to wire the vessel. And really when we say wire the vessel, what we mean is to take and put the pressure sensor distally into the vessel. And so you need to understand where is the pressure sensor located along the wire that you're given. Mort is pointing here. In this particular case, they use one of the Volcano Phillips systems. He's pointing to where this is. It's 3 centimeters offset from the tip. Volcano makes a different kind of wire, Doppler wire that has both a pressure and a Doppler crystal on it. In that case, some of the models have it where they're both located at the end. The Opson's product, for example, it's 3.5 centimeters from the tip. Boston's 3, St. Jude is 3. So you just need to understand for the pressure wire that you're using, where is the sensor located? And really what we're talking about is placing the sensor distal into the coronary artery. Now this was an issue that Rosaire brought up, and I just want to highlight it again too. You want to place the sensor distal enough into the coronary artery. Here's an example on the left-hand side where they're interrogating this LAD lesion, and this pressure sensor is too close, and I'll show you what that means specifically in a moment, whereas you really want to be placing your pressure sensor far enough from the lesion in order to evaluate the entire artery. There are 2 separate competing components that can happen. This is something, a very nice study from Olivier Bertrand's group, where they did FFR measurements proximally in the vessel and then repeated them distally in the vessel. And what you'll see is when you put the pressure sensor more distally, the FFR value is lower, and that's due to 2 reasons. One is diffuse disease along the vessel, and the second is, in some cases, a second or tandem stenosis. And so really when you interrogate the vessel, you want to first understand all of those effects together, and so that's the argument for placing it distally. As Rosaire mentioned, and this is the same figure that he was talking about, you can have pressure recovery as you come out of the stenosis. That is, there can be a small amount of pressure rise, just as we see when we make valvular pressure gradient measurements. And it's important to understand that the myocardium sees the recovered pressure. That's what drives flow in the muscle. So to just think about it practically, you want to place your sensor far enough away from the stenosis to avoid both of those effects. You also want to place your sensor in a location that's stable. So here, for example, is in red coronary aortic pressure signal, and in green is the coronary pressure signal, and you can see that every time systole comes along, there's this enormous pressure spike. And the reason that that happens is that pressure sensor is being knocked against the wall of the blood vessel. That can either be due to vessel motion, or in some cases a bend in the coronary artery that bonks the sensor. And so what you want to do is to either push forward or pull back a little bit to eliminate this artifact, which we call whip artifact. The second issue to look at before you start making your measurements is to make sure there's no distortion in your pressure signals. So for example, here in green is the coronary signal. Very nice. You can see a very beautiful dichrotic notch. But look in red at what's happened to the aortic pressure tracing. In this case, both the systolic as well as diastolic peaks have been smushed in, and that is due usually to a bubble in the system or inadequate flushing of the guiding catheter, especially if you're using a smaller guide catheter. So just make sure before you start that you've gotten rid of all of these and have nice looking pressure signals. The following step is hyperemia, and Zolt's going to talk to us about this in more detail, but I'll just say briefly that there are lots of options. I've listed here kind of historically their development. Obviously, the real workhorse for the past several decades has been adenosine, but the important thing is that there are many options for you to choose from, and what you need to do is to pick one based on your local availability, local price, and local practice that you develop. My particular style has been to use IV adenosine, but whichever one you choose, you've got to kiss Keep it simple and standardized. Choose one or maybe two methods of hyperemia for your lab and use them all the time in the same way. My style for using IV adenosine, and this is something that I set up in Chicago, this is the Eindhoven setup, we use this now in Houston, is we have adenosine pre-mixed, it's ready in the lab, the nurses can just grab it easily, and the infusion pump is attached to the FFR console so that it's all there in one place, ready to go, simple and standardized. As Mort says in this nice video, you turn on the adenosine, you put your hands in the air, and you step away from the table. It's really a very plug-and-play option that gives you the ability to make rapid and nice hyperemic curves. It's important, though, that once you finish making your hyperemic measurement, that you're a little thoughtful about looking at where the console decided to pick FFR. Because often what the console will do is simply pick the lowest value, and as you can see here, that lowest value may correspond to a part of the tracing that is artifact. In this case, the aortic pressure was open because they were giving intracoronary adenosine. The machines aren't that smart. You need to be smarter as the doc. You need to just look at the machine and make sure that it's giving you a valid portion of the tracing. You also need to look at the pressure signals and make sure there hasn't been drift. On the left-hand side is red, the aorta, blue, the coronary. You can see that these two curves are identical. The coronary artery still has this dicrotic notch. This type of simple translocation, you might say, is indicative of drift, because when you have a real pressure gradient, as you'll see on the right-hand side, the coronary pressure loses the dicrotic notch, and you also have this almost ventricularization that occurs during diastole. Here's a case example. This is the lesion we were interrogating in the distal left main going into the ostial LAD, as well as the second lesion in the mid-LAD. You can see where we place the FFR wire downstream of everything. Here's the pressure tracings. We start off with a rest PDP of 9.4. We turn on IV adenosine, and we quickly see the net effect of both the left main and the LAD with an FFR of 0.73. The next piece is to do a pullback curve. And you can see here, I gradually move the pressure sensor back along the mid-LAD, showing gradual pressure loss. Then there's a focal jump over the transition into the left main, and we're back in the guiding catheter. And this shows you the three important components to a pullback curve. The first is to look for focal pressure jumps, focal being 10 millimeters of mercury or more over a short anatomic distance within the artery. One of the advantages to having the radiopaque portion is as you're pulling back, you can push forward a little bit, and that allows you to really localize where that pressure gradient occurs in the coronary artery. The second component, and this is what you saw in that mid-LAD, is just the two pressures coming back gradually towards each other, and that's due to diffuse atherosclerosis, and these are some examples here. And then when you get back to the guiding catheter, you need to understand if there was any drift. You started off with a PDPA of 1. You'd like to get back to a PDPA of 1, as shown here on the right-hand side. However, in some cases, you'll see that the PDPA isn't 1 anymore. Now, we've been getting more quantitative data about drift, and this is some work that we've been doing in contrast, where we systematically acquired over 600 pullbacks, and you can see that on average, there's no drift, right? The most common value here is 1, and you can see all the averages over here, but it's a distribution, right? There's, like everything in life, there's a biologic variability. About half of the time, you're going to be plus or minus 0.01, about 80% of the time within 3 units of 1, and 90% of the time or greater within 5. Now, this contrast study was done a few years ago using the St. Jude product. Olivier Bertrand last year presented some work using the first generation Opson's wire from the O2 study and actually found very similar results. You can see on average very little drift with a standard deviation of about plus or minus 0.03, and that's essentially the same value that we get in contrast. Now, realize that drift can be due to any part of the component. So it can be due to the pressure wire, it can be due to the fluid-filled guiding catheter, or it can be due to the piezoelectric pressure transducer system that you use for the fluid-filled catheter. So it's not always the wire's fault, but what I think we're going to see over the next several years is a lot more attention to drift. So those are the steps that I went through. I won't read them again, but that's just a systematic way that what you should be doing every time you make an FFR measurement in order to get high-quality data. So now I'd like to go through a couple common questions. Again, it's interesting how much overlap there is with some of the issues that Rosaire was bringing up in his discussion. Question that commonly comes up is, do I need to measure the right atrial pressure? And as he mentioned in the theoretical derivation, you can see that the venous pressure is part of the equations. But even back then in the original manuscript, they noticed that if the venous pressure was not elevated, then it could be neglected because its influence was quite minimal. And that's moved us from FFR myocardium to just plain old simple FFR. the ratio of pressure is simplified for clinical practice, but how valid is that simplification? I think it's a good question. This is the best data on the topic. It's a study of over 1,600 lesions from over 1,200 patients from the ULST group. You can see the distribution of right atrial pressures in their cohort. And again, these were patients who were undergoing right heart catheterization because there was a suspicion of elevated right heart pressure. So I'd say, if anything, this is probably skewing the distribution towards higher right atrial pressures than you would see in standard practice. You can see here they compared the FFR myocardium, that includes the right atrial pressure, on the y-axis to just the standard pressure ratio FFR on the x-axis. An extremely linear relationship. You can see the high R-squared values with an average difference between the two of 0.02, so a very small difference. And the most important thing clinically is shown here on the right is that nobody crossed over the gray zone. Sure, the values may change by 1 or 2 small little units, but you're never going to change from a clearly positive to a clearly negative result or vice versa, and that means that you rarely, if ever, need to measure right atrial pressure. So what should we do for picking the FFR value when it fluctuates? After all, when it's stable, it's quite easy. So take a look at this pressure tracing on the left-hand side. Here's the rest, transitions with IV adenosine, stable measurement, easy to pick where the FFR is. But what do you do with something like the one on the right-hand side, where you turn on the adenosine, it goes down, it goes up, it goes back down again? Where are you supposed to pick FFR in that case? Well, this is something that we looked at in the Verify study, and what we saw was that about 60% of the time you get this classic appearance: rest, transition, hyperemia. There it's easy. But what that means is that 40% of the time you can see some degree of oscillation, and I've shown some examples here from Verify. The exact width and height and how frequent these things oscillate back and forth varies. But the most important thing clinically is to make it easy, and that's that if you always pick the lowest value, that's going to be an extremely repeatable FFR measurement. And I've shown you here when we did this twice, that is, they did 2 FFR measurements. As long as you pick the lowest value, no matter all the bumps and humps, that gave you the repeatable FFR. Can I use the FFR wire for PCI? The answer is yes. The exact steps of how you disconnect the FFR wire, pull it off, and then reconnect it afterwards vary by manufacturer, but basically it's some kind of disconnect maneuver and then pulling out the wire. And exactly what the console shows you, or the pressure transmitter, varies by manufacturer. The advantages, of course, is that you use one wire for both your FFR and your PCI, so you save time and you save money. The important thing after you reconnect is to wait and make sure you have a stable signal, and also check for drift at the end of the case, since the wire has been manipulated more during the PCI itself. Reconnecting after PCI allows you to do 2 things. It allows you to reassess, make another FFR measurement for a second lesion. So in cases of tandem or serial stenoses, or you might have missed one that's not so anatomically obvious, you might uncover the need for a therapeutic maneuver of doing extra PCI. Or simply measuring post-PCI FFR has a prognostic value. There's been a lot of emerging data about that, and actually Olivier Bertrand is going to talk to us about that later on today. Sometimes you can see an FFR greater than 1, and you may ask, what does that mean? Because it's a little bit confusing. We thought that the most normal value was 1. How could you ever be more normal than normal? Here, for example, is a right coronary artery that I was interrogating as part of a research study. It was a completely normal vessel, as you can see, and I put the pressure sensor down here in the PDA. I started off with a PDPA value of 1.02. So you might say, okay, you've got some drift in your system. That's why you're greater than 1. So I gave IV adenosine. The FFR was 9.7. I did a pullback, and the pullback was exactly 1.00. That is, there was no drift. So how can you have a pressure higher downstream than upstream, but yet have no drift? And the reason that this happens is the so-called hydrostatic effect. That is, we equalize the pressure systems at one level, say in the anterior surface of the myocardium, and then, for example, in the PDA, we're on the inferior wall of the heart. And there's a fluid-filled column between those two, right? Say the LV is about 5 centimeters in diameter. If you do the math, you can figure out that this hydrostatic effect can sometimes cause the pressure to be higher by a few millimeters of mercury. So the final point, and this was something, again, that was brought up, was this influence of the guiding catheter on the measurements that we make. Can the guide catheter interfere? Well, you can see the relative percent area stenosis if you have a 4 millimeter vessel, say something like the left main, with a 5, 6, 7 French system, depending on how much osteal stenosis there is. And you can see as you get down here towards the lower right that the guiding catheter indeed can have an influence, and that's obviously what we see clinically when we're in the lab, when we engage the coronary artery and the curve ventricularizes. But sometimes it can be more subtle than that. It might not be frank ventricularization. Here, for example, is a case you can look at the pressure tracing in the lower left where the guiding catheter was engaged, in the lower right where it was disengaged. Both of these aortic signals look quite normal. There's no obvious ventricularization, but you can see a slight difference in the two FFR values, implying that even here there was some subtle degree of obstruction. Now, in some cases, the guide catheter can really migrate in and cause obvious ventricularization. Here was a case where they were interrogating this mid-LAD lesion. At baseline, everything looked normal, but during hyperemia, you can see ventricularization of the aortic curve, implying that the guide catheter got sucked in, giving a falsely damped FFR value of 9.0, and when they repeated it with better attention to guiding catheter position, the true FFR value is 0.73. So it can make quite a significant difference clinically in terms of making the right decision. What about side holes? So we use side holes when there's some ventricular when there's ventricularization due to an osteostenosis, but realize that side holes have two competing things that they do. One is they let more flow into the guiding catheter. That's the whole point, is in order to perfuse the coronary artery better. But that extra flow can create a gradient along the catheter itself. So here's a case where we're measuring the femoral artery pressure in green, the pressure inside the guiding catheter right at the level of the side holes in red, and then the pressure at the end of the guiding catheter in purple. And you can see that there's a gradient along the guiding catheter due to the extra flow. So side holes make things complex, and so the simple message then is to disengage. Here's a very nice study that brought home this point. It was just published last month. They took 26 lesions and they made 4 FFR measurements: guide catheter engaged, disengaged, guide catheter with or without side holes. And the basic message is over here on the right-hand side, and that's that as long as your guiding catheter is disengaged, it doesn't matter if you have side holes or not. The challenge is if your guide catheter is engaged, then it can make a difference whether or not there are side holes. Again, if you look at the numbers, it's a small absolute difference, but it's statistically significant, and that's why the basic message is to disengage. So to go through answers to these common questions, we rarely, if ever, need to measure right atrial pressures. If FFR fluctuates, we need to take the lowest value where the tracings are valid. You can use your FFR wire for PCI, and there are a lot of advantages to that. Due to hydrostatic effects, occasionally you can see FFR values greater than 1, and because of this issue of guide catheter interference, we need to make sure we disengage. And if you follow all the steps that I've talked about, you're really going to be using first-class techniques for using this Class 1 tool from the ESC. Thank you.
So we'll move to the next speaker now, and of course, I mean, questions and answers are very important. I will emphasize we have been very privileged to have probably the most truly guru, if I may say, about FFR and IFR. So it's a unique opportunity for all of us to ask questions, and we will keep like 15 minutes questions at the end of this session. So now we have heard so far about the concept of basic fluid mechanics, going through FFR measurements, and then in the cathlab about all the pitfalls and the details, and you know the devil is in the details. And now we're going to move now to the next one, the IFR, and Professor Sen. Thank you.
First of all, thank you very much for inviting me to this great meeting, and I hope that we'll have a lot of discussion throughout the course today. I'm certainly looking forward to it. I suppose this is the first... Okay, brilliant. So I've probably got the honour of doing the first possibly controversial talk of the day, but I'm going to try and keep it as low in terms of controversy as possible. Why are we talking about IFR and PDPA? We just had a great discussion about FFR, and probably one of the best talks I've heard about the pitfalls of measuring FFR, and I think that really needs to be highlighted with regards to interventional cardiology and its adoption around the world. But we're talking about these indices for several reasons that I'll discuss over the next few minutes, and then I'll try and ascertain as a community what we're looking for from these new indices, some facts about IFR, and what we have to do from the IFR camp to persuade you as practicing interventional cardiologists that it's a viable option for you in the clinical arena. So we're talking about physiology today because our patients want to know, are we putting in stents appropriately? Are we managing them properly? Also, the insurance companies want to know, and our colleagues want to know. And this is why, really, I think physiology is going to be intricate to the armamentarium of the practicing interventional cardiologist in 2016. Fractional flow reserve, developed in the early 1990s, really has set the benchmark for any of the new indices coming through the system, but it was in the 1990s. So we've had about 30 years now, at least over 20 years of fantastic evidence, meticulously validated in several cohorts of different subset of patients that we see in clinical practice. And in my view, quite rightly so, is a Class 1A indication in European guidelines to guide revascularizations in patients with moderate stenoses. Who here uses FFR routinely in clinical practice? Okay, I can tell you that we're not even halfway in the room. Okay, and that's reflective of general practice around the world. Okay, so this is slightly outdated. I would expect that hopefully with the education that the FFR and the FFR, IFR groups, PDPA groups and the companies have been doing over the last 5 years, you can add probably 2 or 3% onto the percentage adoption here that I highlight around the world. But it's extremely small. We've got to go back to where we came from. And this is where, really, the time that FFR was developed, this is the kind of fidelity of the technology that they had at that time, and this is what they had. And credit to Nico Pills, Bernard de Bruyn, Lance Gould, they made a great effort in developing FFR, pushing it forward into the clinical arena as we have it today. So can we make an analogy of FFR to what we all have probably in our pockets sitting here, or maybe even using at this point, which is slightly upsetting? Yes, we can. This is the mobile phone back in the 1990s. I think we can all probably remember that. And this is the phones that we have today. And the first thing that we want to ask with any phone is, can I make a phone call with it? That's the first thing. And then you're choosing your phones or any new technology because it has added benefit or added convenience to you. If we take that analogy back, this is the kind of pressure tracing that FFR was developed on, and this is the kind of pressure tracing that IFR was developed on. It's got nothing to do with us, it's just got to do with progression of technology and improvement of science. So I think as interventional cardiologists over the last 20 years, we've become more discerning with regards to the type of stent we want, the characteristics of that stent, for example. It has to be able to be delivered in tortuous vessels. It has to be have good radial strength, for example. We're getting more discerning with regards to our antiplatelet therapy, moving from warfarin initially to aspirin, to clopidogrel, to prasugrel, to ticagrelor. I think we'll get, over the next few years, a bit more discerning about our physiological index as well. Of course, our physiological index has to tell us that we need to, the vessel is in trouble, whether or not the vessel is ischemic, but it also will want an index that is able to give us an answer rapidly, be applicable to the majority of the patients that we see on our cathlab table, and perhaps be useful in indications that the current technology is unable to answer, and I'll go into that in a bit more detail. The first question is, can we make a phone call with our new technology? Can IFR identify ischemia? I think over the last 6 years, we've demonstrated quite categorically it can. Whenever you take a patient and measure IFR and FFR and compare it to another index of stenosis severity, there is absolutely no difference in its ability to detect ischemia. And I suppose the largest independent study that has done this is using PET, is this study from Bonconcu, which, as you can see here, demonstrates no added advantage in adding hyperemia to your physiological assessment. So, we can make the phone call. What else can we do? Can we surf the internet? I think there are several aspects within FFR that over the last few years we have really become more aware of. I think with the first study, the FAME study, the FAME2 study, we're comfortable in using fractional flow reserve in patients with single vessel intermediate stenoses and even in patients with multi-vessel disease. I think we're less comfortable in using FFR in patients with serial lesions, with left main stem disease. I'm sure Professor Berry will talk to us about the difficulties in using it in acute coronary syndrome and perhaps the potential of using it in acute coronary syndrome. And then obviously there is always a limiting factor of having to have a drug available to you to produce hyperemia and the variable effects of that drug in each patient. But what about diffuse and tandem disease? This is increasingly the kind of patient that I'm seeing in my cath lab in London. Gone are the days of the type A lesion in a single vessel. They're more likely to have tandem disease or diffuse disease. And can FFR be reliably used in these situations? Well, this is an example of an actual patient that was recruited to the Illumine 1 study, and I borrowed very kindly from Carlo De Mario. So what he did in this study is he passed the pressure wide distally, infused adenosine, and got an FFR of 0.74. He then put the pressure sensor in between the two stenoses. I think we can all appreciate there's an intermediate stenosis here and an intermediate stenosis here. He measured the FFR again and got an FFR of 0.91. He then popped the pressure wire proximally and demonstrated that the FFR there was 0.98. Which vessel would we all target here? Which lesion? Distal, proximal? Who would go for the distal lesion? Yeah, I think so. I think it's reasonable. It's got the biggest gradient. If we did go to the distal lesion, do we think our job is done? Stent the distal lesion. Would anyone check the FFR afterwards? Yes? Why would you check it afterwards? Neil's saying yes. Exactly, yeah. So for maximal hyperemia to be achieved over the proximal vessel, the distal lesion is impeding that. So once you've treated the distal lesion, you're duty-bound to go in to make a proper assessment of that proximal lesion. So what does he do? He stents with a beautiful result of the distal lesion, remeasures and gets an FFR of 0.69. So the proximal vessel suddenly becomes a problem here, and he's duty-bound to stent that, which he does so and gets an excellent final result. Now this required 4 FFR runs. The adenosine syringes needed to be changed. 2 pressure wires were used, and it added approximately half an hour more to the procedure. Was FFR useful here? I think it was. Could we refine this process and make it easier for people to use? I think we can. Should we be doing that? Probably to promote adoption. And this is exactly what Professor Curzon relates to. In the context of a tandem lesion, the 2 lesions interact such that FFR cannot be used to delineate the significance of any one of those lesions. So you are duty-bound to do multiple FFR runs. So you stent the distal lesion, and that results in a change in hyperemic flow and a change in your FFR values, which are completely unpredictable. Can a resting index like IFR here help? Well, let's take this patient. This is a patient of ours that came into the cath lab. This is very indicative of the kind of patients that we're seeing increasingly in the UK, for sure. An 85-year-old, so they're older, comes in with unstable angina, with diffuse long LAD disease. Now, I don't need to tell you that this LAD is ischemic. Who here would use a pressure wire in this patient? No one. Good, excellent. What I'm going to show you is how I would use a pressure wire in this patient, because I don't want to give this patient 80 millimeters of stent. I want to identify the stenosis that's most likely to be causing the problem and get out. Okay. This is actually a patient that we had in our cath lab. So this is a case where the operator has passed the pressure wire distally and he's pressed the IFR button. He's got an IFR value of 0.72. Anything below 0.90 is indicative of an FFR of less than or equal to 0.80. You can see here in real time that we're able to identify the appropriate segment of the wave-free period to ensure that we're making accurate measurements. The next question is, everyone here knew that that vessel was ischemic. The question is, which one of those stenoses do I treat them first? And so what the operator here has done is closed the O-ring and is literally pulling back the pressure wire as you would pull back an IVUS catheter. So about 1 millimeter a second. And what is being plotted in the blue line, which hopefully is visible, is an IFR at each point in the vessel. Now, I've put the vessel in the top right-hand corner of the screen to demonstrate or remind you of what kind of vessel it was. And you can see we're already 2/3 of the way up the vessel without any significant pressure drop. And we can see that all the pressure losses are actually due to the proximal end of that vessel. Now, you could tell me that FFR will give you exactly the same information, and I think it would on an individualized pullback. But the question is, using this pullback, can I predict what the post-procedure IFR value is? And using the very simple facts of resting coronary physiology, we can do that. We can model the post-IFR gradient gradient and predict it as a value of 0.92 by taking out simply the area of the largest pressure drop. And this is what we did in this patient. So the operator here just focally stented the proximal end of that vessel. And you can just see what the final result is. Okay. This is a live case. We asked him to remeasure the IFR at the end of the procedure. And what you can see here is reconnected on. He's done the procedure, as Neil said, on the pressure wire. These pressure wires have developed remarkably over the last few years, and we've got an RF value of 0.92. Now, you might say this is remarkably convenient. This is probably just the only case that this has ever been demonstrated on. In fact, we've done this systematically in lesions whereby we have predicted what the post-IFR value will be and then demonstrate it, and this has been published in JACC Intervention 2 years ago now. So I think the traditional role of physiology to tell us to stent or not stent will remain, but I think we'll ask more of our physiological index. We'll want to know, sure, is there ischemia? But we'll want to know, can we discriminate the most significant lesion easily? Set a target for post-PCI threshold and a rapid assessment post-PCI. Ideally, we'd like to know if we can target a lesion and know exactly what the IFR value will be before we've even ballooned it or stented it. The way forward, in my opinion, would be to co-register these images onto the angiogram, and hopefully during one of the live cases today from our centre, you'll be able to see how we are working to co-register this physiological data onto the angiogram to provide a heat map for interventional cardiologists to use to guide their PCI. So let's talk a little bit about PDPA. I'm not here to argue one case or the other, but I am here to say that not all indices are the same. So certainly IFR is not the same as FFR, and PDPA is not the same as IFR. That discussion, I suspect, could fill a whole day, and certainly some of us in this room have done that already. But I'd like to show you another example of a patient of mine with tandem lesions in. Hopefully this is transmitting nicely. Who thinks number 1 is the most significant lesion? Number 2? Number 3? So the majority are probably going to take the patient off the table because no one put their hand up. What we can do is do a pullback, as you've seen before, and we can do that with PDPA. And this is the kind of pullback you see. So you can see that number 2, you can get a hint of a gradient there. Number 1, very little gradient. And number 3, very little gradient. And in fact, angiographically, I think number 3 is probably the area that we'd go for. And this is an advantage of using physiology. Okay. If we do an IFR pullback, we can see that our spatial resolution is improved. Okay. And this is purely because the flow over this period of time is higher than it is with PDPA. And it's very similar to that achieved by FFR. The advantage of IFR being we don't need to infuse an agent, and we can predict what the post-PCI IFR value will be. A lot has been discussed in the literature with regards to IFR and PDPA. When you look at them on a Bland-Ullmann plot, which is probably the most scientific way of looking at it, there is a clear difference. But if you look at mismatch in large numbers of patients, so almost 1,000 vessels here, and we compare the categorization agreement between IFR and FFR, we're getting about, IFR and PDPA, we're getting about a 15% mismatch. We can talk about mismatch, we can talk about variability, biological variability in cut points. Some of us have done that for years, but it's not going to change what you do when you go back to your cath lab tomorrow. What's going to give you confidence with IFR? Well, are other people using IFR? Yes, they are. We don't have any outcome data for IFR, but it's used in over 3,500 cath labs around the world. And hopefully in my next discussion, I'll demonstrate to you how it's been used in some of the largest randomized trials to date. In my opinion, for me to use IFR alone, I need hard outcome data to show my patients, show my colleagues, and show my healthcare system that I'm doing the right thing. I'm glad to report that this data is on its way. In combination with our Swedish colleagues, there are 2 randomized studies comparing IFR-driven revascularization to FFR-driven revascularization. The defined FLARE study will recruit 2,500 patients and has finished recruiting, and will shortly be reporting its 1-year outcome data, and we'll be following up those patients for 5 years. And the Sweetheart study, exactly the same protocol, will recruit 2,000 patients. So hopefully in the next 12 months, we'll have data looking at IFR outcomes, hard outcomes in terms of MACE in about 4,000 patients. Remember, the reason why we're discussing this is because we have clear outcome data from FFR to show that a physiological approach is better than angiography alone, and this is what we're dealing with in terms of adoption. Now, when I got the title of the talk, I looked up hype on the internet and Google, and actually there is a thing called the hype cycle, which I didn't know about, which quite aptly is applicable to new technologies. And I think as part of the physiology community, we're going through the hype cycle of physiological guided PCI. There's a technology trigger and innovation, and I think that's fractional flow reserve. I think with the data from DEFER, FAME2, we were extremely excited and hopeful that adoption would take place and everybody would be incorporating FFR into their clinical practice. Unfortunately, from the map that I just showed you, this doesn't seem to be the case. And there's several reasons, ranging from education to the ability of cost, paying for the equipment, to the ability of time in the cath lab, to the availability of hyperemic agents. I think we're on the slope of enlightenment, and perhaps with the data that we've got so far, we can conclude that hyperemia is no longer necessary, and that should hopefully improve adoption of this technology. And hopefully over the next few years we'll go to the plateau of productivity with combined efforts to improve adoption of physiology within our cath labs. In summary, ladies and gentlemen, innovation triggers progression, and we need to progress as interventional cardiologists for our patients. We need to challenge existing beliefs and concepts in order to progress, and I think that's where PDPA, IFR, contrast FFR come into play. The data suggests that hyperemia is no longer required to assess a stenosis with regards to ischemia, and newer indices may allow us to use physiology in new patient subsets and promote adoption. Thank you very much.
I believe there will be many questions regarding your talk, but maybe we're going to keep it for the last after the last talk. Otherwise, we're going to be late for sure. So maybe Zolt, you're going to continue, and then we'll keep open the session with questions.
Thank you very much, ladies and gentlemen. It's a pleasure to give this talk, and it's a tough time actually for me to talk about vasodilators after this eloquent talk. Can I have my slides, please? So the talk that I have to present is how to achieve maximal coronary vasodilatation. But of course, after this talk, I have to ask myself the question, why bother to achieve maximal coronary vasodilatation? And there are three things I would like to share with you. Fractional flow reserve is a flow metric. And its measurement, if you go back to the first lecture that we heard today, mandates elimination of autoregulation. So in other words, in practical terms, we need to realize that the full diagnostic power of FFR and coronary physiology, for that matter, can only be achieved during maximal coronary vasodilatation. If we have insufficient hyperemia, we underestimate the gradient, and therefore we overestimate FFR and underestimate the lesion severity. FFR is like putting the plane in a wind tunnel, and I think vasodilatation is what gives the wind itself. Otherwise, it's a wind tunnel without wind. This concept of pyramid of diagnostic accuracy has been adopted by many, and these slides come from Nico Pels, but also Nils Johnson used them in his talks. And we have to realize that if we do a diagnostic test like flipping a coin, we have a 50% chance of getting things right. Of course, we know that we have better things in coronary diagnostics, and of course coronary angiography was the first to come. But many papers, and this one comes from the Oz group, and the first author is an ex-fellow of mine, Gabor Tóth, and he presented over 4,000 angiograms. That diagnostic accuracy of coronary angiography is no more than 65%, no matter whether you talk about left main, LAD, circumflex, or right coronary artery. There's not much difference there. So Soames, when he did the first coronary angiogram, and many people afterwards, of course, had this beautiful imaging tool, which we of course need all. It's a roadmap for all of us, but it has no more accuracy than 65%. I read some other papers, different from Dr. Sen's, and these papers tell me that resting indices, no matter whether you're talking about PDPA ratios, IFR, or others, have no more accuracy than 80%, being in Resolve, Advice 2, or Verify 2. Actually, it's not quite new, because if you go back to the literature and check out what Anders Grünzig did in all his very first cases and all his presentations, he used pressure gradient as a surrogate of clinical success of his cases. But he realized that the resting gradient is far from enough, but unfortunately it's all I have now. Of course, it was the problem of the technique as well, because he measured the pressure gradient across the region using the same balloon, which itself created some gradient naturally. And also he did not realize the importance of hyperemia. So putting this all in perspective in the context of the pyramid of diagnostic accuracy, I think we arrive at some 80% of rest physiology as compared to the holy grail of 100% certainty and accuracy, which could be the potential gold standard. And in the following slides, I would like to convince you that hyperemia will give you 95+% diagnostic accuracy, close to the Holy Grail. And we have to realize, and this is why I really like this concept of pyramid of diagnostic accuracy, that the more hyperemia we have, the more accuracy we have also. This slide comes from Niels Johnson, and it's an almost complete list of vasodilatators that we can use. And of course, I'm not to touch contrast medium. He will give a beautiful talk on that in the afternoon. But there are very many drugs on board, starting from dipyridamole and so forth. And I would like to highlight some, like papaverine, adenosine, and regadenoson. Papaverine was the first to come. It's a very cheap drug. It's easy to administer. It reaches peak hyperemia in about half a minute, and it's quite long-lasting, about a minute, allowing pullback recording, and also microcirculation can be interrogated during this. The problem with papaverine is that it causes T-wave abnormalities and seldom torsade-point ventricular tachycardia, which is a problem. I mean, we are doing a diagnostic test. We really don't want to kill the patient on the table. So this is why it's by now mostly abandoned. It was realized, though, that especially a problem in patients with hypokalemia or patients on already QT prolonging drugs. And we realized that no more than 3 doses should be used. Otherwise, you might have this kind of pressure tracing, which of course is lethal if untreated. The dosage used to be 10 to 15 milligrams in the right and 12 to 20 in the left coronary artery. But it's very cheap, very practical. If you don't have anything else as a last resort, of course, it can be used. But adenosine came over in the early 90s at the start of coronary physiology, basically. And we have to realize that adenosine has a number of different receptors, and it's basically the 2A receptors that we are aiming at, which causes coronary vasodilatation. And there are others, the A1, A2B, and A3 receptor, which have other actions and which actually are responsible for the untoward side effects of adenosine. First, it was IV adenosine, which was advocated. We have to realize that it's expensive in some countries. For example, in my country, it's quite expensive and a little cumbersome to prepare because we have only small vials of 6 milligrams, and we have to prepare a solution in each and every case. So it requires an infusion pump and lines, and central venous access was advocated in the first time. We'll come back to that later on, being in an AimRADIal Congress. And we have to realize that it takes about half a minute or maybe even more to reach full hyperemia. But once you have the infusion running, you will have full and stable hyperemia as long as you have the infusion. And the effect is worn off after about a minute after the infusion is stopped. It has a very well-established gold standard dose of 140 micrograms per kilogram per minute, and it's considered the gold standard of FFR measurement. On the dark side, as you know, AV block is one of the problems with adenosine, but this gives you much less AV block than IC adenosine. Guide catheters with side horse are allowed if you're a fan of those, and most technical caveats with FFR measurement can be prevented by using adenosine IV. Bronchospasm is a problem, of course, so true asthma, which is quite rare to find, is a contraindication, and you should have theophylline available. Caffeine and 1 or 2 cups of coffee are no more a problem. And of course, it is associated with significant fall in systemic blood pressure once you have reached full hyperemia. But interesting to see, if you take a look at the pressure curves that usually when you have the infusion starting, we will have some increase in the systemic pressure as a notion that the infusion has reached the body, but then it decreases. Usually people report engine-like sensation, but we have to reassure the patient that this is harmless. This has nothing to do with myocardial ischemia. It's only caused by the stimulation of free nerve fibers in the myocardium, but it's also a good feedback for the operator that the substance has reached the receptors, and therefore the measurement is valid from then onwards. Now, there has been debate about whether large cubital veins can be used, and the answer is yes. I will give you some hints about that. And we should ask the patient to breathe normally. It's quite important. So we are in an AimRADIal Congress. We want to leave the femoral region alone, and we only want to work in the arms. So the question was asked whether we can avoid puncture of the femoral vein. And as always, we have a paper on that. And it was shown in this paper a year ago that it's actually a single center observational study of 28 gauge hand, i.e. no more than wrist veins punctured, not something upper than that, as compared with 5 or 6 French, I'm sorry for this misspelled, IV adenosine given in the femoral vein. There were 84 vessels paired, and there was an extremely good correlation between the two measurements, and there was not a single patient, not a single vessel that crossed the gray zone, i.e. from above 0.80 to below 0.76. Stability was unchanged, but the only thing that was significantly different, is the time to reach full hyperemia. It was a little longer for the distal hand veins. So we have to be more patient, just like Mort Kern was shown. We have to sit back and wait and enjoy the sight of the infusion. This was actually touched by Niels, so I will skip. But I would like to stress the fact that yes, there are fluctuations in about 40% of IV adenosine cases, and we have to pick the SMART minimum, which is defined as the lowest average of 5 consecutive cardiac cycles of sufficient quality within a run of 9 consecutive quality beats, i.e. the lowest value that you see. And in that case, if you pick that, the correlation of the second and the repeated measurements is extremely good. And actually, it comes to the coefficient of variation of 2.5%, which is something extraordinary in medicine about FFR. But of course, more and more people use IC adenosine. It's very cheap. Since the drug is actually very, very cheap, it's easy to administer. It reaches peak hyperemia very, very quickly, but it lasts very short, less than 20 seconds in general. But some patients do have longer full hyperemia. Therefore, it generally precludes pullback recording and microvascular interrogation like CFR or IMR. And if you are not quick enough, you may miss peak hyperemia, so you really have to be quick. The main side effect is transient AV block, as mentioned previously, especially in the right coronary artery, and of course guiding catheters, which run the risk of spilling of the adenosine over and not reaching myocardium, are not to be used here. The doses is quite an issue. In the first papers, it was much lower than right coronary was then advocated to be given at least 40 to 60 micrograms, and the left at least 50 to 80. But what is realized is that incremental dose escalation is needed. However, there is a very nice paper from the Oz group showing that, of course, as you expect from very small to very high doses of adenosine, you have more and more percentage of maximal flow velocity reached as measured by Doppler wires, both in the left and the right coronary artery. But on the other side, there is an increasing probability of side effects like AV blocks. So the consensus here is that for the left coronary artery, you should not go beyond 200 micrograms, because then you don't have any more peak hyperemia, but you will only run the risk of AV blocks. And the right coronary artery, the dose that is suggested here is 100 micrograms IC. But of course, even in these cases, we might have some side effects, and we have to go back to the receptors of adenosine. And we have to realize that if you have a selective 2A receptor antagonist like regadenoson, which is FDA approved and available in a couple of European countries, you have a much better drug. It's good because it's a selective 2A receptor antagonist. It's good because it has a standard dose of 400 micrograms, irrespective of the patient's body weight. It can be given as a bolus, either in a central or a peripheral vein, and it reaches a maximal hyperemia within a minute. And in the majority of cases, it lasts quite long, allowing us to do a pullback recording and also microvascular interrogation. There have been a number of papers showing a very good agreement with IV adenosine, the gold standard of FFR. And it was also shown that the length of hyperemia takes is at least 10 seconds, but sometimes it's more than 10 minutes. The mean was almost 3 minutes, and 3/4 of patients had at least a minute of full hyperemia, which is quite comfortable for us to do a complete pullback or whatever we wish to do. But an important note after all these lists of things is that no matter which hyperemic stimulus you use, we should never forget to use IC nitroglycerol to prevent epicardial coronary vasospasm, because we're of course not only talking about microvasculature, but also about the epicardial compartment of coronaries. So ladies and gentlemen, in conclusion, IV adenosine infusion is a safe, reliable, and well-tolerated method for induction of maximal coronary hyperemia, and therefore it constitutes the gold standard for FFR. It's a little cumbersome in countries like Hungary, but in other countries where it can be produced in the local pharmacies, it's quite easy and not cumbersome at all, like Holland for that matter. IC adenosine is a good alternative, but does not produce steady-state maximal hyperemia. We have to ensure that the interruption in the recorded aortic pressure is as short as possible, not to miss peak hyperemia. And please remember that the suggested dose of IC adenosine in the left coronary artery is 200 micrograms and 100 in the right coronary artery. IV regadenoson gives perfect FFR, but has unpredictable duration and is a little costly, which might preclude its use. IC papaverine is good, but it can only be used as last resort. So please, I know that we have to settle for compromises, but it's only for the sake of accuracy and full diagnostic potential. And with that, I would like to thank you very much for your kind attention.
Thanks, Zoltan, for an excellent presentation. So I think we have about 10 minutes before going live from Hals to have our first live case. So I think now it's time for the discussion. I don't know, do we have mic? Okay, so we have mic. So maybe I will start, if you allow me, I will ask with a very basic question to Niels and get very practical details. One thing that you didn't touch, Niels, and I've been learning quite recently. In the past, we used to have the old cathlab system. I'm talking about the proximal and the aortic reference pressure. So in the old days, we were very obsessed to calibrate the level of the pressure transducer. All the nurses were educated to look at the patient, try to guess where is the level of the right atrium. And we took peculiar attention. 2 or 3 years ago, and that was a big fight in my lab, we moved towards the use of the automated system, and we moved to the assist that we love. And then I realized, and I did not, sometimes I was confused with the way my pressure was moving, let's put it that way. And then I learned that this system is completely different the way we used in the past. Basically now we are using a distal transducer when you measure the pressure, so you are very depending where you connect, and it's a completely different system. Do you have any experience about this? Do you think it's a new challenge in the environment, or you think that we're going to learn as usual?
Yeah, it's a good point, and I'm thinking back, I've worked a lot in 3 different labs, and I must admit, in every one of the labs I've worked, Chicago, Eindhoven, and Houston, we've always had a fixed height aortic reference on the table, probably what you had up until several years ago. Now in Eindhoven, we did use automatic contrast injector, but it wasn't the assist model, and it also let us have a fixed height aortic reference on the table. So and the only labs that I kind of have more contact with that use a free-floating aortic reference I do admit I still have that worry that you do, that free-floating aortic is a bit tough. You pick up the manifold to inject, you put it down on the table, you can easily have several centimeters of water difference between those two. I think that it's an issue not just for coronary work, but for valvular work. We're making a lot of pressure measurements in the cath lab now for structural heart disease, and I think that it has the impact to affect all of those. And I would almost say that we're going to learn that we should probably go back to having fixed height transducers on the table so that things don't wander around on us as we move our manifolds and make connections. I don't know if anyone has more input on. You use the.
Yeah, it's quite subjective. That I would like to say is that we use assist machine for a number of years now, and I have the impression that the stability of the signal is not 100% perfect, but usually doing left heart catheterization, this should not be a problem, because a drift, say, so to speak, of 2 to 3 millimeters of mercury may not make too much of a difference. However, on the right, in the right heart, it does make a major difference. So I'm more confronted with this kind of technical problems when I do right heart catheterization. But of course, you can zero it at the level which you choose. So if your patient is very large or very thin, for that matter, you may just open the tap and zero it at a different level, different from the transducer. But this is really a problem that we have to realize.
And just to come back to a point, I think that one of the important things to realize about hyperemia is that it's easier to measure big things than small things. And I know that sounds obvious, but it's important because if you do have a few millimeters of mercury uncertainty, usually that's not a big deal for FFR, right? The kind of cutoffs that we have mean that you're going to have a pressure gradient of 20 or 25 millimeters of mercury along the artery. So, okay, if you're off by 2 or 3 millimeters of mercury, you're never going to cross that gray zone. You have enough of a buffer there because the pressure gradients are large. Whereas when you're making resting pressure measurements, typically you're on the order of 5 to 10 millimeters of mercury. And there, the same 2 or 3 millimeters of mercury pressure gradient cause a much larger relative uncertainty. So just remember, big things are easier to measure than small things.
Dr. Sen.
I'm not sure I would just get the ball rolling, the blood pressure up a bit. I'm not sure I'd agree with that comment. If you look at the data and the dynamic range, i.e. if you have 100 stenoses, how those stenoses are spread out by FFR, IFR or PDPA, the spread is very similar between IFR and FFR because we're getting a 30% reliable increase in diastole. And actually, in reality, the patients that go on our cath lab for stenosis assessment tend to center around the 0.8 cut point. So I don't know if the people who use FFR a lot here would agree. Certainly, if you look at large registries, the majority of the patients that come on our cath lab that we do FFR in the real world have an FFR between 0.75 and 0.84. And so a few millimeters of mercury change there will have a difference, have an effect. And I think this has got nothing to do with a particular index. What the important thing I think this goes back to is meticulous technique. And I think listening to Neil's talk, hopefully we can adopt some of those.
Nick.
So in regard to this issue about FFR, IFR, I would really appeal to everyone to try and keep it in context. We're here as an education thing about coronary physiology and its importance in helping us manage our patients better. And I think there is a real danger that people, especially when they're not that experienced in coronary physiology yet, get distracted and put off by this debate, which I find personally extremely tedious and unnecessary. If the outcome data from the trials that are being done, quite rightly, are promising, then to me it won't matter whether people use IFR or FFR, and I'm quite happy to use either in my own practice. So the real message here is that please don't get distracted by these slightly academic debates about which is the best method. Take on board the real message, which is if you're not using coronary physiology to manage your patients, you'll probably get their management wrong in a very decent proportion. And let's wait and see the outcome trial data from IFR, because if they're impressive, what's wrong with that? But at the moment, I think, for me anyway, in my practice, I'm not going to change from a very well-established technique based on a lot of trial outcome data until I'm convinced that the alternative is equivalent. But
that may not be very far away now. So my plea to people, especially when they're not using coronary physiology in their routine practice, is do not be distracted by this debate. Use coronary physiology.
Yes, Nick, I could not agree more. And also I think it's my duty to emphasize what just has been said. The only thing is that we have been hearing a lot of very important information since this morning, and we have to realize that from the beginning it's a complicated stuff, and as interventional cardiologists, when we usually play with the tools, a new device, we like it and we go fast. You know, you have to remember that when we talk about the cutoff of the FFR value to decide or not, I mean, we have moved from the 0.75, then we talk about the gray zone that nobody knows exactly what it is, then there is the new magical threshold, and basically it means that over the 20 years, 25 years of experience, there has been so many things that have influenced the results that we should be careful not to have like the magical number that gives you what you have to do and just separate between IFR or FFR or any new index. My point and my goal from this first session was really to say you have to be extremely careful to each detail, and it's going to be very, for example, I'm coming back to the question I had to Niels, that I was struck with this change in sometimes the aortic pressure by using the assist. I've been learning a lot because I've been collaborating with Opsens and their engineers. So they came and they said, there is something wrong, and I didn't know as an interventional cardiologist. And I think, for example, when I asked the question to the guys who have been doing most of the FFR, like Bernard de Bruyne, you're going to see from Aalst in a minute, he also shifted to assist. And then some of these guys complain about the difference in value, and then he has now a parallel system, because of course there is no way I want to go to the entirely old days of having of forgetting the assist system. So I think we have to evolve and continue, but the basic principle of measuring two pressure, every detail to have the most accurate pressure, will remain. Then in fact the IFR versus the IFR is the concept of a stress test. As cardiologists, we have been educated to use stress tests since cardiology exists, and it's a bit provocative to say, okay, no, I'm going to use some kind of a derived baseline pressure and I can do the same. So I think that the proof still has to be done, but when it will be done, it will be perhaps great, but until, we should focus on all the detail to measure both pressures. So other people are in Aalst already? Steve? So should we go to Aalst?
What? Okay, I will wait for their signal.
Okay. So we're going to go live, but of course we try to keep on track, so there is coffee available outside, and if you want to go out in, just to follow the case, and I hope...
okay, I don't have the feedback from the room.
Bernard?
Yes.
Oh, good morning.
Good morning.
Good morning, Bernard. So this is Olivier Bertrand speaking.
Ah, hi, Olivier.
So we are very pleased to have you. And so, Bernard, we were just discussing the importance of the proximal pressure, especially that many guys have been using the assist system. And Niels was also emphasizing the requirement of sometimes using the old fixed system to make sure that there is no change with the new way of the moving, let's say, distal pressure transducer with the assist. So, as you know, we will let you demonstrate how you work in Aalst from step by step.
Okay, so if you don't mind, Olivier and guys there, I would like just to make a test. So you hear me clearly?
Yes.
There? Is the sound
perfect.
Good?
Perfect.
Okay. And do you see us? Because I have no feedback from your room.
Yes, we see us. At this time we have, we were seeing you like 5 seconds ago, but now it moved to a slide, but...
Okay. So, well, you know what? I would propose to ask Mariano, who is one of the research fellows here, the interventional fellows, to present the case. But I would like to set the stage a bit. since we are in this FFR/IFR/physiology course, I wanted to start with a very, very simple case. I think that Nick Kurtzen is here, and he will be pleased to hear that we are here actually in the diagnostic stage. This is a patient who was brought back to the cathlab for the purpose of the course, but actually we have to put ourselves in the shoes of the interventional cardiologist to perform the diagnostic angiogram on request of the clinician. So this is just to set the stage. Mariano, you can just present the couple of slides that you have prepared.
Thank you. So, good morning in Budapest. The patient is a 79 years old lady suffering from hypertension. Is an obese lady with family history of coronary artery disease and recurrent vasovagal syncopes. Next slide. She was admitted almost 10 days ago in our institution for a stable angina and dyspnea, and this is the ECG. Next slide. And we performed the coronary angiography starting from left ventricular angiogram that showed the preserved LV function with hypertrophic LV. Next slide. The right coronary artery is non-dominant. Next. The injection of the left coronary system showed a focal lesion of the ostium of the marginal branch, OM1, and the long calcified lesion at the level of the proximal mid-LED and involvement of the D1. Next one. These are the two views of the left coronary systems. And we see also a tight ostial lesion at the level of the intermediate branch. Next. So summarizing, we will go to measure the LED and diagonal, and probably first marginal branch, ostium of the intermediate branch, and the mid-circumflex. Next slide. This is a strategy for today. And these are the laboratory data. We have a moderate reduction of the renal function. Thank you very much.
Okay, thank you, Mariano. So we are, I would say, live, but real world live, in the sense that we are dealing with not an extraordinary case, really a day-to-day clinical practice. And the first thing that we have to observe is that this is a relatively old lady with overweight, and I really wonder how you guys in your practice would do non-invasive testing in this patient. Actually, the patient was not admitted in this institution. She was seen on the outpatient link. So it's a very stable patient, but this is what we see every single day. So maybe you can discuss there in the room about the values and the limitations of non-invasive testing in this kind of patients. You have seen that in our institution, we did not even perform one single stress test, if I'm correct, Mariano.
Yeah, of course.
Okay.
The BMI was 31 of this
31,
patient.
yeah. So probably there is, I don't know if you have any special observation, but this is something we face very often, probably in more than 50% of our stable patients.
Bernard, it's Colin Berry speaking.
Yes.
So I'll just ask
Colin.
Hi, I'll just ask our delegates, perhaps with a show of hands, as to what they would do with respect to non-invasive testing, or indeed no non-invasive tests at all. So can I ask who would perform no non-invasive tests, that would accept the history, high likelihood of coronary disease, and go direct to invasive angiography? If you could show your hands. There's no hands going up for that. So who would undertake an exercise treadmill test in this lady? There's no hands for that option either. Who would undertake, by the way, guys, we do have to have 100% votes here, so abstinence is not acceptable. Stress echocardiography. So we've maybe got about 20 to 30%. Some other form of stress imaging, such as stress nuclear imaging. Stress nuclear, so there's almost an equal proportion for that. What about more advanced stress imaging, if you have in your centre, such as stress MRI or PET? Okay. And finally, a CT? Who would undertake a CT coronary angiogram? So the majority of people in this room have not voted. Anyway, thank you for those who have voted. There seems to be some interest in undertaking stress echocardiography or perhaps stress nuclear over any other modality. Looking at this, Bernard, I would give you a personal view. I think this case, if one undertook standard CT coronary angiography, it would simply lead to a problematic set of results because there's multiple narrowings, the visual discrimination of stenosis severity with intermediate disease is difficult. So, I mean, I think there's a case for direct invasive management or potentially some form of stress imaging. Over to you, Bernard.
Yeah, well, this is exactly how we did. And actually, I was not a referring cardiologist. This is how one of my colleagues did, but this is how we do very, very often because we are so disappointed by non-invasive stress testing in general, but specifically in these elderly patients. And to name them stress test, exercise stress test, you forget it. She is 80 years old and obese. It will be submaximal anyhow. A myocardial perfusion imaging will tell you that there is reversible ischemia at the level of the inferior wall, and above 75 to perform as first-line stress test, or let's say non-invasive testing, a CT, will give you in many, many cases diffuse calcification, and this is indeed the case in this patient. So that's the reason why we have a threshold which is very, very low to go immediately to the cathlab, provided, of course, in the cathlab you can obtain functional information. And this is where we are here today, today to discuss with you. So I would like to show you the images we just took. You can show the image, Panos. Sorry, could you show the angel? We took a couple of shots, and you see that indeed she is heavily calcified. We find moderate lesions everywhere. In the meantime, also important, very often forgotten, I reintegrated the patient, and actually she told me since the coronary angiogram a couple of days ago, I didn't feel anything except slight shortness of breath during exercise, but no real chest pain. So, yes, next, there is one. So we see the ostium of these marginal branch, the ostium of the intermediate branch. We see the LAD, which is not a super big vessel. Next, I think we have a LAO with cranial, or maybe you showed it already. Yes, there it is. I hope you see the angios. Do you see the angio, Colin?
Yes, we do.
Okay, good. So, summary. We have the angio, we have the complaints which are not very, very convincing, and as we could expect, we have diffuse disease with many segments which are question mark. So this is how we do. Then we take the angio and we go for pressure measurements and FFR measurements. We have collected already the pressure wire to the quantium. We are working, in this case at least, with a St. Jude medical pressure wire. And again, I would like to start with very simple things. The connection of the wire I will not show you because you are all familiar with these things, and it changes a little bit from brand to brand, but roughly these are the same. What is important is the zeroing. I would like just to ask Isabel, one of the nurses, to lift the to lift the fluid-filled transducer. Maybe you can show the pressure on the quantium and the hands here of Isabel. So she will simply lift the, wait a minute, Isabel. Do you see it on the screen?
Yes, that's
there?
Perfect, Bernard.
Okay, so you can lift this and look how go a little bit higher. You see that the red signal is going down, and now Isabel try to go below the level of the patient. Okay, stop. Excellent. So put it back again. This is just to illustrate that the height of the fluid-filled pressure transducers is important, and you can go all directions, let's say, in making errors. You can make a lot of errors simply by putting the height of the pressure transducer on the wrong place. Now, this being said, this place where it should be put is difficult to determine, and this is the reason why we have the equalization which is also present on the Volcano device, on all the devices. Okay, you can equalize now, Mariano. And actually, equalization is a method to ask to both systems to speak the same language and to correct for the small errors which are related to both the height of the fluid filled pressure transducer and the microtip manometer. So again, we go to the ABC of pressure measurements, but this is equal to 1, almost 1. What are you doing there? Okay. Okay, so let's go live. And we are there in the guiding, and by the way, I was speaking a little bit too much, and we did not equalize at the right spot, so we are going to do that again. And we're going to direct the wire into the circumflex. You can go in the RAO caudal, Sophie, if you want. So the first vessel I would like to interrogate is the circumflex test. But I will make a brief stop here to re-equalize. I made a mistake, you see. Well, it is still equal, but I equalized in the guiding. This is not the place where I should have equalized. It should be equalized exactly there where you see it on the screen. I hope you see it on the screen. So let's go now to the distal part of the circ. There's a bend there. And sometimes to take these bends, it's easier to disconnect the wire, because the wire is a little bit easier to manipulate, but you see it's going easily. It's taking all side branches. This is something which is quite characteristic of the St. Jude wire. It has the tendency of taking all possible side branches. Here we are distal from this myec lesion, and we can have a first measurement. So we see that the pressure at rest, there is no gradient. It's not a big surprise, but okay, we are here. We are here to make a kind of demonstration. So we are going to test this. Do you have adenosine? At rest, there is a very, very little pressure gradient, reverse pressure gradient, which might be due to the fact that we are first working with the needle, which is also something we can discuss, but also to the fact that we went a little bit lower than the level of the guiding. Maybe someone in the room may explain this. We're going to inject adenosine now, and we give 200 mics. I tried not to, you recorded a little bit too late, I would say. That's not a problem. We are going to repeat it. We always do that in duplicate. And you see that these diffusely diseased calcified circumflex is responsible for small pressure gradient of 10 millimeters of mercury, FFR of 0.9091. We are going to keep the recording during 60 seconds. We always try to record during 45 to 60 seconds. To make this reproducible, and then we duplicate the measurement. We try always to do that in duplicate. And also important, and we will come back to this, these pressure measurements are sent, so to speak. Oops, there is a kind of drift there which occurred at the end of the measurement. Okay, now we are back to the baseline values. Okay, you can record, yes. We always try to record 10 beats at rest. You have to be a little bit patient. Look, we interrupt the aortic signal for just 1 or 2 beats. You have seen that? And then we reconnect it without doing too many, let's say, introducing too many artifacts, so that we can have nice pressure tracings. So the pressure remained very high. I think I came back a little bit proximal to the lesion. That's the reason why the values are somewhat different. What is absolutely sure is that there is no pressure gradient, neither at rest. Also, the morphology of the signal is something which should be looked at. And this is But there is also something which should be mentioned. We should never hide this. Also during live cases, there is drift. A little bit drift, probably, but too much to be perfectly true. In this case, it will not really impede or decrease the quality of the measurement, but it is something which is extremely irritating. And the real drift can be evaluated, of course, only when you come back to the proximal part of the vessel, which I do now, and you see that there is still a difference of 4 millimeter, let's say PDPA of 1.0304. Of course, it's not a catastrophe, but it's, in my opinion, something which is really to be avoided, and that the companies are probably working on. Okay. Or should work on, at least. You can stop. We have measured the circumflex. We are going to focus now on the LAD because this is the most important lesion.
Equalite.
You agree? So
yep.
we are back, and we are, before going to the LAD, we are going to re-equalize. You can test me in test me. I think we are still we are still far away. And we are going to disconnect the wire to have him talking a little bit better. You see that it's sometimes difficult to manipulate these wires. And if we are here in the angular branch, this is also something we had to measure. So if we are entering the angular branch, we are going to measure that. Because on the description of the angiogram, it was told critical lesion on the ostium of the angular branch. Not quite sure this is a critical lesion, but we are going to don't do anything, don't touch anything. Okay, you see that we're going just to advance the. So you see that across this critical lesion there is absolutely no gradient. I will just give contrast medium to make sure we are in this angular branch. Yes, we are. And you see, I will put the sensor just distal to the lesion because this is really illustrative, and I will film to have good quality. You see the sensor is just distal to this lesion, which angiographically indeed looks very tight. At rest there is no gradient. IFR is certainly equal to 1. And FFR is equal to 1, 2 with contrast. We know that contrast is almost as good as adenosine. And to be absolutely complete, we are going to give adenosine also in this vessel. So I told you it's not very, very impressive, all these lesions, but this lady was catalogued as a tri-vessel disease, which is probably not the case. Okay, we have again this small reverse gradient. We're going to re-equalize them to make sure. No, just let me do. Okay, we are there. Yeah, you can re-equalize. There is a little bit of drift. Okay, you tell me when I can go.
Yes, one.
Bernard, it's quite atypical that you have to re-equalize as often, right?
I would say it's not uncommon. We should not hide the truth about the drift. This is a persistent problem which is vexing, probably also vexing for the engineers, but for the clinicians it's even more vexing. There are some fluctuations of these sensitivity of the sensor which leads to drift. And of course you can elaborate hundreds of theory, but the company who will come on the market with a real drift-free wire will have a major advantage. Okay, for the sake of completeness, we will give adenosine, which is given here. And again, here we ask the patient to come back to the cath lab and to be catheterized again. This is typically something we do on the spot in the laboratory when we are doing the angiogram. So an angiogram should really be completed by pressure measurements in many cases. This is what we try to do almost systematically.
Bernard, Bernard, can I ask you another question? Because I learned from you that all the time we have to combine nitro for the epicardial vessel and adenosine or whatever for the beds.
She got nitro. That's true. I didn't insisted on that. You can go in LAO, but she got nitro in the beginning of the case. Just was that your question? Sorry.
No, I was just, so you do not give nitro every time you do an FFR measurement?
No, not each time, but at the beginning of the case, let's say of the angiogram, or every 30 minutes thereafter, we give nitro. Okay. So each time we do a fractional flow reserve measurements, we suppose that the patients are under, let's say, full epicardial vasodilation due to thanks to the nitroglycerin test. It's not a good projection to enter the LED. That's a better test. No, we are still in this. Okay, go in a RAO caudal, yeah. See, yeah, test. Just try to enter this LED. I made a big J to facilitate the entrance in the big circumflex, because I expected a problem there to take this bend, but it's exactly the contrary which happens there. Okay.
So I will say for the people, I mean, this is real life. So you have to understand again, you have to have a complete different mindset. I mean, if you want to use physiology, you need time, patience. I mean, obviously, if that kind of lesion probably will use a BMW, will take like 5 seconds. And it can be very frustrating that sometimes you spend 10, 15 minutes to check your equalization, then go distal. It's more frustrating sometimes than even put a stent, but that's better medicine.
Yeah, it's very uncommon to have this, and I made actually a small mistake by taking such a bend in the wire. So I would not be so pessimistic. We have measured that in our lab, and actually it really goes very fast. So I would not be too pessimistic about the length, the time needed for obtaining these measurements. I will reposition the guiding a bit better, that test. But it's a very long left main, very big left main, and the circumflex is also very big and very attractive for the wire, apparently. So I'm afraid I will maybe try to remove a little bit of the curve of this wire. Very often you have to do the contrary, but well, do you have any other tricks to enter this LED? We can go also in spider, Sophie.
Good morning, Bernard. This is Rod speaking. What I do in such difficulties sometimes is to take a pilot 50 and enter the LED and just follow it like a body wire with a pressure wire.
Yeah.
I'm in real trouble.
Yeah. It's true. I know what you mean. That's true. That's a good small trick. We're going to see in the spider, which is a very, very heavy projection in this lady, how the wire behaves there as compared to the LED. Yeah, there is a very sharp bend. I did not anticipate that at all. Yeah, you see. And let's take indeed a test. Oh, that's the angular branch again. Test. I'm sure there are 100 pairs of hands there in Budapest who would like to help, who would do it differently. Yeah. There's also a nostril plaque there. I will try to put the guiding differently. Test.
So, no. Bernard, it's Colin Berry speaking. Of course, you could have shown us a set of FFR results and talked about something that had happened earlier, but you know, the whole audience is identifying with what you're doing just now because this is real-life clinical practice. So I think it's edifying and resonates with us all.
Mm-hmm. Colin, I'm sorry, I didn't grasp all your comments.
So you're
beginning.
You know, it's sometimes challenging to pass a pressure wire, and indeed any wire, into a coronary artery, and
yeah, but even any wire, I'm afraid, even a.
You know, so it's just real life clinical practice, which is what everyone in this room does. So this is you know, it's a good case, and hopefully we'll get the measurements in due course.
Yeah, very kind. No, actually, it's not a good case at all, but you know what, I'm going to first use a regular wire to show the way, but I'm not even sure this will be better. And you know, these exchange of wires, we can always do that, but this is really not the purpose, to make it complicated. Geef eens een gewone wire. Yeah. What we can also do is to take Judkins guiding. We are going to change everything. Okay, so it's a little bit a pity, but it's live. Okay, we are going to keep this wire. Wire is still good. Geef eens een Jud. Ja, geven je L4, this is French.
So Bernard, I concur with Colin. I mean, that's exactly what basically obviously you probably would love to go faster, but that's exactly the intent of this workshop, is to show real life and not to make people believe that it takes 5-10 seconds every time. But in your practice, really, how often do you need to go to plan B and cases like this? 10, 20% less?
Do this, I should ask to the nurses what is their gut feeling, but honestly, this is relatively rare. I have no numbers, I have to admit. I have no numbers. When you see big series, for example in Famous, if I'm correct, Colin, there was 1 or 2% failure of measurement, something like that. See? But we have probably something like 1 or 2% of failure of measurements, but very often it is related to tortuous vessels. Here you cannot really say it's a tortuous vessel. It's simply a difficulty to engage, and sometimes you have that with regular wires too. So give me the wire again, simply the pressure wire. Sorry, Colin, I interrupted you.
No, one of the outcomes from Famous that surprised me was that we were able to get FFR measurements in all patients. I was surprised because it wasn't just from our centre, it was from 6 hospitals, and I would suggest that 3 of them certainly were not, didn't have a strong track record in FFR measurement. The other thing from this study that surprised me was the very low incidence of guide wire coronary dissection related to the guide wire. I think it was, if I remember, 2 in 706 lesions. I think it was about 0.3%. So that was much lower than, for example, in other reports. Ripcord was slightly higher, next here, and I think guide wire dissection can happen sporadically, but you know, in FAMOUS, these were unselected patients with multiple arteries instrumented, and safety was confirmed. I suppose in this situation that you're in, you just need to take your time. I don't know whether you routinely check ACT to maintain anticoagulation.
Yeah, we do that every 30 minutes.
Yeah.
I'm going to change again the shape of the wire. But yeah.
So it's just a matter of time, and I suppose the longer the procedure goes on, perhaps one might tend to become a little bit more frustrated, and then mistakes can happen. And you know, you and your colleagues and most of us have got the experience to know that you just need to take your time and adapt the approach according to the feel, and you'll get there.
Test. Now there is this first diagonal branch, or first, let's say, small angular branch, which is really difficult, which makes it's difficult, but you know, if you want, I can propose you is to give a lecture, and we will keep you informed about the measurements, and we will show you the results afterwards. I don't know. It's really up to you. It's not. I think the case is whether or not the LED will be significant. Well, is not so fascinating for you. What is important is to discuss together the strategy in the diagnostic setting, and that's really what we wanted to show. I think this is the LED. Finally, go in the other projection. Yeah. Yes, we connect. Go in the LAO with cranial. Another small detail, but again, these are small details, is we very often equalize with the needle inside. Okay? This is not what is written in the books, but this is what we used to do because it makes things much easier, and this can be done if and only if your needle has almost no leakage. I don't know if you can magnify here the needle, but you see there is almost no backflow, and we calculated that the difference with or without a needle is a matter of 1 or 2 millimeters of mercury. So, did we equalize again? Because now we are going to forget that. You see that the wire is still in good shape. Better than to find the LED. Good, equalize. Yes, there we go. My best guess is that it will also be negative. And you can leave it. Very difficult to advance the wire, and I think it is due to the sharp bend upstairs there in the proximal part. Yeah, that's good. It's better. Okay, so we're in the distal LED. Finally, I will give you a shot. Yes, you can show this. Okay, you can look at the screen. This is, of course, with contrast medium. And it will end up with just 0.80, like usually. It's very interesting. Okay, so keep this in mind, and let's try to find a better projection, Sophie. In the meantime, we're going to load the adenosine and to let the pressure tracing go back to the resting values. That's important too. And I will stay away from the pressure measuring devices. I mean and please also note that we are far distal from the lesion. I used to do the first measurement at that stage, and we have a PDPA ratio at rest, more or less at rest, whatever rest is in the cathlab, of 0.90, 91, 92. we are not able to calculate online the IFR. Maybe some of you guys can do that by eye, but it must be also in the range of 0.91, 92. Probably just below the threshold where they advocate the additional use of adenosine. Is there someone who is in the room who can comment on that statement? Again, we cannot measure it online, but I think this is the range where it is really needed to have hyperemia induced. Much more than in the... Okay. Yes?
Dr. Sen will comment, Bernard.
Okay. De Bruyn, this is a great case, showing exactly what it's like to make these assessments. And thanks for sharing it with us. I agree with you. This is in the realm that we would suggest doing an FFR. All the data in terms of outcomes is for FFR, and if this was on my cathlab table, I'd do an FFR here.
Bernard, it's Colin Berry. Bernard, it's Colin Berry speaking. The minimum PDPA value with contrast was 0.8, I think, if I saw correctly. Do you think you've got enough information just now to make a treatment decision? I accept that you're an enthusiast for intravenous adenosine, but putting that caveat aside, do you think that with contrast at 0.80, and also, of course, taking into consideration the patient and the clinical circumstances, do you think you've got enough to make a treatment decision based on that alone?
Okay, good question. We are ready to give adenosine IV, at least we should be ready. So we will do that in just 1 second. You can have it run. And I will also show you how we do, because, for example, in some other labs, they have it cloaked. Okay, so maybe you can see that we give it still, in many cases, through the femoral vein, not needed. It can also be through a forearm vein. But we let it run outside the patient so that the only thing we have to do is to switch it on, switch it off, switch it on, switch it off. That's very convenient. I will switch it off for the moment. I will let it run outside the patient, but I would like to give a second run of adenosine IC before, as we always do. We always do it twice, and we always try to let the patient come back to the baseline value. But the point is well taken that when we are in the, let's say, the real gray zone, which is more than the gray zone, it's 0.80, these difficult decisions, we have to do it twice. And we can discuss endless about the need for pulling back, the need for giving other stresses. Let's give first adenosine again. Okay? Let's go. And I keep my foot on the... This time I will flush it with saline, because I'm not absolutely sure the guiding is still in. You see? That's interesting, because I pulled it back. Okay, now the adenosine certainly entered the vessel, and it's a good position, because we are disengaged. It means that the guiding is not impeding the flow at the level of the left main, so the value is 0.77, that's what I saw. And if you don't mind, we are going to give it IV on top of this. So, Isabelle, it's running, the IV? Okay. So, 0.76. Okay, good. Yeah, okay, it's running. No? Yeah, you can record, because then we can discuss that with the colleagues. And Isabelle, I will already ask you a second wire, but maybe there is a second wire, because we will have to protect the side branch. Adenosine IV is, well, at least in our experience, and you have to be a little bit more patient. And it takes some time to be fully active. And sometimes it takes 3-4 minutes. 3-4 minutes in a cath lab is very long. But I agree with the protagonist of IV adenosine that it gives very nice tracings, steady state. You have this increase of the aortic pressure, which you see there on the screen. The value is 0.75 now, very, very similar to what we have seen with 230, yeah? Okay, ACT is 230, so it's a little bit lowish, what we doesn't make it. So 0.75, 0.76, it's very, very close to what we obtained. Well, it's actually the same that what we obtained with IC adenosine.
Bernard, how is
yes.
the patient just now? Is she symptomatic or not?
No, well, she voelt u iets in de borst nu? Nee. Well, that's extremely interesting and also quite exceptional. Patient doesn't feel anything. Okay, it's interesting. In our experience, it's at least 80% of the patients who at least feel something. And you know, I will not take any big risk, but I will pull back, because this is also something which provides us with a lot of information. You can put a marker. We are still, yeah, you have to een beetje druk. She has something. Okay. Yeah, there is quite sharp. Okay, did you record that?
Yes.
Okay. Yeah, okay. Stop. We are going to stop the adenosine because the patient feels something. I was telling you that it was exceptional that the patient didn't feel anything, and of course now she feels something. But, okay, I think there is indeed a nice step up at the level of the mid part of the LAD, exactly where the lesion is, but you see that it does not come back completely to 1. So, Mariano, thank you. Yes, there. You can magnify this? No. Okay, now we are back distal. You can give me contrast, and I think we are going to do something to the LED. You know, we could even argue, yes, but this is still in the gray zone. We might leave it like this, the more that there is probably something also in the proximal part of the LED. But I think we might help this lady by increasing the conductance of this segment, which will probably decrease or increase, probably lift the value of fractional flow reserve to a level which is non-ischemic or less ischemic, no, non-ischemic probably, and hopefully improve her shortness of breath. I fully agree. I'm the first to say that this is with a lot of question marks, but these are the data we have now at our disposal. I don't know if you agree. Maybe some of you would say, well, okay, she is 89, she will, 79, she will never exercise a lot. We are not taking a big risk in leaving it like this. I agree. So if you have other opinions, they are very welcome, and we can discuss that. We can discuss that. This is also one of the goals of the live cases. We're going to put Olivier?
Yes, I think does anyone disagree or everybody agree with? I think that's real life, and you have to make a clinical decision at some point.
I have one small question, Bernard. Could you go back, please, to the ventriculogram that you took at the very beginning of the procedure? And the more comment I would make is that in a patient with dyspnea, what we would do probably is rest echocardiography, just to exclude the possibility of valve disease. Did this lady have mitral regurgitation?
No. She has no mitral regurg, that's for sure, but she has a mild left ventricular hypertrophy. So, again, it's never black and white. Give me the second wire. It's never black and white in medicine. She certainly has many reasons for her dyspnea, but the dyspnea occurred 2 or 3 months ago. Before that she was fine. So we have quite some arguments to suggest, at least, but I realize we are on weak grounds here to suggest that her dyspnea might be at least partially ischemic. She only has that during exercise when she climbs the stairs, and sometimes, but it's very vague, sometimes she mentions also a slight chest compression. So I believe a lot in the, yeah?
Since you've excluded the possibility of valve disease, which might be responsible for her symptoms, I think this was a great demonstration to show that there is basically a very small gradient, i.e. she's fine at rest, but when she exercises, this gradient will go up 25 millimeters of mercury, and her LAD in her FFR in the LAD will be absolutely ischemic. So I think it's very well justified to do something about this LAD, and the dyspnea can be thought of as angina equivalent.
Okay, you can go back to the LAO. Sorry, to the spider. We are going to see whether the BMW is better, or let's say I'm better with the BMW. Let's be fair. To go into this LAD. Definitely yes. Okay, go. We gaan terug in de LAO with cranial, LAO cranial. We are going to protect the diagonal branch. Okay, I'm going to give a film, not too much contrast because she is.
Bernard?
We are lucky. Yes?
So in the interests of the program with other lectures, we are going to have to move on. I think what you've shown us is a real-world case with some technical challenges and guide wire advancement, and you've shown us some very interesting insights into resting and hyperemic physiology and how the use of contrast FFR might obviate the need for intravenous adenosine. So we are going to conclude here, and I think we're all very grateful for this insightful case.
Okay, thank you very much. The only thing I wanted to underscore is the usefulness of these type of measurements in the diagnostic setting to avoid patients to come back unnecessarily. That's the only point I wanted to make clear, and I hope you agree with this. Thank you very much.
Bernard,
we're going to complete this case.
Bernard, so I just asked Steve, because we are based on the internet, it will be possible sometime in the day, I don't know, we will communicate with you, but maybe we'll get the final results at the end. I will communicate with you.
We're going to send you a slide or two with the final result and the final FFR.
Thank you very much, Bernard, and our whole team. Bye-bye.
Thank you. Bye-bye. Okay, good.
Okay, so we're going to move to the next session now.
That was a mess. Bon, oké. Geef een 2,5 ballon. Nutje. Ja. 15.
All right, hopefully everyone's recharged with a little bit of caffeine here. I'll have, let's see, Jolt and Shai join me up here for the panelists. And building on the theme that Bernard just brought up about FFR in the diagnostic phase, our first speaker, Nick Curzon from Southampton, is going to speak on that very topic and its usefulness in changing clinical judgment. Once his laptop is connected, Nick will give us a speech on that.
So thanks very much for the invitation to speak. I've been asked to talk about FFR assessment and how it affects your clinical judgment. As I said in my comment, I don't really care whether it's FFR or IFR. I care that we use coronary physiology more. And it's very important. If one thing comes across here, that's what I would like to come across. So these are my potential conflicts. I think conflicts are important. These are all either research grants or speaker fees from companies that have something to do with coronary physiology. So let me just show you a case. This is a man in his 50s with multiple risk factors who's getting some shortness of breath on exertion and some chest discomfort. He has an angiogram, and the left coronary is completely clear of atheroma, and this is his right coronary. So this is something we face every day. So has he got coronary disease? The answer is yes. Would he benefit from optimal medical therapy? The answer is yes. Are his symptoms due to this coronary disease? I have no idea, and neither do you. And should he have this right coronary, possibly here, revascularized? Well, I have no idea, and neither do you. And that sums up the reason that FFR, or coronary physiology, is important. So in our clinical practice, we make decisions on a daily basis about the best treatment, optimal medical therapy, PCI, or surgery. And furthermore, which vessels should be targets for this revascularization. And the tools we use, the ones that we have available, are anatomy and physiology. And they are interdependent on each other, these things. But we're being pretty dumb about the use of physiology. We're relying very much on anatomy. And this is flawed. We're taking our eye off this ball because the use of anatomy on its own is no longer a state-of-the-art assessment for patients. And one thing I hope I will persuade you is that we will get our management of patients wrong on a regular, routine basis if we just use the angiogram. So our current strategy is we see someone with chest pain, we may ask for a test for ischemia, or we may, as we've heard, often go straight to an angiogram. And then we have three choices. We're obsessed with stenting because we're interventionists, but there are two other choices that we make every day. And the angiogram is flawed for that indication. This is another patient in his 60s with very classical angina. As you see, he has a very tight lesion in his LAD, but he also has quite a tight lesion in a high OM, an osteal moderate lesion in the circumflex, and some more disease, moderate disease in the mid-right. So this is multivessel disease. How should we treat it? Based on this angiogram, I have no idea whether he would benefit from surgery or stenting. And neither do you, really. And the problem is we just can't tell from an angiogram what the best treatment for him is. And it's important. And in fact, if you do a systematic FFR at that diagnostic angiogram, you find that only the LAD is ischemic, not surprisingly, because it didn't even have TIMI-3 flow. But the other coronaries are nowhere near ischemic, according to FFR. So instead of having a patient who might benefit from bypass surgery, we have someone who has single vessel disease. And of course, I went on to stent him. So if your currency is the significance of the lesion, you won't be able to tell based on an angiogram. That's the coronary physiology lesson. And it's amazing that we're still just using an angiogram to me. We're looking to see whether the patient has ischemia and whether the lesion that we're focusing on has ischemia, and you can't tell that reliably from an angiogram. And we're barking up the wrong tree to some extent. We're barking up the angiogram tree, and we should probably, if we want to get it right, bark up the physiology tree. So going back to our algorithm, we do a diagnostic angiogram, and we have three treatment options. Well, thanks to Bernard and Nico Pils and the pioneers of FFR, we know that we can affect our judgment related to people who we have decided already need a PCI. But what about the people who are going for optimal medical therapy or bypass surgery? What's the power of FFR to affect our management? Now, this is my favorite paper of all the papers I've ever read. The reason it's my favorite is because it's very simple. It's the kind of research even I can do. It's just observational, small number of patients. So in this study, there was a small group of patients who had had a diagnostic angiogram, and the cardiologist had decided needed 2 or 3 vessel PCI because they had 2 or 3 vessel disease. And then when they came in to have that PCI, they had a pressure wire assessment of all their vessels. So before the pressure wire, 21% of them had 3 vessel disease, which was the intention was to treat that with stents, and the rest had 2 vessel disease. After the FFR, this was the distribution. Not a single patient had 3 vessels showing significant reductions in FFR. Only 9% of them had 2 vessel disease. 75% of them only had single vessel disease. And believe it or not, 16% of them had FFR negative all of their vessels. And it was that study that made me want to do ripcord, which was an assessment to test the hypothesis that in patients who are being investigated for stable chest pain, routine assessment of FFR of all their stentable vessels would modify the management strategy that was made based just on doing an angiogram. Or in other words, how different is our management when we have FFR available in all the vessels compared to just doing an angiogram alone? So there were 200 patients who had been listed for an angiogram for chest pain by their cardiologist, and they came in and had that angiogram, and then we asked that cardiologist to make their normal, everyday decision about whether the patient should have optimal medical therapy, PCI or CABG, or more testing. And then we got in an interventional cardiologist who did an FFR of all the stentable vessels, regardless of how tight the lesion looked or whether there was no angiographic lesion at all. And we showed the FFR data to the original cardiologist and asked them to make a second management plan. And the endpoint, the primary endpoint for ripcord, was the difference between the angiogram-derived plan and the FFR-derived plan. This is a scatter plot of every measurement on every lesion in this study. And as you see, on the x-axis, we have the degree of stenosis of each lesion. And on the y-axis, we have FFR with a cutoff of 0.8. So above that line, not significant, below it, significant. And we see a mismatch between the angiogram and the FFR. So there are some quite tight lesions here, which are FFR negative, which definitely would have been stented. And there's a whole load of intermediate and really quite minor disease, which is FFR positive. So if there's one lesson, it's I wouldn't restrict even my FFR measurement to intermediate lesions, because there are some very mild lesions that are FFR positive. In fact, 32% of lesions, the experienced cardiologists would have said they're significant or non-significant and have got it wrong according to the FFR if they just use the angiogram. And of course, this led to a big change in the patient's management. If we look at the first plan, which is from the angiogram, and the second plan, which was from the FFR, we see that there's a change in management in every conceivable direction as a result of measuring the FFR. So, for example, in 72 of the 200 cases, angiogram said the patients needed medical therapy because they didn't have any significant disease. That was only true, according to the FFR, in 63 of those 72, because in 6 of them, they needed PCI, and believe it or not, in 3 of them, they had triple vessel disease and needed bypass surgery. So those patients would have been reassured based on the angiogram, sent away, and sent to a gastroenterologist. In fact, the FFR told us that 89 people didn't have any significant coronary disease, including 24 who would have got a PCI based on the angiogram, and 1 patient who would have got a bypass operation. And so it goes on. There's a mismatch in management based on the angiogram systematically, to the point that in 26% of these cases, the management was changed fully by having the FFR available. And okay, there are lots of limitations. This is a small observational study. But what it does tell us is that FFR makes a more accurate diagnosis and therefore leads to the patient getting a more accurate treatment. And this is spookily consistent with other data. Don't believe my 200-patient ripcord study. Believe other data. Remember this discrepancy between severity at angiogram and FFR? Here's the FAME series. Exactly the same. Here's Colin Berry's famous study of ACS treatment. Exactly the same discrepancy, exactly the same proportion, about a third of lesions. Here's a massive series from Bernard de Bruyne's group. A third of lesions, you cannot tell whether they're FFR positive or negative based on the angiogram. So I'm afraid this is true, and if there's one thing you take away from an FFR workshop or an IFR workshop, I don't care. It's no matter how experienced you are, no matter how tight a lesion looks or doesn't look, you will be wrong about whether it's causing ischemia in 30%. This is scary. If you're not using physiology routinely, it's time you started, because this has enormous implications for clinical practice. The management by an angiogram alone is fundamentally flawed. There's very good evidence for that. And it can be improved drastically with coronary physiology assessment. Of course, there are no large-scale randomized trials of this, which is what we're just initiating in the UK in a trial called Ripcord 2. Let's just have a look at some of the other studies that have shown the same thing, the impact on clinical practice. So this is the French RF3 registry. Much larger number of patients. At operator discretion, at least one of the lesions underwent FFR on top of the angiogram, and then they studied how much difference that made to the patient's management. The answer is, in 43% of these 1,075 cases, the management was fundamentally changed just by doing FFR, maybe even of only one vessel. And it changed in every conceivable direction. So if you look at the ones who were initially committed to medical therapy, actually, over a third of them required revascularization. They would have been sent away, reassured there's nothing wrong with their heart. If you look at the ones who were originally sent for PCI, nearly a half of them didn't have any ischemia and didn't need a PCI. And a very large proportion of people needing CABG either needed optimal medical therapy or actually only had single vessel disease that could be treated with PCI. 43% change in management. And the POST-IT study, which has just been published, 918 cases with some FFR measurement. The headline is this: in the ones who were originally committed to medical therapy based on the angiogram, over a quarter of them needed revasc, or they would have been sent away being told they had no angina. Of the PCI ones, over a quarter of them didn't need PCI. Most of them just needed reassurance on optimal medical therapy. There is a huge change in management in these patients just on the basis of routine FFR, and scarily this correlates with outcome. There is nowhere to hide on this. If you don't do coronary physiology, you will get the management wrong, and it will have an adverse effect on your patient's outcome. Scary stuff if you're not doing routine physiology yet. Now, I've shown you 3 studies: Ripcord, RF3, POST-IT. But actually, all of these studies have shown exactly the same thing. And the consistency with which they show it is really remarkable. Here are the studies. If we look at their variable, all but famous are observational. Famous is randomized. Very variable numbers, elective and ACET mixes, mixture of degree of stenosis which initiated the FFR. In my opinion, we've shown in Ripcord and in Famous that it should be from 30% up. Because between 50 and 30%, there are plenty of cases that are FFR positive, and you'll get those wrong if you just restrict to this 50 to 70 type. But look at this column here. This is the percentage of patients in these studies in which their management was fundamentally changed. And the answer is it's between 22 and 48% of these populations. So in between a fifth and a half of your cases, you will get the management wrong, fundamentally wrong, just by using an angiogram. In the year 2016, that is untenable. And remember, in these studies, many of them, the operators only chose to look at intermediate vessels. Imagine how different the management would have been if they had systematically looked at all of them. So if we conclude what effect does coronary physiology assessment have on your clinical judgment, it's an astounding effect, and it's astounding to me that people aren't doing it. Clearly, there is a discrepancy between anatomical angiographic assessment and physiology to assess significance of lesions. And it's been repeatedly shown that you can't tell whether a lesion is causing ischemia just from an angiogram in about 30% of lesions. And as a result, not surprisingly, if you use an angiogram to direct your management, you'll get it wrong in between 22 and 48% of cases. So in my opinion, there's already a very strong case to use FFR routinely for all lesions between about 30 and 90% every time you do a diagnostic angiogram. But probably for the guidelines to change, we're going to need a randomized trial to show that. And the first case is going to be done in Ripcord 2 in the UK in the next week or two. And just finally, one other message about FFR. This is the case I showed you at the beginning, the man who turned out to just have an LAD lesion. So I thought, fine, I'll treat it with a drug-eluting stent. One little plea, and we're going to talk about this later today, but just take this message away because it's a real beauty, this. So I put a very generous drug-eluting stent across this lesion, and I got this angiographic result. And I was very pleased with myself. But being Mr. Obsessional, I measured the FFR because I did the intervention on FFR wire, which is what I always do. And to my frustration, the FFR after that stent was 0.73. So I thought, oh, well, there's probably a bit of a step down here, maybe a bit of dissection or something. So stupidly, I put in an overlapping stent, producing this angiographic result. And being Mr. Obsessional, I checked it again. And it was only 0.76. And I was really, really fed up. To the point that I took the wire out, I re-equalized it and put it back down because I didn't believe it. 0.76. And then I did what I should have done one step earlier, and I IVUSed it. And it showed there was a big segment that was underside and under-deployed at the top of this first stent. So I post-inflated it with a larger non-compliant balloon, and the FFR was 0.9. This is real life. I could have sent that patient away, still ischemic, despite a beautiful angiographic result. That is the power of the FFR. Thanks very much.
What I think we'll do is we'll save discussion and comments for the end and move on to the second talk in the series. It's Dr. Yoshiaki Kawasa from Gifu, Japan, who's going to be talking to us about expanding pressure wire indications through complex PCI procedures.
Okay, thank you for the invitation. Today I would like to talk about the expanded potential of pressure wire used for complex coronary angioplasty. So my talk is based on the recently released FFR wire using the optical fiber. So we did the in vitro experiment. So using this wire, experiment one, ballooning by 22 millimercury, while pressure wire is beneath the balloon. And experiment two, pulling out the wire under the inflation of the balloon by 10 millimeter mercury. So with this experiment, this is actually mimicking the bifurcation lesion. So with this experiment, we didn't see any drift with experiment one, and we did see a very tiny drift with experiment two. So this wire is like a very strong, tough wire, so like a G-Shock. Yeah. So recently, the problem with the drift is forecast. This paper shows the around 11% of the drift over more than the 3 millimeter mercury is observed when we use the pressure wire, electric type pressure wire, for the just diagnosis. So this is the data from our facility. We use the pressure wire with optical fiber for 75 patients. So we use this wire for the measurement of the pre-FFR measurement, and also we use this wire as a workhorse wire. So we deliver the IVUS, balloon, and stent over this wire and perform all the procedure. And after that, we reconnect the wire to the connector, and we check the drift again. So the here is the detail about the procedure. Total procedure time was 97. Total contrast volume was 114, and device exchange time was 6. And max pressure over the wire was 21 atmosphere, and rotablator cases was 8 cases. So we have to exchange the wire to the rotor wire in this case. And at the end of the procedure, actually the mean drift value was 0.016. And the pressure drift more than 3 millimeter mercury was 5%. So even though we use it as a workhorse wire, at the end of the procedure, the big drift is almost same or less than the conventional pressure wire. So what can we do with this kind of pressure wire with less drift? So I think it's make it easy to monitor PCI result during PCI, and also it make it easy to measure the final result. So we use this wire for the treatment of the bifurcation lesion. I think bifurcation lesion is one of the representative things for the complex PCI. So Dr. Koo reported that even though there is a severe stenosis at the ostium of the side branch, there is not frequently ischemia in the side branch. Also, there is a report that if you perform the kissing balloon, the stenosis rate going to be increased, especially with drug-eluting stent because of the damage of the coating. So from now, I'm going to show you the case report, 3 case reports. So first one is the 56-year-old male. So I think using the pressure wire is very suitable for the minimum contrast procedure. So this case is minimum contrast procedure with gelled pressure wire. So he woke up with a chest pain on the night of the April 2016. The chest pain lasted for several hours but improved. So he went to the home doctor for regular visit on April 22nd. He was pointed out the abnormal ECG and referred to our hospital. So this is the CAG of the RCA. Although there was several stenosis, the pressure wire measurements showed there was no stenosis, no ischemia with this vessel. And this is the angiogram of the LCA. As you can see, there is a thrombus inside of the LCX. So, and also, we can see the severe stenosis just distal of the diagonal branch. So at this time, we treated the LCX lesion. And we just directly pressed the stent, and the total amount of the contrast was 80 ml. And since this was the emergency case, we didn't have the result of the blood test until we finished the procedure. So after that, we found out that this patient has a renal dysfunction. But fortunately, we didn't see any CIN after the procedure. And we tried to do the rehabilitation with this patient, but during the rehabilitation, he complained about the chest pain, and also ECG shows the ST depression. So we had to treat the LAD lesion, although it was just 4 days after the first procedure. So in this time, we pressed the pressure wire in the diagonal branch and measures the FFR. The FFR value of the diagonal branch was 0.90. So we decided to press the stent directly to the LAD lesion. So we check the good apposition of the stent strut with the IVAS, and we remeasure the FFR of the diagonal branch, and the diagonal branch FFR was 0.86 after the procedure, just a 0.04 drop from the previous value. And FFR value of the LAD was 0.95. And we don't have the pre-PCI value because this patient has the renal dysfunction, so we didn't want to use the so much contrast. And in fact, with the use of the gelled pressure wire, we could finish this procedure with 10 ml of the contrast. And again, happily, we didn't see any CIN event with this patient. So the second thing is that I got the accusation that they are using the pressure wire for the gelled pressure wire can sometimes cut the wire. So if you have the some severe calcification in the vessel, maybe gelled balloon is the one of the way to avoid the such kind of damage of the wire. So this case is an 85-year-old male, and he has a history of RCA-MI and the treatment of LMT to LAD disease in January 2016. He admitted our hospital again, complaining of chest pain on effort in August 2016. CAG revealed a moderate stenosis in his mid-LAD and diagonal branch. So gelled balloon is from the Europe, so I think you guys all know, but just the illustration. So you can protect the diagonal branch with balloon and preventing the diagonal branch from occlusion. So this is the case. although there is an occlusion of the LCX itself is very small, so we didn't treat this vessel. So as you can see, there is a moderate stenosis in the middle part of the LAD and the diagonal branch. So we decided, so the FFR measurement of the LAD was 0.55 and the diagonal branch was 0.60. So we decided to do the gelled balloon procedure. So first we place the stent to the distal part of the LAD lesion. And after that, we place the second stent to the proximal part of the LAD lesion. At that time, we place the balloon over the pressure wire in the diagonal branch. And we place the stent, and this one is the after stenting. So you can see the delayed, but there is a flow inside of the diagonal branch. At that time, we also measure the pressure, FFR value, before with balloon and without balloon. And we can see the clear increase of the FFR value after removal of the balloon. So by using the pressure wire in this kind of situation, we can you can see the actual effect of the pulling out of the balloon from the gelled condition. Yeah, this is the actual not pullback, but continuous measurement. So after that, we recross the diagonal branch with the another wire and perform the kissing balloon, and the final result was like this. And I think this one is almost the identical one to the previous presentation, but this one is also, reveals the dissection. So the case was 65-year-old male. He visited our hospital complaining a chest operation on effort. CAG revealed stenosis in his D1 and RCA. A PCI for D1 lesion was performed without problem. He readmitted to our hospital for the treatment of lesion in his RCA. So, yeah, if you see the guiding caster, you can easily imagine there's going to be something happen to the ostium of the RCA. But because of the shape of the aorta or the RCA, we had to use this guiding caster. So the FFR value was like this. So there is a rather big jump up with the proximal part of the RCA lesion. So we treated this lesion first. So we placed the stent, and after the stent, we could see the very good result. But the FFR value was lower than the previous, so 0.66. So we got confused, and we wanted to do the pullback measurement, but if you see the guiding caster, if you do the pullback, maybe it's gonna just jump out of the coronary artery. So we anyway placed the second stent to the distal region, and after the stenting, the FFR value was still 0.77. So we really got confused, and we performed the pullback, and we saw there is a jump up at the exactly the ostium of the RCA. The jump up was 0.15. So we recrossed the wire, and we used a diagnostic caster to confirm what is happening at the ostium of the RCA, but we couldn't see anything from the angiogram. So we Japanese love to do the IVAS, so we checked it with IVAS. But this is the end of the stent. You might see some turbulence flow or some dissection, but we couldn't know what is causing actually. So we performed the pullback of the wire, and we saw the same jump up as the ostium of the RCA. So we anyway decided to place the stent as the ostium of the RCA. So the result is like this, but from the angiogram, you can't tell which is the previous and pre and post. But actually, the FFR value was 0.94. And this is the post IVAS. So you can see the start of the stent, and around here, the guiding caster came out a little bit, so it's very quick, but you can see the stent is sticking out of the aorta, out of the coronary arteries. So take-off message. So the advent with FFR wire using optical fiber enable us to use FFR wire as a workhorse wire. And this development of FFR wire makes it realistic for us to use already published useful data of FFR in a daily practice. Pressure wire with optical fiber promote FFR wire from diagnostic tool to monitoring and optimization tool for PCA procedure like IVAS. Thank you for your attention.
To the live case, thanks very much. We're going to move right along to Dr. Ian Gilchrist from Hershey, Pennsylvania, who's going to be talking to us about using 4 French catheters. And then after this, we have the live case from Hammersmith. But hopefully somewhere in there, there'll be time for discussion of these 3 excellent talks. Dr. Gilchrist.
Thanks a lot. Let me just get a flipper to...
How does that make you feel, hearing Dr. Johnson talk?
Do we have the title slide coming up? Any case, I'm one of the more, I'm sort of a radial nut. I've been doing radials now for 20 years, and I got interested in coronary physiology and went to a couple courses. I went to the one at Imperial College they put on, and I just noticed like everyone was in the groin, and I'm thinking that here they are trying to do optimal treatment for the patient, but what are they doing down there in the groin there? And thought maybe we should talk a little bit more about how we can do this better. In any case, I was assigned the topic FFR use for French catheters, can slender topics technique work here, and I stole the Japanese slender club motto there just for to make the slide look pretty. In any case, for French feasibility, we had looked at 4 Frenches in our, we have a mechanical heart group, and they have engineers in that work with our artificial hearts. And we had them look at some of the catheters that are available out there. And it appeared that compared to a Millar catheter, which is in yellow, which is an electronic catheter, 7 French, all the way down the 4 French catheters made by Aero all seem to have fairly good fidelity with a pop test, or this is in our pulse duplicator, which is a machine that tries to make a regular pulse waveform. And so we felt our 4 French catheters were pretty much as good as regular catheters, at least in ideal situations for regular hemodynamics. So we had a little bit of background information on 4 French. We were also using 4 French in the wrist. So our interest in 4 French was that our standard diagnostic catheterization would be with 4 French catheters either through the groin or through the wrist, and we use 4 French right heart catheters up the arm if we needed a right heart catheter. So in any case, when you look at the 4 French catheter, the area of that's about 3.1 millimeters squared, and then when you throw in an 014 wire, the area of the 014 wire really isn't that great in a cross-sectional viewpoint. So let's talk about taking it down a notch or going down to a lower French size, and I'll give this clinical case here. 50-year-old woman with recurrent atypical chest pain. We sometimes get younger women in our cath lab. Not all of ours are like in Canada, where they seem to be in their 80s now. In any case, she'd had a stent placed via her left radial artery at another institution a year prior. She had now an equivocal stress test, and she was a small, light-framed woman, and she had her radial done a year prior in another hospital and definitely wanted the wrist approach again. And that's why she came to see me. I didn't know why they used the left radial. I just figured they liked the left radial, so I went right radial. And so the plan was to go right radial, 5 French sheaths, because I have an option then for an intervention if needed. In the U.S., you can do interventions at 5 French. We don't have 4 French interventional catheters. So I put in the sheath, and immediately the .035 wire stopped at the sheath when I tried to put the wire up to pass our angiographic catheters up. And so we took an angiogram, and lo and behold, you've got this radial artery that doesn't stop at the elbow. It just goes and it goes and it goes. So now I got a problem. This is 5 French. Let me go back. 5 French. Okay, moving on. So we then switch out to 4 Frenches. 4 French diagnostic catheter. And if I can get this to work. We're not going to get those to work.
Can you maybe try clicking on his movies for him and see if it plays from the back bench?
I don't know how to. Can you click on the movie on the right side of the screen? We can do a. All right. Well, in any case, we'll move on because I can show you the still frame next. You guys don't have to fool with that anymore. Okay, there's those. Trust me that the picture on the right, the left coronary artery looks normal, and the right coronary artery, right where this is going to point out, there's some people in the room were saying it's looking hazy. Some people weren't sure what it was, but there was this thing that looked a little funny in the stent, and no one was quite sure what to do. Okay, the options now. I got a lady with a little tiny thready high radial artery on the right arm. You know, she's come to me. She wants to be done from the wrist. I never pulled her pants down. My patients come to the cath lab with their pants still on, so we didn't want to necessarily disrupt all the gowns. Contralateral radial, go over there where the guys at another institution already gone, or maybe even do the ulnar like some of our friends in the audience here might already be in. But in any case, we didn't do that. We went ahead and I put a 4 French multi-purpose diagnostic catheter in, and I tried a variety of things, but couldn't get the FFR to drop anywhere near ischemic. We used a nipride to vasodilate her. Back then, our nipride was $1 for a vial. Under the beautiful U.S. system now, that's $800 because some company found it was the only manufacturer and jacked up the price 800 times. So in other words, we were able to, with the diagnostic catheters, get this lady done, quickly identify that this was not a region of problem, and move her on and tell her that everything was okay. Now, just to make FFR easy, we basically have a coronary artery, which is pretty crudely drawn there, and we have a catheter, and then you have a hydrostatic transducer attached to that catheter that goes to a computer. And then you have your FFR wire hooked up to electronic transducer. And then as far as the keys to getting it done right, as we'd heard already this morning, we want the wire normalized, calibrated, and positioned in the right spot. You want a well-flushed catheter, and you want to make sure there's no catheter damping. And with 4 French, with a smaller lumen, you have a lot less tolerance for error in this. And you want a clean signal. So let's look at the effect of the guiding catheters on different coronary ostia. We saw this slide earlier today, and this slide earlier showed the 5 French, 6 French, and 7 French. But if you throw in the 4 French, you get even a smaller catheter, and even less concern to worry about, are you going to get caught up in a lesion in the left main? So that's very promising for a 4 French catheter to actually improve your abilities to accurately measure things. And then we talked about the areas, what happens when you stick a wire in there. And then if you actually blow your 4 French catheter up and try to put the appropriate size 0.014 wire in it, that's sort of what it looks like. So there's not a whole lot of the lumen blocked by that 0.041 inch wire. There it goes. Now, there are some other things we need to worry about, though, as we start getting smaller and smaller catheters. And one of the things is in a in a lumen like this, there is an ideal pressure wave going down it. And when you throw in a wire, you now theoretically start getting more complicated waves going down. And then as the lumen gets smaller and smaller, and you're having less room between the wire and the walls, things start to potentially become less ideal. So let's say your wire is banging from one wall to the other wall. Throw in some little thrombus on that wire. Throw in a little contrast into that lumen too. And if you have a narrower and narrower lumen, there may be problems with the pulse waveform. So in other words, as you go down the 4 French and potentially 3 French, you will need to be very fastidious in how you keep those lumens flush, keep your wires in good shape. 4 French catheters, and this is from my US experience. I'm sure our Japanese colleagues can show us catheters that are almost invisible that work perfectly, but we don't get those in the United States. In the United States, we only have diagnostic catheters in 4 French. You can't go directly to do a PCI if needed. If you're going to do this in the United States or without an interventional catheter, you're going to have to feel comfortable that this patient isn't one that's going to need an acute PCI. And the interesting thing about the inside of a diagnostic catheter is they can be kind of gritty. You put an interventional wire down there, and you sometimes feel this resistance. And someone told me that the inside of a diagnostic catheter isn't polished or isn't as smooth as an interventional catheter, and perhaps less thought has been given by industry on how to coat the inside of that because they never expected anything other than iodinated contrast to go through that. But there is a funny feeling to the wire going down with some brands that you just have to keep in mind. There's nothing wrong with the system. It's just that's the way it feels right now. And then the thermal stability of at least the 4 French diagnostics we have in the U.S. is pretty poor. The diagnostics start to turn into the pasta on the bottom there after it's been cooked. And so you want to use a fresh catheter, not a catheter that's been sitting in the body for 20 minutes while you thought and argued about whether to do an FFR or not on that lesion. So the FFR technique for 4 French, and again, you got to be cautious with all this. You got to do it well. It's going to be less forgiving than the large French. You want to use a fresh catheter. You're going to do it. Put the nice new catheter in there, all ready with your FFR wire, and go for it. Don't sit around, talking to all your friends and paging everyone to come down and look at this. You want to use meticulous FFR or IFR technique. I happen to like IFR. Something just died. You have a lot less room theoretically for error in your technique. You want to confirm the lumen's well flushed, the transducer of the catheter is not damped, and you need to consider that you don't have immediate interventional capacity. You will have to switch out if you want to do it, so that it's probably best done on lesions that you're sort of guessing aren't significant, but you really want to prove it, unless you have a way to salvage yourself. Clearly, in a chronic ischemic situation, that's usually not a problem, but it's probably not a good technique to use in someone who you think has acute coronary syndrome. Improvements are definitely needed. We need a better understanding of the wire and internal catheter interface. They need improvement in the designs of these things. One thought I had was if they had a 4 French catheter with actually the electronic device embedded right near the tip of the thing, so you wouldn't even have to worry about the hydrostatic column. You could just have a wire embedded near the tip of your catheter and move right on. The potential, if you put smaller transducers on, would be a lot smaller angiographic catheters, and if you have high enough pressure injectors, you could get your contrast in and get your measurements if you were using some of these newer electronic devices that could be implanted on the tips. And ideally, I think the goal for radial artery is to use the smallest diameter catheter that you need for the job at hand. Clearly, you can put 7 and 8 French catheters into radial arteries if you really need to, but your chances of having a radial artery available the next time around is markedly reduced. And if you're doing something like what I showed on that first case, which was just to show this lady that the artery was okay and everything was fine, we got away there in a high radial, accessory radial that would only take a 4 French system and got everything taken care of for her. So with that, and hopefully we have enough time to get the live case, I'd like to thank you. I'm from Hershey, which is the home of the Hershey Kisses. I don't know whether you guys get them over here, but there's certainly a lot in the U.S. Thank you very much.
All right, we're going to move on to the live case, and I'm sure some of these points will come up for discussion that we just talked about by our speakers. I've had the thumbs up, which means I think we're going to go live to the Hammersmith in London, and we'll see if we have audio contact. Good morning. Good morning, Imperial. We hear you loud and clear. Nils Johnson here with the rest of the panel and the audience for the FFR course in Budapest.
Great. Well, thanks very much, and welcome to all of you from London. My name's Justin Davis. I'm one of the interventional cardiologists here at Imperial College in London. I'm joined this morning by Rasha Alami and Rafi Kaprulian, two of my colleagues here in London. And it's a pleasure to be bringing you a live case demonstration from our centre here today. I think we've got about 30 minutes today with you, so it's quite a short live case, but first off, Rash is going to describe the case, and then we're going to hear from Rafi what we found with the diagnostic images today. So, Rasha.
Thanks very much, Justin. So today we have the case of a 45-year-old male who presented to us back in July with an inferior posterior ST elevation MI at that stage. He had primary PCI to the right coronary artery at that time and had no risk factors for coronary artery disease, but was found at that stage to have residual circumflex and LAD disease and has subsequently been seen in clinic and is describing exertional breathlessness. So we've decided to bring him back today for further evaluation of the residual disease that was left alone at the last angiogram. If we go on now, just to show you his angiographic findings. So essentially he has, you'll see the angiogram, he had originally an occluded right coronary artery, which was stented with a 3x18 drug-eluting stent and post-dilated to 3.5 with good result. But he had residual disease, as you can see in the LAD. He had a very long segment of moderate disease within the proximal and mid-LAD, and perhaps a more focal lesion more distally. And also in the circumflex here, we can see a severe stenosis at the bifurcation of the AV circumflex and OM1 branch, and more diffuse distal disease. If we go on, we can see the LAD pictures too. So hopefully you can appreciate that moderate, very long segment of disease in the proximal and mid-LAD with perhaps a muscle bridge in the mid-LAD and a more severe tight stenosis as the LAD becomes smaller, more distally. And then if we go on, we can also just show you the results that he had from his stenting to the right coronary artery, which was very good last time. So we know that he now has good LV function, although he has inferior and basal hypokinesia. And our strategy today was to perform physiological assessment using IFR co-registration of the LAD and circumflex with any further intervention as necessary. And obviously the clinical indication was exertional dyspnea in the context of residual LAD and circumflex disease. So we've repeated the images today, and I think Rafi's going to talk us through those.
Can we have, are these the images today?
Yeah.
Yeah. So we've gone for we've approached this via the left radial artery today because the pulse on the right side was very weak or almost impalpable, really. So we put a 6 French sheath and taken some diagnostic images. This is the result from the right coronary artery. You can see that the stent, which is in the sort of distal part, is widely patent. There's sort of mild atheromatous diffuse disease in the proximal third of that vessel. Go to the next view. Next one. You see it in a different view. So we're essentially unchanged. And then we've taken some pictures of the left coronary artery with an EBU guide cath, given a reasonable dose of nitrates, like 300 micrograms here. And we can see that there is quite diffuse disease in the circumflex in these views. especially near the bifurcation with the OM1, and then there's further disease in the AV circ, which then bifurcates into two fairly small distal vessels. The LAD, you can see from that first views, is really only normal in its first centimetre, in my opinion. After that, there's diffuse disease all the way down. The muscle bridge is less obvious, but is there in mid-vessel. And then there is perhaps a more focal stenosis distally, but I would say that the whole of that vessel is diffuse disease. You can see there are two small diagonals. The first one has a severe stenosis, but really it's only a small vessel, and don't think that's relevant. So I think what we were planning to do today is to make a physiological assessment of all these branches, so the LAD, the marginal branch of the circumflex, and the AV circumflex as well. And we were going to use our system, which has recently been upgraded to show some co-registration with angiogram and IFR measurements. So then if Justin wants to say something about that.
So did all of that come across loud and clear, guys? You can hear us fine?
Absolutely, and I think I'll just pause for a moment, because I think it's a wonderful case and really is one that's very timely. There's a lot of interest in what to do with non-culprit lesions in STEMI, and I'm just going to take an informal quick poll of the room here. It's obvious that everyone's hospital almost have a slightly different strategy. We'll ask Imperials for theirs in a moment. How many of you, when you discover what you're considering is a significant non-culprit disease, do an FFR measurement during the STEMI procedure itself? Is anyone actually doing that live after you've stented the culprit? All right, we have one or two hands up. What about a routine post-procedural stress test? That is, they finish their STEMI either during hospitalization or after hospitalization, soon after doing routine stress. All right, two hands up in the room. A few hands are also coming up as well. What about simply having the patient come back to clinic in a few weeks and evaluating for symptoms at that point, which it sounds like was the strategy that was taken here? All right, so we have, that's kind of a few more group there. So I would say that the top two strategies seem to be clinical evaluation, as happened in this case, followed by doing a routine type of stress testing. Very few people, and how many people are doing immediate PCI of the non-culprit? So how many people believe, I'm sure Colin Berry is here raising his hand somewhere. So it seems like those strategies of doing immediate FFR, immediate PCI right on the table are infrequent. What's your strategy at Imperial, Justin?
So usually we do pretty much what we've done today. So we'll treat the culprit vessel unless the patient's in cardiogenic shock, and then we'll bring the patient back for physiological assessment usually. In some patients who are unkeen on coming back for physiological assessment, we'll perform a stress test in the community, for which for us our service we usually offer is stress echo. So that's the kind of normal route here. This gentleman, as Rashi says, still has some exertional symptoms, and obviously the right coronary artery looks good, and it's essentially just that residual disease we're going to assess today with the pressure wire.
All right, show us how.
Great. So with all of these measurements, I think the most important thing you do is just to take a little bit of time before you start your measurements to ensure that you've got everything in place to make an accurate recording. And so we look at these as several steps which you need to take. So we have some slides which will just help you go through that. And one of the first things that we're going to want to measure is to make sure that our pressure wire console, whichever system you're using, is talking to the hemo system on the table. So that we have to make sure that we have a 0 of our PA signal. So if you can just open the patient to air here. So we open on the table, so of course we're zeroing. Now you can see there's an offset here. We haven't taken any measurements. We deliberately left this offset here. And we go to the hemo system and also our volcano console, and we zero the PA. Okay, so now they've both been zeroed. So essentially we know that when we make a measurement on the table using our pressure wire and we normalize to the table, that all the signals are effectively nicely calibrated, so we're getting a genuine value. Now sometimes, of course, this can be offset by quite a bit, and that can lead to erroneous measurements. Okay, that's a step I'd always make sure, and I'd always encourage you to do in your lab as well. That's great. So we open back to air again, open to the patient again, that'd be fantastic. So we can see the pressure traces again. The next thing we'll do, we're using the Volcano Verata pressure wire today, which is one of the latest generation pressure wires. We've unpacked it just to save time here. Then there's three main steps you have to do with this wire, and any wire I'd encourage you to do is firstly to flush, and this is just saline. I'm going to flush this. This is important as it activates the sensor and ensures there's no little micro bubbles on there which can cause some early drift in some systems. The next thing I'm going to do, just all while this wire is still in the package sitting on the table, is I'm going to remove the connector cable, and I'm going to hand this to our team here, who are just going to plug this in to the console. And if we go live to the console screenshot now, we can see when we're doing that, as we plug it in, you'll see on the physiology screen that it says waiting for 0. We leave everything on the table, haven't touched anything. We don't want to cause any disturbance or noise which could cause artifactual interference with the signal. This takes a few seconds only. Once it's zeroed, we're ready to go. So you see I'm just leaving everything here, stay nice and stable, and this will come.
What's going on with the aortic signal there?
I'm not sure.
We'll just see. We'll just check that for you. So whilst Rafi looks at the aortic signal and deals with that, we will just, you see that now that the wire's been normalized. I think he just needed to adjust the guide catheter position there very slightly. Wire's been normalized, and essentially now we are ready to do the third phase here, which is just to lift this little flap up, and in this wire we just pull out the pressure wire, and we going to coil this up and just hand it to our operator.
Fantastic.
So just coiling that up nicely for Rafi. So this wire we've got here comes without any preformed bend on it. So you can see if you just focus in on my hand, you'll see that the wire is absolutely straight. And you can see here, this gives us the opportunity, every operator is different, to put their own shape on, and it may differ, of course, with the vessel you want to interrogate. So Rafi, I'll hand that to you.
Thanks, Raj.
Okay. And there's a little talker which comes on this wire as well, which you can then use, of course, to make it easier to manipulate the wire down the vessel. So whilst Rafi's doing that, and we're shaping the wire, we essentially have given some nitrates to this patient already, so 300 micrograms of intracoronary nitrates. This is important, and as it ensures that there's no spasm in the artery, to ensure that when we're making measurements, we're looking at genuine stenoses rather than looking at the effect of the wire or contrast or irritation from the guiding catheter itself. So they've gone in, essentially made sure we've got a nicely dilated artery. Next thing you see Rafi doing, if we go to the angio screen now, is you see that he's put a bend on the wire, you can see that, and he's going in through the guiding catheter, and he's now going to start to enter the coronary artery, and you'll see that there's a radiopaque segment of wire which is about 3 centimeters long, and that's visually more apparent on the angiogram. And then just at the end of that, where it joins the more normal segment of wire, you'll see that there is the sensor, and he's now positioned that just at the exit of the guiding catheter. So Rafi, you in a good position there?
I think so. I'm just going to remove the introduce a needle.
Yeah, so our standard approach here.
That will make a slight subtle difference
Yep.
to the pressure that measured.
Yeah.
So we're just trying to do that.
Okay. So we always remove the needle introducer whenever we're doing normalization or making our measurements, even when you're doing a pullback, and it's just to be very constant, and it means that everyone in the lab doing measurements are always working from the same standard. You may differ in your lab, and of course there are different approaches to this, but this is just the approach that we use. When Rafi's happy, he's just positioned the wire and the whole housing of the guide catheter and the connector there on the table, and it's now going to essentially go to the normalization mode. So if we can normalize there. That's fantastic. It takes only a few beats to do. And now what we always do routinely, and I'd recommend that you do this as well, is go to the FFR mode of the console. Here we've got FR and IFR mode on this console, and we just record a few beats. Now we record this because if we want to come back and look at the data, make sure that the operator is normalized and we can really trust the physiology value, it's nice to see this. So if we just stop there, that's fine. A few beats is enough. You see the normalization looks great, and we're happy to go here. So if we go to the IFR mode and we go live again, that would be super. So I'm not sure if anyone would do anything differently, Nils or anyone else on the panel, to what we've done, or any other recommendations you'd make.
No, I think that's fairly standard. I'm just going to again poll the audience. How many people leave the needle introducer in when you're equalizing?
Should we carry on?
All right. Actually, I see 0 hands up. So it sounds like everyone is removing it just as you are.
Okay, just go for it.
Great. I think that's a good standard approach, and I think probably some of them have read publications out there which show that if you leave it in, you can get a reduction in the pressure gradient, and of course there's always the possibility the wire can slip more easily. So Rafi's done a really good job here. He's wired this LED, although it's diffusely diseased. You can see he's got the wire down there. We always advance it to the distal end of the vessel, and from a physics perspective, you need to make sure that you're at least 3 diameter widths beyond the stenosis to ensure that turbulence has settled down. Otherwise, you could just be measuring the effect of turbulence caused by a physiological stenosis. So here you see, in this case, that the IFR here is likely to be negative 0.94, and we're just going to go ahead and firstly make a recording. And you can see 0.93. Let's make one other recording there. Go back to live. And hit record again, please. And that's great. So in this case, you can see that we're above the 0.9 IFR threshold, which is what we use routinely in our lab. And what we'll now go ahead to do is just to show you, in this case, how we use this to co-register the angiogram image with the physiology. So it's pretty straightforward to do this. So all we do is we go to the fluoro record mode, and Rafi's going to go to, can we switch over to the Sync Vision screen, please, guys, so everyone can see that? That's super. Fluoro record mode. Rafi's going to just start fluoroing for us, and we just
ready to go?
Yes, please. And that's great. And now if you hit the pullback. And hit pullback on the console, that's great. And you'll see all Rafi's doing is very slowly pulling back the wire. The needle introducer is still out, so the torquer is not the torquer. The O-ring has been tightened up, and he's just pulling back very, very gently on this wire, typically at about 2 millimeters a second. So a typical rate you'd pull back a pressure wire or an IVUS catheter. There's not going to be much gradient in this vessel. You know that because you see that the physiology was very mild towards the end of the vessel, and you see he's just pulling back very gradually until he gets all the way back to the ostium of the guiding catheter. And when he gets there, we'll show you what we do then to make the next step, which is the co-registration.
I just see a slightly different color on the top screen.
Yeah.
One's blue, and then there's kind of what looks to be a yellow and red dash segment. Can you tell us what that means?
Stop the pullback, please, guys. Yeah, so you get that, Nils, occasionally if the system detects an errant pressure beat. So if you look here, and just let Rafi take that image, if you look on your pressure curves, you see in the middle here, there's a beat here where there's just been a bit of noise and a bit of artifact. We'll have a more detailed look at that in a second once we've done this co-registration phase. I'm just going to show you through how we walk through this. Very, very straightforward, very easily. I'm operating all of this from just a little joystick underneath the drapes on the table. First thing I'm going to do here is just going to outline our vessel, which you see outlined there very nicely. It asks us to just click on the vessel in firstly the catheter, then the vessel, then the distal position in the artery. This process is going to become fully automated very, very shortly. I'm just going to make a very small correction to the wire position here, just to make it easier for the computer to track where we're going. Just pull that down. Very simple and easy to do. I OK it, and then it starts to do the co-registration process. And here we go. Not surprising, in this case here, you see an angiogram image. You see the pressure wire pullback. You see on the angiogram image in near real time here a series of dots. Each of these dots represents a unit of IFR loss. We knew this was not going to be a lot of pressure loss here. In fact, all this shows us as we go down along the length of this vessel is this is just very diffusely diseased. We hopefully will show you in a second when we do this with the circumflex or the marginal branch that you'll see a whole stack of these dots when we come to an area of very focal energy loss, which can really help to guide therapy. But you'll begin to see how this really starts to change our practice just looking here, and I'll let Rafi get on and start with the circumflex. I'll show you as I go up and down this vessel, I can now click anywhere on this vessel. We see on that pullback where we are, we see the location. We can do all kinds of great things here where we can measure the length, because this is all co-registered precisely with the actual length itself. So we know in this area that will be a 17 millimeter stent. And we can again fade all the way back along the length of this vessel to link up for the first time accurately and very easily the angiography with the physiology. So it makes life for us interventionalists much easier to know where to deploy the stent and potentially where we can get a big improvement in physiology by placing individual stents.
As you're doing this and doing the pullback of the wire, is there anything you need to watch for technically, like not panning the table, not injecting contrast? Walk us through some of those things, just to the process.
That's a great point, Nils. So with all of these co-registration techniques, and it's a pretty standard approach here, you'll see that we don't move the table at all. So the table is absolutely steady. You find a good position, and then you leave it there. And you leave it there until after you've taken your shot as well with the contrast. With IFR, if you're measuring a PDPA, whatever you're measuring, you don't want to be giving contrast as you do your pullback as well. That doesn't make a nice curve anyway, because essentially you're going to lose your PA signal as you're doing your injections. But over and above that, of course, it will cause some mild hyperemia as well. So those are the things. The very unique thing about this system is you'll see most of the other co-registered systems out there. So you may have seen these on-table ones, or even some of the offline systems involve you having to take two orthogonal views. Now this takes a completely different approach. You'll see one view, you've seen exactly what we've done to perform this, and what it actually does is a very clever system whereby it looks at the actual radiopaque segment of the wire, and it triangulates that as it comes back through the length of the vessel to see how that changes in shape and length. So it knows exactly how far it's coming back, so it can get a distance in conjunction with co-registering the pressure measurements on the physiology location of where it is in that vessel. So it's a different approach.
Frame rate that you need to pull back at?
The manufacturers recommend 12 frames a second, but you'll see on our table here today we use 7.5. So that's our normal frame rate. That's what we use conventionally in the lab just for our kind of X-ray safety in inverted commas to reduce the X-ray dose for all of us and for patients, and it seems to work fine. Get the engineers here; they'll always say, "Oh, increase it to 12," but in practice and reality, things work very well on 7.5.
Looks like guys, we'll just have a look at the physiology
screen so we can check our normalization.
So if you can flick back to the physiology screen outside, that we're just going to check our normalization again. We do this as standard of practice. You can open. That's fine. Yeah, it's great. Okay, and
we have some.
So just reattach that brush. We're just going to reattach the wire there to the connector, and
just wipe it.
Now for this one, the attachment is a little bit different than some of the other manufacturers. Can you maybe just zoom in and show us what you're doing there, Rashmi, for the attachment component, since it works a little different among manufacturers?
So obviously we've seen that the connection, there was a problem with the connection, so I've taken out the wire tip and I've basically wiped it with a wet swab, and then I've dried it, and now all you need to do is place the wire inside the port, and what they say is to drag and drop, so you feel a click. And then at this point it should be working, but there seems to be potentially a problem with the wire. So we may just need to take another pressure wire just to...
Yeah, if we can just grab another pressure wire. So I think
maybe while you're grabbing that second pressure wire, if you could just zoom up on that and show us all once again the disconnect and reconnect as you're taking the second wire there.
So essentially I pull back, I slide back the grey section of the connector, take out the wire, you should be able to see that, and then essentially you insert the distal tip into the port and you drag until you feel it catch, essentially, and then you should, once you close the port, be able to see the wire connection. But it's there's obviously a problem with this wire, so we will just swap to another wire.
Can you show us, does it give you an error message on the console just so people can see what it
says,
looks like if the connection isn't good? Can you flip to that screen?
It says attach wire connector, so it's essentially not seeing the wire connector. Unfortunately, you can't see that now because what we've done is very quickly, swiftly move to another wire. So we're now waiting for the second wire to 0.
So we're all done here. Let's get this out. Yeah, I think Nils, is a good question. So I think there the clues, we thought there's something a bit funny going on. It doesn't happen often, but if it does, and you get no signal, I'll just change straight away because it saves us a lot of time in the long run. Is that we just had a almost flat line of our pressure signal, and which told us that something went wrong in terms of a connection somewhere along the length of the wire.
Justin, Olivier speaking. I mean, that's very interesting because, I mean, we had a case from Bernard this morning, and it's very glad that you show real life. And Bernard, had to fight quite a bit to succeed to use the one different wire to go in the LED after going into the circ, and it was a good example to show sometimes you have, to have a different mindset. You want to do physiology and you spend some time. So I just ask you the same question. How often do you have like that kind of technical failure and you need to replace the wire?
So I think pressure wire drift of more than 2 millimeter mercury now is very infrequent. These wires, probably less than 1 in 20 wires. A major failure like that probably is 1 in 50. So I think there's been a considerable improvement. But you'll see our approach here is really, and this is not just for live cases, if there's a significant problem with drift on any wire, or you have a problem where it's clearly not connecting properly, we just change the wire straight away. You return it to the manufacturer. They're always very good at sorting out and examining what the cause was. But in these cases where there's an electrical issue, then you just have to change. The patient comes first, and you have to make sure that the measurement you're making is accurate.
Excellent.
Yeah. So Rafi's popped that back in, and basically in the same position, Rafi, is that right?
Yeah, and we just need to normalise again.
We'll just normalise now.
Let's come back a little bit. He's coming in and out with his rest.
So another thing I'll just, while Rafi's doing that, and we can go ahead and normalise when he's ready, is often you see with any of these wires, if there's a problem, often there's a big offset between the PA and PD signal right from when you first introduce it into the patient. You can see here there's almost no offset, and this means that it's very likely that we'll have no problems with this wire at all.
And that's a good point, and I think that the St. Jude system, as I recall, won't even let you equalize if it's greater than 30 millimeters of mercury. But really, if you have differences that are that large, you need to troubleshoot your pressure system anyway. So in a way, it's trying to prevent you from doing something you probably wouldn't want to do anyway. That should be a red flag that something is going on.
Absolutely right. Absolutely right. I mean, there's something funny going on, because in the lab where these devices are made, they're actually all calibrated, so there should be almost zero offset when you put them into the table. So if something funny is happening, there's something that you've got to troubleshoot, as Neil said. Absolutely correct.
And I remember a very memorable case where we troubleshooted everything, and it ended up being that the piezoelectric crystal that you use on the manifold to transduce the pressure during the case had become faulty. And so sometimes you need to really be systematic about backing up. Is it the wire? Is it the guide? Is it the connection? Is it the manifold? Is it the pressure connections on the table to troubleshoot those ones? But it looks like you're in position now and ready to show us the circumflex.
Yeah. So this is another pitfall, which I think has just happened by mistake, and it's again good of one of our team to spot this, is when the wire went distal, that the normalize button was pushed. So what's happened is now it's normalized distally to where we should be making the measurement. And of course, if we made the measurement there, you'd be making an erroneously high measurement, and you bring it back here, and no surprise, it's got offset by the amount of the effect of the stenosis in the downstream vessel. So we'll just very quickly normalize here again.
Normalize again, please. Let me just. Okay, let's normalize there.
So I think with everything physiology or anything in the cathlab, you've always got to have kind of eagle eyes for any potential pitfalls and errors that you could have. And we've done it now. And so now Rafi can go back down.
And so the visual clue that tipped you off that you needed to pull back and re-equalize, can you just repeat that again for everyone?
Unfortunately, at the bottom of the screen, it said normalized. So there was a message which came at the bottom, which normally only comes when you push the button, and also, of course, the pressure waveforms looked almost superimposed upon one another. So it's something which you must always just keep your eye out for, just in case that happens. Doesn't happen often, of course, but that's okay.
No, the ports was closed.
Okay, so Rafi's just easing back the needle introducer, and you can see there is a small gradient there, but nothing much. We'll just go ahead and make a measurement there. So if you can press the record button. Thank you.
Justin, once you've done the measurement, could you just give some contrast to show the audience exactly which vessel you're in?
Yes, no problem. So if you just go to the angiogram screen, and let's just go give some contrast. There we go. Okay.
I'm going to exaggerate the IFR for a few seconds.
There we go. So you can be very careful with interpreting that IFR number there, because although it's gone a lot lower, remember that if you give adenosine with IFR, the equivalent of an FFR cut point of 0.80 is about 0.66 with IFR, because you're just looking at this diastolic phase where the flow is highest. If you see there, I think the PDPA ratio then went down to about 0.86, 0.87, which is consistent with the IFR.
Yes, it looked as if there was a much larger gradient. I would say, yeah, the contrast FFR looked to me to be about 0.85 or so when you did that little injection.
Exactly right, yes. So I think both of these, the contrast, I think Neil's correct me, is 0.83, is that correct, the cut point for positivity?
Yeah, somewhere between 8.3 and 8.5.
Yeah. So it looks like both of these values are negative. Rafi, are you planning to go to one of the other branches as well?
I was going to go to the OM as well.
Yeah. So Niels, if you have to give people a single cut point to recommend for the contrast, so some of our colleagues are interested in looking at this. What's the single number you'd go for? Is it 0.83 or 0.85 or what's the number? I know you've published in this area.
Yeah, it's a great question, and again, we're going to talk about this afternoon. Sorry, before we get to that, there's a question from the audience. I want to make sure we get to this. Please, sir. Do you have a microphone? If you could pass him one, please, then that way everyone, including Imperial, can hear his question.
Thank you very much. Stefan Hab from Austria. Hi, Justin. I just want to use the opportunity. You have a very special case here. You have a lot of distal disease. You have side branches that are diseased. What I wanted to ask you is, in this case, would it be closer to the truth to look at the FFR or at the IFR?
Well, I think remember that the FFR and IFR are going to give you subtly different information. It's a really interesting thing, that for many years, 15, 20 years, there's been this big debate between flow and FFR. And all around the world, the different groups have competed for what's most accurate. And what IFR is doing, we know from the data, and there's many data sets out there now, including the AimRADIAL data set, which is the largest collection of human pressure and flow data is there. It shows that we can make these resting measurements with the IFR, which is more closely aligned with flow. So I think you're going to always see some differences between IFR and FFR. In terms of why the values do differ subtly. Now, when it comes to distal disease and when you have sequential lesions along the length of the vessel, this is where you start to get differences between the IFR and FFR. And I think this has been well published and well publicized, the fact that if you have sequential tandem lesions with FFR, that it can be very problematic. And this is because flow with stenosis severity is not linear like it is under resting conditions, but there's a parabolic curve there. So I think that's certainly a problem which we may encounter, and a difference you may see between the IFR and FFR. Certainly another thing, we've seen some of the exciting data from Syntax 2 looking at this, which of course Syntax 2 data was very, very supportive for physiology, IVCs and modern stents. 80% of all cases were just IFR in Syntax 2. And of course, a lot of these multi-vessel cases, there's a lot of collateral branches. There's some very exciting data coming out, which very much looks like if you have a collateral branch going between two vessels, that it's likely that it's very difficult for using FFR on its own to distinguish between the donor and the actual vessel you're measuring in. So actually, if you have a heavily diseased right coronary artery and you have a mildly diseased LAD and there's a collateral there, the LAD will often be positive. If you then go and treat the right coronary artery, it then becomes negative. And that's obviously a bigger problem if you're inducing hyperemia. The ventricle is getting very excited.
If I could just, sorry, I think we've lost your volume. I want to pause before you do too much more speaking. Okay, we've got it back. Please go ahead, Justin.
So obviously the effect of collaterals and you inducing these crosstalk between different vascular beds is much bigger if you're using hyperemic conditions. Under resting conditions, of course, you're not inducing that big collateral response, and as a result, you tend to interrogate the epicardial artery more individually than looking at the whole vascular bed. But they both give you different bits of information, and that's how I really look at this. There's all parts of the puzzle that you could be looking at. In this case here, it's clear that the gentleman came in with an occluded right coronary artery which got fixed. He's got lots of diffuse disease. We know from the work of Nils and lots of collaborators around the world that really what makes a difference in terms of outcomes is having very, very significant FFR, IFR values, so down as low as 0.66. So you can clearly see in this case here that the values are well away from this. They're very, very normal in terms of physiology. And the one way I like to think about this is if you were to put a stent into any of these cases and you're actually measuring the flow, the actual improvement in physiology would be absolutely tiny, really, really tiny. And you'd be replacing one disease state, so the atherosclerosis, with another, which is a lump of metal in the artery.
So I think we're going to soon pause here and break for lunch, but I just want to conclude this case because it looks like you finished with the circumflex measurement. So just to summarize then, the patient presented a little while ago with an RCA STEMI, was stented, had symptoms in clinic and returned for physiologic evaluation, and you made resting measurements in the LAD and circumflex and have decided then to continue just medical treatment alone without further vascularization. Is that correct?
Correct.
That's absolutely correct. And I mean, we've made many of these measurements over the last 3 or 4 years. In fact, Rafi is probably the world's leading authority on making these measurements. He has a very high case volume and has made several hundred of these. We'll be showing more of the cases at the TCT meeting in the live cases on November the 2nd, where we'll be showcasing 4 patients, hopefully with similar disease, and hopefully in those cases we'll have some vessels which also need treatment as well. So hopefully you can join us for that as well.
All right, thank you for your time, Imperial. We'll give you a round of applause.
Thanks very much, everyone.
All right, we'll break for lunch. I believe we're back at 1:30 for the afternoon session. Thank you. Oh, go to the restaurant. Follow the food.
Okay, time to start the afternoon session. Please take a seat, and then we'll try to, I would say, keep on time, which is always the most difficult part of any sessions. So we're going to wrap up with Bernard De Bruyne and Alst first, and then we'll try to keep up the right timing. And Dr. Gilchrist will be the chairman of the session.
All right.
Hello, sorry, I have to become the professional cardiologist that was helping Bernard before the live case. Sorry, but Bernard is no more available here in cathlab. I would like to show you what we did. We have feedback, can you hear me? Yes.
Yes.
My FFR was 0.76 on this LED. We performed the PCI of the LED protecting the diagonal branch. We planted a 326 millimeter vessel on stent, and then this is the final result. We accepted the final result with box, and this is the FFR after the PCI. It's 0.90.
Oh, that looks excellent. That looks excellent result.
Yes.
Congratulations.
So, thank you very much, and thank you for your attention, and sorry for the absence of
No, that's excellent. Thank you very much, sir.
Thank you.
Thank you again to the whole team.
Thank you very much.
Okay, so as everyone's filtering in here, we're on the session number 3, which is going to be lessons learned from clinical trials and registries. I'm Ian Gilchrist from Hershey, Pennsylvania, and to my left, we got Olivier Bertrand, and then my pronunciation is not perfect, but
Dr. Kawazi. Dr. Kawazi.
Okay. Yeah.
And Dr. Unza.
Perfect. And we're the panelists, moderators for this afternoon session. And the first speaker that we have is Lessons from the FAME Trials, and Colin Berry.
So thank you very much for the invitation to participate in this workshop. It's been a very interesting meeting so far. So if I can have my slides, thank you. I'm happy to speak to this subject, but these are not my slides.
Despite the fact he's a radialist, he would need his real presentation. So this is the wrong presentation, please. Can you update?
They look familiar.
That gentleman knows that because I've just spent the last 10 minutes with him organizing my slides. So I'm not expecting any ambiguity about the slides I'm going to speak to. Great. Lessons from the FAME trials. So these are institutional disclosures from my employer, the University of Glasgow, with various companies. I don't hold any personal contracts. So the objectives in this talk are to review the evidence from the FAME and FAME2 trials, to consider the practice guidelines which are informed dominantly by these two trials, and of course there are other contributors. And in that regard, those are the lessons. So I'm not going to give you personal lessons on my take on the trials. Rather, I'm going to give you the accepted wisdom, and we're happy to talk about personal insights at the end. So I'll take you through FAME and then FAME2. I should mention that I was not a formal investigator in these trials, but I may have participated in some studies as supported my colleague, who is Keith Oldroyd, and an investigator in FAME in Glasgow, along with Nick Curzon in Southampton, and there may be other FAME investigators in the room. So FAME involved 1,005 patients with multivessel coronary artery disease in whom PCI was intended. The patients were randomized to FFR-guided PCI or angiography-guided PCI. 1/3 of these patients had a history of medically stable acute coronary syndrome in the absence of chest symptoms for 5 days. It was mainly a stable population. First-generation drug-eluting stents were used, and the primary composite outcome was death, non-fatal myocardial infarction, or repeat revascularization at 1 year. So, in terms of the procedure-related differences, because after all the intervention is defined by the procedure, so there was no difference in procedure time, perhaps reflecting the additional time to measure FFR, because on the other hand, the impact of the FFR disclosure was to reduce the performance of PCI, and therefore contrast volume was less in the FFR group. The mean number of stents were fewer in the FFR group, and the total stent length was less, reflecting a reduction in PCI and a focus on the reduction of stenting and therefore the optimization of the stent procedure as compared with visual assessment of disease severity to inform PCI decisions. So at 1 year, the composite outcome occurred in 91 patients in the angiography group and 67 patients in the FFR group. The relative risk was reduced by FFR guidance to 0.72. But interestingly, there was an impact on death or myocardial infarction. 55 patients experienced that event in the angiography-guided group compared to the FFR group with 37, and the hazard ratio was 0.66. There was an immediate separation in this primary outcome, reflecting the reduction in PCI and therefore the reduction in PCI-related complications and MI, but there was also a progressive separation over the first 60 days, and then this difference was maintained up to 1 year. So those were the results, but how can we understand the results and the differences therein? So this is a publication, angiographic severity versus functional severity of coronary artery disease. I just noticed in the bottom flag, the FAME, it's not FAME, it's from Jack in 2010. And if I draw your attention, I wonder if this laser pointer will work. So if you look at the red line, that is on the y-axis for 0.8, so anything above the red line is non-flow limiting by FFR. And then if you look at the group categorization on the x-axis, the angiographic severity of disease is classified into 3 groups with very severe disease on the right-hand side. And you'll see that there is a discordance between the angiographic severity of disease with a large number of individuals with an FFR of less than 0.8 and yet a stenosis severity between 50 to 70%. And if we accept that the conventional criteria for obstructive disease by angiography is 70% or higher, there's clearly a discordance, and overall there was a left shift impact of FFR assessment versus the angiographic severity of disease, therefore reflecting the reduction in PCI between the two groups. I mentioned that 1/3 of the trial population had a history of medically stable acute coronary syndromes. We also know that patients with an acute coronary syndrome have a much worse longer-term prognosis compared to patients with chest pain who present with a stable coronary syndrome, stable angina. And so you see that survival free from MACE on the y-axis versus time from randomization. And now in this case, this is up to 720 days or 2 years. This was another, shall we say, post hoc analysis of the FAME trial according to ACS or stable presentation. And consistent with our understanding of prognosis in coronary disease, those patients who presented with an ACS had a much worse outcome compared to, so they are in the lower line plots or groupings compared to those with stable angina. But the FFR in the ACS patients improved their prognosis with a consistent magnitude to what is observed in those with stable angina. There was no difference apparent really in the absolute relative risk or relative risk reductions. So that indicates that the prognostic advantage of the FFR guided strategy appears to be consistent between patients with stable or an ACS presentation, albeit within this clinical trial, and of course this is a post hoc analysis. I'll come back to that point in my next talk in this session. But what about the health economic impact of an FFR guided strategy versus standard care in FAME? And there was a pre-planned health economic analysis. This is one figure from the Fearon paper in Circulation 2010. I'll talk you through this. So on the y-axis is incremental cost in dollars, and on the x-axis is incremental quality adjusted life year. So if you look at the dot plots, which are clustered in the lower right-hand quadrant, for this trial population, against, I think it was a US-based economic analysis, the FFR guided strategy was associated with a positive benefit in quality adjusted life years and negative incremental cost for FFR versus standard care. So that's all very well, clinical events at 1 year, but what about in the longer term? So the patients in FAME were followed up through to 5 years, and this data set was published in The Lancet in 2015. So again, on the y-axis is survival free from major adverse events, versus on the x-axis is the number of patients at risk in each group through to 5 years. And one could hypothesize that the avoidance of stenting at the time of the index procedure might have some early benefits, that however, the presence of coronary disease untreated by a stent, the natural history of that disease may lead to negative remodeling, and ultimately the patients have late events and that there is a catch-up, and that isn't observed here through to 5 years. So I think the 5-year analysis provides some degree of reassurance in that regard. What about subgroups? So again, this is from the Van Noonen paper, and if you look at the point estimate and the sort of y-axis north-south with FFR better versus angiography better, I'm pointing to down here just now, across a range of groups, so that's age, diabetes, presentation type, ejection fraction syntax score, and the involvement of proximal LAD or left main disease, there was no interaction, with the one caveat on sex, and there did appear to be a difference around gender, which is maybe something we would like to discuss at the end of this talk. So that was the FAME trial. It was a PCI selected population. So let's move to FAME 2. 1,220 patients who had an FFR assessment in which the FFR was less than 0.8. And the question was asked about the outcomes of patients who would be medically managed or who would receive PCI at that time. So they were randomized to a PCI strategy or not. And this was a population of patients in whom the FFR in the treated vessel was less than 0.8. 2 years follow-up, primary outcome was cardiac death, non-fatal MI or urgent revascularization. Again, this is straight from the papers. The primary endpoint, PCI, so that outcome occurred in 36 patients, or 8% in the PCI group, versus 86 patients, or 20%, so more than double, in those patients managed medically who did not receive PCI, and there was a very substantial impact on the hazard ratio in favour of performance of PCI. So that is the primary outcome, but let's look at the cumulative incidence of, in this case, so one of the components, death or myocardial infarction, and this also includes a landmark analysis where the outcomes are assessed within a period of 0 to 7 days or within a period of 8 days to 2 years. And in each case, there is a hazard ratio in favour of PCI, with a late catch-up with medical therapy. And of course, this is a component composite. What was dominating this reduction in the hazard ratio in favour of PCI was revascularizations and catch-up in revascularizations, so-called urgent revascularizations in the medically managed patients. So these are some main components of interest from FAME and FAME2, including some post-hoc analysis. I'd now like just to touch upon what is articulated in the clinical guidelines. So the ESC guidelines for stable coronary disease in 2013, so specifically referring to patients with severe angina, so class 3, or a pre-test probability of greater than 85% based on the likelihood of coronary disease from risk scores. The recommendation is to proceed directly to invasive angiography. And this, to me, makes sense. So I work in a public health system. As soon as I request a test, treadmill, stress echo, what have you, it immediately invokes weeks of delays and then potentially another outpatient appointment to discuss with the patient the non-invasive stress test result, and then a decision for invasive management or not. So in a patient who's got severe angina or a high likelihood of coronary disease, that procrastination is obviated by referral straight to the cath lab. But of course, there's a lack of knowledge about inducible ischemia, and so the guidelines state, so invasive coronary angiography with FFR when necessary, so if there's diagnostic uncertainty, is recommended for patients with severe angina with a high-risk profile, particularly if symptoms are inadequately controlled with medical therapy, and that's a class 1 level of evidence C recommendation. So I think the C relates to the fact there's only one large randomized trial, which I think is focused on the FAME trial data. Another recommendation in this guideline is in patients with stable CAD, coronary angiography should be considered for risk stratification in patients with an inconclusive diagnosis or on non-invasive testing. So quite different to the different population, and probably representing a larger proportion of the patients that we might see in our clinics. So in that setting, the FFR informed strategy has got a class 2A level of evidence C recommendation. So not such a strong recommendation as compared to those patients with severe angina. We do have data, although less complete, in patients with unstable coronary disease. So from the ESC guidelines, there are 2 statements I'd like to draw your attention to. In the interest of time, focus on the italics. So far, the value of FFR-guided PCI in this setting has not been properly addressed. And furthermore, the role of FFR testing and FFR-guided management still needs to be defined. So therefore, I've shared with you a brief summary of the FAME trial data. In summary, long-term clinical outcome data confirm the benefit of FFR-guided decision-making about revascularization with a threshold of greater than 0.8, so 0.81 or higher, is sufficient. Medical therapy is sufficient in that patient group, whereas FFR of 0.8 or less would support a decision for revascularization, but always bear in mind patient-related factors. This tenet seems to be consistent across various subgroups, perhaps with the one caveat about sex, but certainly in my clinical practice I'm not really thinking about men versus women in my decision-making in that regard. And we do have clear clinical guideline statements with level 1 evidence or level 2 recommendations of evidence for stable coronary disease and ACS respectively. And one other point I'd like to mention, I thought I might not have enough time, but I do, is about the meaning of a single FFR value, and that relates to work that Niels Johnson has done and colleagues, where looking at FFR initially in relation to longer-term prognosis, that value of FFR is prognostically significant. So lower the FFR, more the prognostic implications and disadvantage, more that patient would benefit from revascularization and relief of that stenosis as FFR is low. So with that, I'll conclude. Thank you for your attention.
Colin, I just have one question. I mean, in fact, I mean, we always learn from talks. It's the first time I get my attention caught by the sex-EP interaction. I never. Is there any? I mean, I guess there have been a lot of discussion among the high-profile academic FFR guru like you, I would say. But is there any pathophysiology, or is this something that people are just focusing on statistical, maybe nuisance or something like that?
Yeah. So I think there is some information about this in the literature separate to the FAME studies. And an explanation for why there might be differences in relation to sex and outcome, and I think the publication came from a cohort analysis from the Mayo Clinic, if you want to look for that. Potentially relates to microvascular dysfunction in women. It may be more prevalent, and of course microvascular disease is relevant for distal coronary pressure. On the other hand, thinking about FFR, the validity of an FFR value, in some senses it's whether that microvascular dysfunction is dynamic and reversible, because then the index may change according to different conditions. And a different analogy would be in unstable coronary disease. But if the microvascular dysfunction is fixed, then the FFR value is valid. So I think there is some potential explanation in relation to sex differences in microvascular disease in women, and perhaps that may explain the observed prognostic differences that were noted in FAME. But in clinical practice, I'm not really drilling into that in my decision making. I mean, I'm looking at the FFR value, I'm thinking about the symptoms and the patient, and what revascularization might do for that patient.
Because obviously this is completely counterintuitive. I mean, you always like the objective physiology to go beyond the atypical symptoms of women, and then you are stuck. So I think, are you aware of any prospective data or any studies trying to to understand better, or there is no? So
make, two other comments. So the FAME trial wasn't set up to prospectively answer a question about sex differences with FFR. When I presented the post-hoc analysis on ACS, I pointed out that that's what it is in prospective testing. So I suppose what I'm suggesting is it's an observation, it's something to have at the back of one's mind, but it is a post-hoc analysis.
Sure. Exactly.
Yeah.
Thank you. Question?
One more?
Yes, I believe so, and I believe there may be some data on that coming out in the coming years. Prof. Curzon?
So it wasn't mandated in these trials to do a post-stent FFR. It was done in a reasonably high proportion. And there's a presentation of TCT results of that post-op analysis. So it wasn't part of the randomized trial.
I understand Zolt, who is now heading to Semmelweis, will be the first author on that manuscript, so it's coming.
Okay, well, let's move on. Our next speaker is Dr. Nick Curzon, who's going to give us a talk entitled Lessons from Platform. We can get his slides up.
So thanks again for inviting me to be here. It's a pleasure to talk to you about the lessons that were learned from Platform. My conflicts of interest are that I've received grant funding and speaker fees from HeartFlow, who are responsible for the FFR CT technology used in Platform. So I think what we've established so far on today is that the addition of FFR to angiographic assessment improves diagnostic accuracy and thereby optimizes patient management and probably outcome as well for patients. And that's because hopefully you're convinced that FFR defines much better both patient level and lesion level ischemia and allows you to target treatment and in particular revascularization to people who are ischemic. But, you know, how cool would it be if we could achieve that anatomical and physiological assessment of people and define lesion level ischemia in particular non-invasively? That would be pretty cool. And I'm old enough that when I was a boy growing up, the original Star Trek series was on. And this technology really makes me think of those days when you couldn't believe that they could scan someone's body from the outside and look inside it. But now you can. Now, of course, what we already have is we have invasive ability with an angiogram to look at the anatomy. And if as we've heard, we have FFR or AFR to look at the physiology and look at identified lesion-specific targets. And the concept here is that you can do the same angiographically, non-invasively with CT angiography, and through the technology developed by HeartFlow, and it has to be said, other teams around the world, you can now estimate FFR from non-invasive CT angiographic data. So it's a bit like Star Trek. So the process is clearly one that I'm not going to understand because I'm an interventional cardiologist. How am I going to know how they do it? It brings me to a point, all joking aside, which is, why do we expect to be able to understand this? I mean, how many of you know how your car works, or your vacuum cleaner, or your mobile phone? But in principle, the way this works is a CT angiogram is done, and the data, the raw data from this, is uploaded to HeartFlow. They use a proprietary software to rebuild it into a volume-rendered, 3D reconstructed picture of the coronary circulation. And then the really clever bit is a supercomputer goes through millions of calculations, making assessments about the myocardial mass, the patient's size, the coronary volume, to come up with estimated FFR in the vessels. And that's the bit I don't understand. But what I do understand is that they've done a series of investigations over the last few years, culminating in the NXT trial, which have looked at the diagnostic accuracy of FFR-CT. Remember, it has to be in people who are suitable for a good quality CT coronary angiogram in the first place, so that's a limitation. But looking at a group of patients, all of whom had invasive angiography and invasive FFR, with which to reference the FFR-CT data. And so these levels of diagnostic performance you see on the right-hand side are referenced to invasive FFR. And this diagnostic performance is very impressive. So it's in that context that the platform study was set up and designed, for which I was the UK PI. So it's designed to test the hypothesis that patients with suspected coronary disease, evaluated using an FFR-CT type approach, would have fewer invasive angiograms that showed no significant obstructive coronary disease than would patients who are evaluated using our standard methods of evaluating patients who present to us with new stable chest pain. So it's basically a comparison between usual care and assessment and FFR-CT. So the primary endpoint was the percentage of the people who had an invasive coronary angiogram planned in whom there was no significant obstructive coronary disease found within 90 days. And the secondary endpoints were clinical outcome data. So it was done in 11 centres, 584 patients. And that's Southampton, in case you wonder where it is. So it's a complicated algorithm. Now, the design of this was non-randomized, and there are various reasons for that, I suspect. But the principle is that when the patients presented, the people who assessed them clinically decided whether they should have a non-invasive assessment or an invasive assessment. So that's dependent on local practice. In the UK, we have national guidelines with a sort of Diamond Forrester type risk assessment of patients, which directs us to either go non-invasive or invasive. So in the UK, it's relatively standardized, but around the world, I guess there are different practices. So the patients were either destined to have non-invasive stress testing or coronary angiography or CT angiography or an invasive angiogram. And once they'd been allocated to those two cohorts, they were then reallocated to either FFR-CT or to usual care. The demographics had no major differences between the groups. One of the reasons they were non-randomized is that they wanted to make it as real-world as possible. So there weren't loads and loads of people screened and then excluded because they didn't fit the inclusion criteria. So let's look at the primary endpoint, which is the percentage of people who underwent an invasive angiogram and didn't have any obstructive coronary disease. And we'll look first at the cohort who had undergone a stress imaging test first, i.e. the non-invasive cohort. And when we look at that primary endpoint, we see that there is no significant difference between the ones who had ordinary care with a stress echo or a perfusion scan and the ones who had FFR-CT as their primary test. But in the cohort who were destined to have an invasive angiogram and then either reallocated to FFR-CT or went ahead with their invasive angiogram, there was a very highly statistically significantly lower rate of finding that they had had an invasive angiogram with no obstructive coronary disease in the FFR-CT group. In fact, there were 60% less cases who had an invasive angiogram with no obstructive coronary disease if they had had FFR-CT. There was no difference in clinical events in any of the groups. So there was no price to pay for having avoided an invasive angiogram by having FFR-CT. This is the 90-day outcome. If we look at this a different way, on the y-axis we have the percentage of patients. This is for the group who were planned to have non-invasive strategy, either routine or FFR-CT. And you see that the number who had an invasive coronary angiogram in this group was relatively low, which is characteristic of all rapid access chest pain type activity. And there was no difference between the ones who were found to have obstructive coronary disease or indeed people who did have an invasive angiogram and didn't have obstructive coronary disease. So in the non-invasive group, the FFR-CT didn't show any change in rate because the rate was very low. But in the group who had been allocated by usual care to an invasive angiogram, we see that there is a very high rate in the dark on this left-hand panel. There's a very high rate of patients who turned out not to have coronary disease of any significance. And this was almost exclusively removed if they had had an FFR-CT. So there was 60% less people being put through an invasive angiogram in whom there was no obstructive coronary disease because they had had the FFR-CT assessment first. So this made a very major difference to the care pathway of these patients. So that's the number of people who didn't need an invasive angiogram at all. compared to the ones on the left who all had one. And this is the small number of people who, after they did have an invasive angiogram, didn't have any significant coronary disease. So in other words, the majority of people who had had an FFR CT and were found to have ischemia on the FFR CT and were then put forward for an invasive angiogram, the majority of them did indeed have significant coronary disease. So the conclusion from the first platform paper was that an FFR CT approach was safe and feasible as an alternative to an invasive angiogram from the first up, and was associated with a significantly lower rate of invasive angiogram yielding no significant coronary disease. Other papers have shown that well over 60% of people who are put forward for an invasive angiogram on the basis of new chest pain have no significant coronary disease. So this is a potentially very useful and powerful clinical effect. But of course, the way healthcare is at the moment, one of the things we're going to need to know is whether this is cost effective. And there was a pre-specified cost effectiveness or resource utilization model built into platform to address this question, which we published in this paper last year. So the aim was to determine the effect on cost and quality of life of using FFRCT instead of usual care to evaluate these stable patients who had suspected angina. It took into account a wide range of things, including the tablets that they had, the number of tests they had, and of course the number of trips to the cathlab that they had. And these are the results. In the ones who underwent invasive angiography, there was a significant reduction in overall costs in the group who underwent FFRCT. You would kind of predicted that from the results I've shown you from the first paper. And it's very, very significant. In the non-invasive arm, who underwent a stress test and then didn't go to the cath lab, most of them, there was no difference in cost in resource utilization. So it was cost neutral. So the conclusion was a strategy of FFRCT to evaluate patients with suspected coronary disease was associated with lower costs than a strategy of an invasive coronary angiogram and was associated with an improved quality of life in that cohort. So these data are encouraging. Subsequently, the one-year outcome data have just been published, which show a very similar thing. There is no change in these resource utilization outcomes. So if you put people through for an invasive coronary angiogram who are new chest pain patients you suspect of having significant coronary disease, it is more cost effective to do FFRCT first, with all the limitations of this kind of study. But just to remind you the real impact of this, if you follow patients at the top who had a usual care a pathway, not many of the ones who had an invasive angiogram actually had obstructive coronary disease. So that's a little bit of a waste, mainly, I suspect, for the patient's time and comfort, but also in terms of resource utilization financially for the healthcare system, compared to the bottom algorithm, where most of the people would be diverted away from the cath lab and never have to visit by avoiding needing to diagnose them as having no obstructive coronary disease in a cath lab. So this is a powerful effect, potentially. So the conclusion was in patients with stable chest pain and planned invasive angiography, care guided by FFRCT was associated with equivalent clinical outcomes and quality of life and lower costs compared to usual care. So those are the lessons from platform. So that the FFRCT in suitable patients, and I emphasize that because some people are not suitable for a CT coronary angiogram, shows a high degree of diagnostic accuracy. That was shown before platform started. That FFRCT is associated with lower rate of invasive coronary angiography, showing no obstructive lesions. So in people who you want to take to the cath lab, you will reduce the number of people going to cath lab with no significant coronary disease and a negative FFR if you do FFRCT first. That's a very attractive algorithm, both in terms of a one-stop. You see them, you do the angiogram in the CT scanner, and you know that you don't need to do anything else. But also for the patients, you avoid them needing the stress of an invasive angiogram. It's associated with lower resource utilization in people who would otherwise have had an angiogram. But it is my opinion, which isn't shared by all of the platform investigators, that this is really providing preliminary data for a properly powered randomized clinical trial to prove whether FFR versus routine care is superior or equivalent. We might be able to offer the patients a choice if it's equivalent, but if it's superior, then we may well need to change the way we work. Certainly, I'm working on a randomized trial to do exactly that, because I think it has the power to change the way that we work in these patients and provide them with a one-stop assessment of their coronary circulation, both anatomically and physiologically, even if it means that we avoid lots of them going to the cathlab who turn out to have no significant coronary disease, and we provide them with the convenience of knowing that and reassuring them without ever going to the lab. For the ones who on FFR-CT do have positive coronary disease with abnormal ischemia, then they might still have to go to the lab in the near future, especially if we think they're candidates for PCI. But one day, if you believe in Star Trek, it might be that some of them go straight for an operation and never need to go to the cath lab at all if they've got very severe coronary disease. I'm going to talk about the future of FFR-CT in my next talk. Thanks very much.
Thank you. Just a show of hands, does anyone here have FFR-CT at their institution? We have one or two. How about how idiot-proof is it to get an FFR-CT? Like, do you need special training to get the FFR portion done right? You know, we've heard this morning about how important it is in the cath lab.
I can reassure you that there are no idiots involved in that bit, because it all goes, it's sent away by a special link to heart flow, where the FFR-CT reconstruction and computer modeling is done, and they send you back the outcome. So the bit that has to be done very well, and the limitation of this, which, you know, is where Heartflow and I might stand in slightly different places on a podium, is not everyone can provide good enough, high quality enough CT angiogram data to get a robust output from this technology. But, you know, we've only just, most of us, given up using a treadmill test to find out whether someone's ischemic. And the data consistently showed for about 30 years that that was wrong in about 3 out of 10 cases. So there's room for us, when we're talking about screening tests, to accept that not everyone is suitable for it. For me, it's a very promising advance for people who are suitable for it, but not everyone is suitable for it, for sure.
So right now, it's not quite ready for prime time then?
Well, I mean, funnily enough, the National Institute of Clinical Excellence, that's not its proper title, but NICE in the UK, has done an early technology appraisal of this, and their preliminary findings are out for consultation, so they're not finalized. But even though there are no randomized trial data yet, they have been extremely positive in their preliminary outcome about this technology. So whether it's suitable to use in clinical practice now, I think unfortunately depends on whether you're a cautious person, whether you're very much in favor of it, or whether you're an optimistic person. For me, I don't use it in my patients yet, because I'm not yet completely convinced until I've seen randomized trial data. But a lot of my colleagues around Europe and some other places in the world are already convinced based on platform and the diagnostic validation studies, and will use it clinically. So that much is a little bit down to your individual assessment, I think.
Colin?
Nick, can I ask your opinion about the theoretical concept of IFR, CT, IFR? Sorry, can I ask your opinion about the possible scenario of CT IFR or IFR CT, because there are groups undertaking that type of development work. I mean, how do you fit that into the schema of things?
Well, Colin, we've known each other for a long time, so you know that I'm too stupid to be able to answer that question properly. but if you
I didn't ask it with that thought in mind.
But if you want me to speculate, it's a little bit like invasive IFR. I'm prepared to just keep an open mind. What I know a lot about is FFR CT, and I think it's very promising. Other developments are running in parallel with this. They're probably, it's fair to say, not so advanced. They're certainly not, haven't been tested as much. But like a lot of things, and like everyone else in the room, I just want to do the best by my patient. And so if in the fullness of time there are other non-invasive modalities with very convincing results, and even this I don't think for me is convincing enough yet, then of course I would be happy to take them up.
All right, thank you. I have to move on. Of course, you can always ask everyone questions in the hallways, grab them wherever you can. Now, coming up next, or recalled next, since he's given talks already this morning, is Dr. Sen, and he's going to give IFR trials regarding current practice.
Great. Well, thank you very much for inviting me back again to give this talk, which is really going to discuss some of the IFR trials to date and how they can influence our clinical practice in the cath labs from today onwards. What I'm going to do over the next few minutes is really talk about how I use IFR and how I would suggest, if you're a new user to physiology and IFR, how I would suggest that you incorporate it into your practice. We'll highlight what's limiting its use, and then we'll talk about the clinical trials of Define Flare, Sweetheart, and how they compare to the FFR trials. So you would have seen from the live case today that some of my colleagues in my own unit are just happy to be guided by IFR alone. I'm not quite there yet, and I was one of the developers of IFR. I think we've got 20 to 30 years of good, hard evidence from FFR, and that's where I'm really basing my decision-making with my patients at this point. We don't have any clinical outcome data for IFR, and we have to jump over that hurdle before we can sit at the table with FFR. Now, one way we can incorporate IFR into clinical practice is to use it in a way that allows us to match treatment decision guided by FFR in a highly accurate way. And this is the hybrid approach, which is how I think most of the centers in Europe who have adopted IFR are using IFR. Let me take you through this approach. What we would do in this situation, you have a patient on the table, you pass your wire down the vessel. If your IFR value is less than 0.86, we know that if you give adenosine, your FFR value is likely to be below 0.80. In fact, it's 95 times out of 100 likely to be below 0.80. Therefore, we don't give adenosine, and we have a remit to stent. If we put the IFR wire down, measure the IFR, and it's above 0.93, we know 95 times out of 100, your FFR is going to be negative. We don't give adenosine, and we stop. Anything in between, we are very close to the cut point of IFR and FFR. There's a large degree of disagreement between the two indices at that point, and I would defer to FFR. This hybrid approach has been adopted by pretty good-sized randomized trials. This is one of the studies that has used it and has reported recently 30-day outcomes at EuroPCR, and you can see the hybrid approach being adopted or suggested in the protocol of this study. Now, this study involved severe coronary artery disease and compared multivessel disease to a retrospective cohort of surgical patients, so it's slightly different to the intermediate lesions that we are proposing that you use physiology in. Despite that, Patrick Sorois has reported that 73% of these patients that were in this study were assessed without adenosine. Now, as I've already said, I'm not quite there yet, but clearly some of my colleagues are. I think Patrick Sorois and Prof. Curzon have a similar kind of outlook on life. I think we have to wait and see what the data tells us to decide where we go with the newer technologies, but we do have a very good technology which is well validated in our pocket, which is FFR. Despite that, IFR is now used in over 3,500 labs around the world. I hope in a hybrid fashion, but I suspect in a large proportion of these just using IFR alone. I think the physiological differences between IFR and FFR are well defined. One is measured with adenosine, one without, and one within a particular period of the cardiac cycle. We do know quite a bit more about the relationship between IFR and FFR since the publication of the ADVISE study, which was done in 2011. What do we know? Well, we know IFR and FFR have a similar ability to detect ischemia. In several studies, and I've shown this slide before, when we take IFR and FFR on a particular patient and compare it to an external index of ischemia, there is no difference in the ability of either index to discriminate lesions that are ischemic or not. And this has been confirmed in larger independent studies using PET. What we also know is IFR is not FFR. These are two different indices measuring physiology in two very different conditions. So we have the potential here of, instead of saying using one rather than the other, but perhaps, I suspect in the future, using both, or using them dependent on the kind of patient that's in front of you on the cathlab table. What are the differences between IFR and FFR? Listen, in 1 in 5 patients, your IFR and FFR will disagree. What that means, we can discuss, and we can spend weeks, and we have indeed spent years discussing what that means in terms of flow, in terms of hyperemia, in terms of distal disease, in terms of right atrial pressure. But what does it mean for you as a clinician with a patient in front of you on the cathlab table? We know that some of these newer indices, in particular IFR, can provide different opportunities for us to interrogate coronary vessels in a different fashion. And in the live case, we explored this today with regards to the pullback. We know that IFR is simple to perform. We know it's safe from large studies now, having compared IFR to FFR in over 6,000 vessels. We know it doesn't require adenosine. It takes a few seconds. You avoid serious complications, potentially, of administering a hyperemic agent. The side effects are obviated, and it avoids off-label use of adenosine. But this is the key point. There's no outcome data, okay? And until there's outcome data, I think we have to defer to fractional flow reserve. Now, I have to say, the data with regards to fractional flow reserve is very robust. They really did set the bar for any of the new indices. In order to get accepted into clinical practice, we have to provide you data as clinicians about randomized control studies in large populations with hard outcome data. And that's what we have with fractional flow reserve. And hopefully we'll be able to provide you that with IFR too. So as medical leader defined FLAIR study, we wanted to provide the community with some hard outcome data with IFR. This study looks to compare IFR-guided revascularization to FFR-guided revascularization in a large number of patients. So we're talking about 2,500 patients in one-to-one randomization. What does that look like? Well, it looks like 16 countries and 47 different centers. Some of the participating centers are in the audience today, but we're ranging from Australia to Japan to South Africa to Europe to America. So it's really a global study of intermediate stenosis severity. And it's a very simple study. So anyone that the operator thinks requires physiological assessment is randomized 1-to-1 to either FFR according to standard cut points compared to IFR according to a cut point of 0.90. If you're in the IFR arm, you can't measure an FFR, and if you're in the FFR arm, you can't measure an IFR. It's a protocol violation, and the patient is excluded. And we can check that because we get real-time live screenshots from each and every physiological assessment. Primary objective is to determine, is IFR safe to use to guide revascularization, and is it as safe as fractional flow reserve? With a study of this size, we'd be looking to follow the patients up for out to 5 years, as was done with FAME, but also it gives us an element of opportunity to look at certain subsets and certain secondary analyses with regards to cost, quality of life, prediction of events with a post-IFR value after PCI, and whether or not IFR can be reliably used in acute coronary syndrome. At the same time, a parallel study is being performed by Swedish investigators using the SCAR registry involving 2,000 patients with exactly the same protocol, with the aim of combining the results from both of these studies to get a more powerful outcome. Where does Define Flare and Sweetheart really sit in the history of randomized controlled trials with regards to physiology? Well, we look at the first study, we're talking about 91 patients having physiology. We look at the FAME study, these are the number of patients in the physiology arm. FAME 2, these are the number of patients in the physiology arm. With regards to Sweetheart, these are the number of patients that we're now getting physiological data for. And with regards to Define Flare, we're talking about 2,500 patients. So regardless of whether IFR works or not, we're going to get a lot more information about FFR2, which can only be good for the community. If we combine the two, which is our plan, we'll have a total of over 4,000 patients worth of data with IFR and FFR. Exciting times for physiology in general. What do we know? Physiology is superior to angiography. We know that. We know that there are real physiological differences between IFR and FFR. I'm very much in agreement with Prof. Curzon in that, regardless of the nuances between IFR and FFR, physiology is the way forward. Define Flare and Sweetheart will be the largest physiological studies to date, using both FFR and IFR. Hopefully it will show physiology is simpler and easier to form, more cost-effective and safer, and more patient-friendly with IFR. But the reason we're doing the trial is because we don't know. So who's the winner? IFR or FFR? I think it's really important that we maintain that our patients have to be the winner here. All right? So all this debate about IFR, FFR, all it does, it increases our interest in the field, and that can only be a good thing. I think in a few years' time, there'll be more players in this market. There'll be more indices, and I also think we'll be a bit more nuanced in a way we use physiology. If I asked each and every one of you how many workhorse wires you have in your cath lab, you'll say more than one. How many stents? Likely more than one. How many balloons? Likely more than one. Why can't we have more than one physiological index? And whether you use FFR, IFR, contrast FFR, as long as you're using physiology, it's got to be in your patient's best interest. I think the next step is really exciting with regards to non-invasive techniques. And obviously, I look forward to listening to Prof. Curzon's talk on that. Thank you very much.
That was excellent talk. Any questions from the audience? How many of you are using IFR, like we saw from on our live broadcast, primarily? So do you use a hybrid? Do you use that sort of triage hybrid approach, where if the IFR is in the gray zone?
Exactly. I think that's what we do. If the IFR in the gray zone, we use the challenge.
He's a fellow Pennsylvanian from the U.S. with me, so.
But just to be fair, but you seem to have only one guy doing IFR. Just don't make me nervous. How many of you are using FFR?
Just a few more.
At least we have some physiology done.
Good, yeah, excellent. Brilliant.
Okay, thank you.
Thank you.
Okay, well, moving on and staying on time. Now we're going to hear about contrast as a easy vasodilator agent from Niles Johnson. As you heard in some of the earlier slides.
It's Colin Berry first. It's Colin Berry.
Okay, I fooled you all. I'm just.
Okay, we can do it any order you want.
Oh no, we're going to stay on the right order, because I'm sure I'm going to get grief for this now. I got a little excited because I want to hear about the contrast too. Famous FFR and non-STEMI by Colin Perry. I'm sorry I jumped out of order there.
It's time for a nap in Pennsylvania.
Okay, so I'll do my best not to disappoint you, since I'm not Niles Johnson giving the contrast talk. Famous FFR and non-FFR non-ST elevation myocardial infarction. Same disclosures as before. So the learning objectives, got 20 minutes. Practice variations, incomplete revascularization and prognosis. So that's a clinical context. And then measurement of FFR in culprit and non-culprit disease in patients with recent non-ST elevation myocardial infarction. So in the UK every year we receive information about cardiovascular epidemiology enabled by the British Heart Foundation, and Scotland is bright red because of the endemic CVD morbidity and mortality rates. That's on the left here. But more importantly, there is a whole process of primary and secondary health care around this disease management, which is articulated in 2014 as 26,510 angiograms, 23,053 angioplasties, and actually this was updated last year. And then in terms of disease burden, in terms of incident events, 80,724 MIs, 2/3 of which are NSTEMI, and there's associated societal and healthcare costs. And of course, these are UK data, and similar data will pervade in your countries also. So it's an important health problem, right up there with cancer, and arguably in younger women more important than cancer. So focusing on the subject of this talk, practice variation in non-ST elevation myocardial infarction increases 30-day mortality. So this is epidemiology work looking at hospital level management, including medical therapy as well as invasive management and performance of revascularization in UK hospitals and in hospitals in Sweden between 2004 to 2010. And the revascularization rates in Swedish hospitals are much higher. This is proportion of patients treated, I believe, versus UK hospitals. It seems quite low, but these were the data published in the BMJ. And the purpose of, the reason why I'm showing you this slide is that 30-day mortality is greater in UK hospitals than in Swedish hospitals. And in a multivariable model of the predictors for that mortality, what plays out is practice variation in terms of revascularization. So more there is variation in revascularization within a healthcare system, more 30-day mortality is higher. And that suggests that a lack of standardization about managing individual patients with the same problem, one doctor does one thing, another doctor does another, then intuitively maybe one approach is less beneficial or more beneficial with that variation. And for me, this directly speaks to the standard care pathway of NSTEMI patients. They present subacutely, they, by guidelines, are managed invasively fairly urgently, maybe within the first 24 hours. Where I work, it takes longer to get patients to the cath lab, so it's in terms of days, sometimes even weeks. But nonetheless, these patients go direct to the cath lab, and they are not, their management is not informed by non-invasive testing. We know that in NSTEMI patients, there is a range of comorbidities expectedly. Multivessel coronary disease is more common, as you can, multivessel coronary disease is prevalent, and of course the ECGs, T-wave inversion, occasional ST segment depression, the ECGs are not specific in the way that a STEMI patient's ECG might be, and so that gives uncertainty about which lesion or lesions might be involved in the culprit presentation. And so coming back to our interest in this workshop, might functional testing reduce practice variation? And I would suggest that physiological testing can reduce practice variation by increasing the information available to clinicians in this setting. So what about the evidence base for fractional flow reserve, which is the subject of this talk, in acute coronary syndrome patients? I've already shown you this post hoc analysis from the FAME trial, and just the high level is that clinical outcomes were worse in ACS patients they were improved in that subgroup if managed by FFR-guided management as opposed to angiography-guided management, and that benefit was consistent between ACS and stable patients. But reading that paper, it was notable that the authors stated it is desirable to confirm these findings in a prospective trial. And I think that's a generic comment that would apply to any non-pre-specified subgroup analysis. I alluded to that when we discussed gender and FFR in my earlier talk. So at least 2/3 of our practice in Glasgow involves patients with a recent ACS. So this is a really relevant question, to use or not to use FFR in our ACS patients. We're treating them all the time. So what we did before embarking on any studies, we did a decision model analysis where we looked back in our cathlab records in order to find 100 NSTEMI patients in whom the cardiologist had measured FFR on clinical grounds. There were, I think it took us about 1,200 patients with NSTEMI to find 100, so there's clearly a selected population. But that wasn't the point. What we were interested in was, on an individual basis, having an independent coordinator present the clinical history to the cardiologist. And so we had the cardiologist sit in the cath lab, so trying to mimic the real world, because this clearly was post hoc, showed the angiogram, described the medical history. What would you do with this patient? And imagine the angiogram that I showed you earlier with the number of narrowings. And the clinician may say multivessel coronary disease, stable diabetes, bypass surgery. And then the coordinator then disclosed the FFR result. The FFR in the LAD was 0.95, the circ 0.73, the right coronary artery 0.68. So that might, hypothetically change that treatment decision from bypass surgery to 2-vessel PCI. So this coordinator or registrar, David Carrick, sat with 5 cardiologists separately and reviewed the cases in that way for 100 patients. And this was quite interesting. So the initial treatment plan is shown in blue. So no consensus. So consensus is defined as conformity in the treatment plan in 3 out of 5 of the cardiologists. So no consensus was quite prevalent in about 40% of the patients. Deferred management, patient stable, I'd like to get a stress test to further assess that non-culprit disease. A treatment plan for bypass surgery, multivessel PCI with drug-eluting stents, multivessel PCI with bare metal stents, to medical management, I think is, medical therapy is there. And you can see that once the FFR was disclosed, there's a left shift. There's a trend towards away from multivessel intervention by bypass surgery, PCI, towards medical therapy. But just as importantly, and I introduced this talk by heterogeneity in decision making, there was a substantial reduction in the lack of conformity or consensus. And okay, this was a simulated setting, but the idea that they would defer for additional testing was abolished. So, these two items there on the right-hand side, I personally find just as interesting as any impact on revascularization decisions. So that gave us confidence to undertake a prospective trial, because we thought that the results might be accepted by the cardiologists if the FFR was actually measured in real-life clinical practice. And we undertook a clinical trial. Professor Curzon here, he was PI for his hospital in Southampton. There were 5 other hospitals, a 6-hospital study. The hypothesis was that routine FFR is feasible in NSTEMI patients and adds diagnostic, clinical and economic benefits compared to standard angiography-guided management. We did not set out to undertake a practice-changing trial, rather to gather evidence to inform the rationale, in other words, stop, go, yes or no, and design of a larger health outcome trial. So this is the flow diagram, coloured to try and help with the message as you go down. So we screened patients on the ward during urgent care, about 1,297. We obtained informed consent to the notion that FFR might be used in any vessel with a stenosis greater than 30% with no upper limit. So in some clinical trials, there might be a threshold for 50% or 80%, but in this, we wish to have the most open criteria for FFR measurement to impact on decision making. So just one narrowing of 30% severity would be sufficient for enrolment. So in FAME, multi-vessel disease. In this trial, just one narrowing would have been sufficient for the patient to go in. FFR was measured in all patients, but the result was disclosed in half. So in a diagnostic study, if the clinician is looking at all the results, there's a potential for bias if you're associating one metric versus another. So we, by protocol and by agreement with the Ethics Committee, did not permit the FFR results to be shown in the control group, so that was standard care. But equally, we're able to relate all of the decisions in relation to the FFR data. 350 patients were randomized. All treatment decisions were possible, and they've been followed up to 12 months to date. And in the longer term, we will have a 5-year analysis in the fullness of time. So in the FFR disclosed group, so the treatment plan was established. The patient was then randomly assigned to one or other group. FFR was then measured and disclosed in 176 of the 350 patients. And if you look at the left, bypass surgery, PCI, or optimal medical therapy, and quite literally, the clinician did not change or did change their initial treatment decision in those directions. So some patients shifted from bypass surgery to medical therapy, 2 of them stenting and so forth. You see all the different scenarios. And overall, FFR treatment resulted in a change in plan across these 3 groups in 1/5 of the patients. Overall, that resulted in a net reduction in the performance of revascularization by PCI or bypass surgery, and that difference was broadly maintained at 12 months. So that's all very well, change in diagnosis and treatment, but what about patient outcomes? So if the performance of PCI is reduced, so its complications are reduced also, although in this study that was not statistically significant. On the other hand, spontaneous MI was largely consistent or similar between the 2 groups, but on the other hand, this study was not at all powered to draw any conclusion about the events on individual patients. We need a much larger trial. So, coming back to this question about FFR diagnostic validity in ACS, in non-culprit disease, I would suggest it potentially is, and there's other data that we could discuss that might support or indeed refute that possibility. In culprit disease, that's much more contentious, and I think in usual care clinical practice, one would be cautious about using FFR because of the possibility of reversible microvascular dysfunction. But still, I think that is an open question, and medical management may very well suffice for the large majority of patients with an FFR above 0.8. Again, happy to discuss. In a pre-specified MRI sub-study, we looked at the relationships between an inducible perfusion defect, wherever that may be in the heart, and FFR, because we had multiple FFR measurements across different arteries. And we found a close correspondence between FFR and, according to that binarized threshold of 0.8, and an inducible perfusion defect based on blinded analysis of the MRI scans without knowledge of the FFR results. What about the clinical guidelines, which are clearly relevant? I mentioned this earlier, and so forgive me for repeating, but currently the value of FFR-guided PCI, or indeed decision-making, not just for PCI in this setting, has not been properly addressed, and further clinical trials, I think, are warranted. So it looks like I'm keeping to time. So to conclude, incomplete revascularization and practice variations during everyday clinical practice are common and associated with a prognostic disadvantage. Nothing to do with diagnostic indices. That in itself, I would suggest, is a clinical problem. FFR is safe. I didn't show you the data, but there were 2 guide wire dissections out of 706 lesions assessed, so 0.3% guide wire dissection rate. Appears to be valid in non-culprit disease and was diagnostically impactful because the FFR disclosure resulted in a change in the treatment plan in 1/5 of patients. I think it's reasonable to conclude that FFR is diagnostically impactful in this setting. On the other hand, the clinical impact of the FFR guided treatment decision, if you will, is uncertain, and we would like to see some large trials around this question in the future, because clearly the physiological tests can be impactful, but it's whether that leads to an improvement in prognosis and health and economic costs in the longer term. There are studies, particularly in STEMI, taking place, but not so much in NSTEMI, but hopefully we will be able to have this question fully addressed in the next 5 to 7 years. There is Ripcord 2, of course, in STEMI, which Prof. Curzon might want to speak about. So, thank you very much for your time.
Colin, when you mean that we will have the result in 3-5 years, is because you are conducting such a large randomized trial, or is it still on a planning phase, or what's the status?
Yeah, so I'm suffering during peer review of a trial that we would like to get funded. One funder didn't nearly get accepted, but ultimately did not, and so it's that trial proposition, famous NSTEMI 2, is currently under review with another funder. I'm happy to tell you about it. It's a 4,400 patient clinical trial of very simple dichotomization of FFR guided management in NSTEMI patients versus not, with a health outcome composite of cardiac death or non-fatal myocardial infarction. So the trial is set up to answer the question of superiority, not because we think that FFR will somehow lead to a beneficial effect directly, rather that its impact on the patient pathways in a number of ways might lead to benefits, such as a reduction in incomplete revascularization, a reduction in staged management, because if patients are discharged with residual disease or waiting for a second procedure, they're at risk of early recurrent MI. So it's a large but simple clinical trial. It remains to be seen if it will get funded or not.
Okay, good luck.
Thanks.
Okay. All right. I got a cup of coffee, so hopefully I won't make a mistake this time around. Now our final topic or speaker for this section is going to give us a talk on contrast as an easy vasodilator agent, and Niles Johnson will provide us the speaker.
Right. Yeah, I think you and I are the ones on the farthest time zone here, so we need the most coffee. All right, hello again, everybody. I'm going to be talking about contrast. By way of disclosures, they're the same as before, but just to highlight that this trial was sponsored by institutional research support by St. Jude Medical. So I'm thankful to Zsolt because he already brought up some of these slides, so allow me to go through them a little bit faster, and that will hopefully save some time for a discussion. Bringing up this concept of the pyramid of diagnostic accuracy, we want to be better than a coin flip. And this, I was able to find, is the first ever diagnostic angiogram. I'm not sure if you've seen it before. This was the first selective coronary angiogram from October 30th of 1958 in Cleveland. You can see that this catheter accidentally slipped into the coronary artery. They were trying to do an aortic root shot, and he managed to pacify the right coronary artery. The patient, of course, went into ventricular fibrillation, but managed to survive. And now here we are 60 years later, and we do this all the time, and people live to tell the tale. So it's a wonderful diagnostic test, but what we've learned, and you've seen graphs like this before, is that it has a fairly modest relationship with hemodynamic significance. And what that means is that the scatter between things like percent diameter stenosis and FFR means that there's a lot of uncertainty, especially at the level of an individual lesion. There may be a group trend, yes, but if you say, all right, does this patient have it or not, it's not so clear. And so this tool, now almost 60 years old, certainly better than a coin flip, but by no means a clinical gold standard. Now, as Zsolt also brought up at the very beginning of PCI, Andreas Grunzig on his balloon catheter system was able to measure the pressure gradient across the stenosis, And you can see here how that gradient was measured initially. The balloon was then dilated, and he would make post-measurements in order to understand if further balloon dilations were needed. And so this whole concept of resting physiology really goes back to the late 1970s as this was being developed. And what we've learned through a series of trials conducted over the last few years is that using FFR as a reference standard, which I'll show you that there's great reasons for choosing that, shows us that there's an 80% accuracy. And that holds if you look across a large number of trials. All of these were done multi-center around the world, core labs in many of them. And so I think this is really reflective of the underlying diagnostic test performance. The other important piece of information that we see here is that the diagnostic performance of PDPA and IFR, PDPA is in black, IFR is in blue, is the same across all the studies. So I would say that the easy take-home message is with resting physiology, you're at 80% no matter how you measure it. And so certainly physiology is an advance. I agree with everyone that we shouldn't be using angiography alone. We need to be doing physiology, and that gets us to 80%. But let me show you this patient. So here's a guy, 59 years old. He has this mild and long LAD lesion, and when he's sitting there in front of you, he doesn't have any symptoms. No symptoms at rest. You can see his EKG is normal. His SPECT test is normal. You put a pressure wire down his artery, and there's maybe 2 or 3 millimeters of mercury gradient. All right. So if we would look at all of the design for the current trials of things like FLAIR and Sweetheart, we'd say, all right, this is the kind of person that's IFR negative. We should not be treating this kind of person. Well, let me show you what happens to this guy when he decides to try to do active things like walk. He develops angina, he develops EKG changes, significant ST depression, and he develops a significant perfusion defect in the LAD distribution. And you can see here the pressure gradient down his artery rises significantly with an FFR of 0.73. So you can see this is the reason that we do stress tests in our patient, right? Here's rest. You don't see it. You only uncover it if you stress the system. So I'd just like to think about especially this kind of patient in the context of the trials that you recently heard about. Are you going to miss these kind of people? Do you want to be missing this kind of individual who comes to you with symptoms? All right. So it was through this type of pre- and post-test validation that FFR was really extensively validated 20 years ago. So they took FFR and compared it just like that individual patient against treadmill testing, SPECT, as well as stress echocardiography. And you can see that when the FFR is low, below 7.5, all of these patients had at least 1 and usually 2 or 3 tests that were positive. All of those positive tests returned to normal after vascularization, and the FFR rose. And so this, in conjunction with the clinical outcomes data that Colin was telling us about earlier, is really why we put FFR close to the top of the pyramid. Now, I'm not going to say that one test is right all the time. I think that our bodies are simply too complicated for that. The world is too complex a thing to say that one test is always right. But you can see on the basis of all of that data that FFR is certainly very close to the top of the pyramid. And so for that reason, it becomes a practical question. Which drug should we give for vasodilation? And you saw this list earlier. It's a historical development over the last 40 years of all the different techniques that we've had for inducing vasodilation in humans. And I'd like to go back to the beginning. We're kind of an old school lecture. I showed you the angiogram from 1958. I showed you the Grunsig stuff from 79. So let's go back even further to contrast. And the reason that contrast is attractive is because it's already there in the cath lab. It's hanging for a diagnostic angiogram. It doesn't require any extra setup or cost. There's no extra risk to it. So it's a very easy and attractive agent. What's interesting about contrast is that it's a known vasodilator. So again, this is a historic talk. We're going back to 1959. They took a series of dogs and injected their coronary arteries with contrast, and they saw that flow increased by 60% above baseline. And this was the reason that throughout the 1960s and 70s, and that's why when Gould first came along in the 1970s, he was using contrast as well because it had been such a well-established coronary vasodilator. In fact, if I could just digress and tell an interesting historical piece, I don't know if you're aware of this, but the first SPECT scan was made using contrast. So what they did in Seattle, where Gould was they went up into the coronary artery, they injected contrast through the catheter, and then they quickly injected labeled thallium scans, and then they pulled the catheter out and they took the patient to the SPECT scanner. So that was the first way that they started doing SPECT scanning, was through intracoronary delivery of both the radiotracer, and they used contrast in order to cause hyperemia. So that's where SPECT got started. We don't do it that way these days. All right, so this was the development then of contrast FFR. Contrast provides some degree of hyperemia. It was compared with a large number of other vasodilators in the study, and it was found to have some vasodilator effects, but a little bit weaker than the others and not as long a duration of action. And so it was because of the renewed interest in trying to simplify physiology that we took this existing data and decided to perform the contrast study. And our hypothesis is that contrast FFR would provide superior diagnostic agreement compared with FFR versus resting metrics. And our primary endpoint for the study was diagnostic accuracy, although we also looked at important secondary endpoints like area under the ROC curve and test-retest repeatability. There's been a lot of work on contrast, and so we wanted to make sure that our study had several unique features. As I'll show you, we had a large sample size in order to really improve our precision. It was an international and multi-center study, so that the results would apply to everyone in this room. We sent all of the tracings off for a blinded core lab analysis in order that the measurements be made in a standardized fashion with a minimal amount of bias. And as I'll show you an example, we really had, I think, designed a pragmatic protocol that reflected real-world scenarios. We measured everything twice. We used both routes of adenosine, and we looked at both resting metrics. In other words, if we come back to this pyramid concept, the question for the contrast study is, where does contrast fit in the pyramid? It has to be somewhere above rest. It could go all the way up to full adenosine, but where exactly does it sit? We ended up enrolling a little over 760 subjects, and we had 1 lesion per patient. We asked operators to just select patients who were undergoing routine FFR evaluations in their centers. So these weren't lesions that were destined for PCI. They weren't normal reference vessels. We asked people, use FFR just the way you would clinically. Give us those kind of lesions. Now, for the contrast media, we left it up to local practice. We didn't say you have to use this particular brand of contrast, you have to use 7 cc's of whatever it is. We say just do whatever you do normally for diagnostic angiography. Similarly, for intracoronary adenosine, we again left it up to local practice, but with a recommendation for 1 to 200 mics. IV adenosine was at a standard rate, and the thresholds were standard from previous studies. This is just to show you, much like the slide for FLAIR, that this was a worldwide study from all over the place. Bill Fearon and I were the PIs, and Alan Jeremias at CRF in Manhattan ran the core lab. So I want to walk you through an example tracing, both to show you what it looks like when you give contrast to measure FFR, and also to give you a sense for the data. Here on the x-axis is time. On the y-axis over here is pressure. Red is aortic, blue is coronary, and on the other y-axis is the ratio, and that's up here in black. So at first we made a minute-long measurement to get rest, PDPA, and IFR. Then we injected contrast. You can see that the PDPA falls quite rapidly. This little peak down here at the bottom is the contrast FFR, and then it returns to baseline. We made a second measurement in order to understand repeatability. Then we injected intracoronary adenosine, and you'll notice that the peak here goes lower, so contrast provides less hyperemia than adenosine, and also this peak here is a little broader. The other one's more of a real V. This is maybe more like a U shape that has a bit of flatness to it. Again, this was done a second time in order to understand test-retest repeatability. Then we waited for a period of time back at baseline for our second resting assessment. Then we turned on IV adenosine, we turned it off, we turned it back on again, and finally we performed a pullback to look for drift. So at the end of the day, every patient in this study had this kind of data. We had resting measurements, we had contrast hyperemia, we had adenosine hyperemia, and we had a drift check. And for example, let's take a little bit closer look at this example I showed you. This is a patient whose FFR is less than 0.7, so a very significant lesion. But again, just like that example I showed you earlier about hyperemia, this is someone where there's essentially very minimal resting gradient. This is someone that you'll completely miss at rest. But take a look at what happens with contrast. You drop down below 0.8. So this is one where contrast immediately gives you a clue that this is a lesion that's hemodynamically significant. The results were fairly typical population that was enrolled for people who were undergoing invasive evaluation. We ended up using 8 different contrast materials from around the world. I've shown you the top 5 here. I'm sure whatever contrast agent you use in your cath lab was part of our study. Operators on average injected 8 cc's of contrast, and the vast majority of tracings were accepted by the core lab, although there was a 15% exclusion for ECG. The reason that's important is the current IFR algorithm requires a valid ECG signal. This is the lesion distribution. I really want to highlight one thing about the FFR. 50% of the lesions had an FFR above 0.8, 50% were below. So it was really a population, as you can see from the distribution, that was very clinical, really balanced on that decision threshold. Is this lesion significant or not? It wasn't skewed to the left or skewed to the right. The other interesting thing is just putting down the wire, 10% of the time, the PDPA was less than 0.8. So you knew right away in about 1 out of 10 patients that that lesion was hemodynamically significant. But look what happens when you give a bit of contrast. That number goes from about 10% up to 30%. That is, you triple the number of lesions where you can be confident that this lesion is hemodynamically significant. As I mentioned, the primary endpoint was diagnostic accuracy. Like I showed you and summarized at the beginning, PDPA had an accuracy of around 80%, and IFR showed equivalent diagnostic performance, whether you look at accuracy or you look at area under the ROC curve. But look what happens with a little bit of contrast. When you give a bit of contrast, you improve your diagnostic performance. The accuracy goes up to about 86%, and there's a significantly larger area under the curve. We found an optimal threshold at 0.83, but we found a wide range where the diagnostic accuracy remained high between 8.3 and 8.5. Now, what I've just described to you can be considered a binary strategy. So each test is either positive or negative. It's either black or white, and you make your decision threshold that way. And I've just demonstrated that under those circumstances, contrast performs best. But as we just heard about IFR, the other way that you can use these indices is part of a hybrid strategy. There, instead of just black and white, you have black, white, and an intermediate gray zone or hybrid zone where you need to give hyperemia. If you make that zone quite wide, you end up giving adenosine to a lot of people, but you have a high accuracy. If you make that zone quite narrow, you give adenosine to few people, but then you end up lowering your accuracy. So really what you have is a trade-off between freedom from adenosine and accuracy. And I show you here the two curves for IFR and PDPA performed similarly, whereas the curve for contrast FFR performed better. So to give you an example, if you wanted to have a 96% accuracy, you'd be able to skip hyperemia in about half of patients using a hybrid resting physiology strategy. But if you incorporate contrast, you could skip adenosine in about 2/3 of patients and still maintain the same level of diagnostic performance. So again, contrast does best with hybrid. We also made 2 measurements of everything, and you'd like those 2 measurements, of course, to be as similar as possible to each other. The more scatter, the more spread there is, the more variation you have when you're just measuring the same thing over and over. And the way to look at it visually is to understand how much scattered there is on these plots. The plots are the difference between the 2 measurements over their added value. The mathematical way to do it is to look at the standard deviation. I put those numbers down here, but just focus on the visual. So you can see here that something like contrast FFR has a tighter bunching of numbers than does IFR on the right-hand side. And what that means is that hyperemic conditions, even mild hyperemic conditions like contrast, are more reproducible than resting conditions. Now, clearly there's some limitations. I showed you from the example case that contrast FFR is a fairly short duration of hyperemia, so you can't make a pullback measurement. The same could be said, though, of intracoronary adenosine. We didn't collect data about contrast-induced nephropathy. In my own practice, I tend to give a little squirt of contrast anyway to document wire position, and you can see that the dose used in this study was only 8 cc's. I feel for the vast majority of patients that's never going to push them into renal dysfunction, so I think that the clinical impact of that is quite negligible, and we have some sub-studies that are up and coming now under journal review looking at contrast medium, dose response, LAD versus non-LAD, and a core lab performance, those types of things. So in conclusion then, the contrast study found that contrast FFR was superior to PDPA or IFR for predicting FFR, whether you used a binary approach or a hybrid approach. We found, like many other studies, that IFR and PDPA had equivalent diagnostic accuracy, and therefore FFR really remains the diagnostic reference standard, given that something like contrast FFR only got up to about 85, 86%. In other words, we now know where in this pyramid contrast FFR fits. It fits right around here, almost midway between resting and full hyperemia. And so I think the clinical impact is something like this. With a quick squirt of contrast in about 30% of patients, you'll be able to understand immediately if this lesion is hemodynamically significant or not. And that's important for healthcare systems where adenosine is, say, hard to get, prohibitively expensive, or in those rare cases where it's contraindicated. And I've shown you in contrast that it's easy, inexpensive, safe, has excellent test-retest stability, and doesn't depend on a specific software platform or ECG gating. So this is something that all of the manufacturers don't even have to build into their systems. It just relies on you injecting a little bit of contrast. Now, What happened soon after the contrast publication is the results were confirmed. That's very important in science, that other groups confirm what you find. This Memento series was published just last month in Eurointervention. It's a large series, over 1,000 lesions, again, multi-center from around the world, very pragmatic. They use different amounts of contrast, different contrast material. And then there's a smaller series that came out quite recently from Japan. And if you look at them, the message is always the same. Higher diagnostic accuracy with contrast compared to PDPA, higher area under the ROC curve. So I want to leave you with what I think is a practical algorithm for how to incorporate contrast FFR. The first step is obviously to make a PDPA measurement. If the PDPA is low, less than 0.8, you know right away that PCI is reasonable. Now that happens in about 1 out of 10 lesions. You do lose some information about the depth of ischemia. We talked briefly about it. I think Colin mentioned it, that the FFR continuum of risk is important, and so the lower your FFR value, the worse your prognosis. You don't get that information if you skip hyperemia, but nevertheless, you know that you're going to be less than 0.8. If you do pull back curves, again, big things are easier to measure than small things. You're going to be less sensitive to pressure jumps along the artery if you just do PDPA. If it's greater than 0.8, give a little bit of contrast. You'll pick up another 20% of lesions where the PDPA or the contrast FFR is low and therefore PCI is reasonable. This maintains 100% accuracy, but allows you to reduce your adenosine use by 30% without compromising performance. And finally, if both the PDPA and the contrast FFR are high, give adenosine. You'll pick up another 20% of lesions where PCI is reasonable, and for all the rest, medical therapy. Thank you.
So now, thanks to all the speakers from this session, we have some time to make the discussion. There will be a live case at 3:30, so I guess we will have also some time for a coffee break. So is there any question? And maybe I'm going to start with Niels with a very simple one. Niels, did you notice some difference if it was manual injection or automated injection?
It's a great question. There were maybe about 1/3 to 40% of the sites that used contrast injectors of various types, and the quick answer is no, that didn't affect things. We were simply asked sites to do whatever their standard practice was for diagnostic angiography, and so if that was a contrast injector, that was also what was used here. I'd say the one caveat, and I showed you one of these tracings earlier, is that you can get a damping of the aortic waveform sometimes, especially if you're using smaller French catheters with the contrast in there. But that was a very infrequent thing in this study.
And that was my second question. Did you recommend some minimal size in terms of French? Could you use diagnostic as well as guiding? Or?
Yeah, so we didn't make any recommendations. We wanted this to be a very real-world pragmatic protocol. I would say, because I looked at the database and we tracked catheter size, no one used diagnostic catheters in the series, and people used 5, 6, 7, and 8s, of which the vast majority were 6s, some 5s, rare 7s and 8s for extremely rare cases. So the vast majority of this data probably comes from 6 French guidings. We do have a manuscript that's under review right now looking at that issue from a core lab perspective. And interestingly, smaller catheter sizes were associated with more distortions of the aortic signal. So now again, sorry, because you're going to ask about what this means, and I would say that there are 2 components to it. One is, what's the effect on average pressures, because that's all we use for things like PDPA, contrast FFR, FFR. It probably doesn't affect that. That is, the mean is still the same. Now, if you're trying to do subcycle measurements like IFR, there you can't have distortion of the aortic signal because that factors into the calculation. So probably even that kind of blunting doesn't affect our ability to measure things like FFR or contrast FFR. Yeah.
So you don't chase the contrast out with saline?
So we asked sites to do whatever they would do normally for diagnostic angiograms, but try to get good pressure signals. So we didn't routinely recommend any type of chaser, but if they couldn't get good waveforms, then some of those sites did give a little chaser to try to push it through. Yeah, so that wasn't a routine part. Again, the protocol was quite simple, was do a diagnostic angiogram, but just record that pressure tracing on the monitor while you're doing it.
Because then aren't you, when you've standardized your wires and everything, that's done with your catheters flushed with saline, and now you're running a test where the catheter is filled with contrast. And at least when I've done some contrast ones, and it's not that so hard to have like a 3cc syringe hooked up to one of the side arms, and you push your contrast, push your 3 cc syringe, put your thing down, and
yeah, and you're done. And again, a few sites asked me, hey, can we always chase it with things? And I said, sure, go for it. Whatever you think it takes to get the contrast down and to get a good waveform afterwards, but not spend 20 seconds so that you lose all the hyperemic effect. Yeah, so I don't think that this is a technique that's dependent on that, details of how you do it like that. I think it's a wider, more robust technique. And the other thing that I think supports it is the fact that other studies like Memento, which were completely different populations, came to the same results with different protocols. So I don't think it's a protocol-dependent issue like that.
And Niels, if we want to get let's say, a practical message for the operators.
Right.
So in your practice, let's say you have one lesion to assess.
Yep.
Let's say you're going to cross it. If the baseline value, let's call it that way, it's below 0.80, what's your next step?
Yeah, I would say that if you have, so you ask what I do, and I must admit I almost always give hyperemia, although I'll tell you a case of one recently where I just used contrast FFR. So this was a patient who had an LAD lesion that I evaluated with hyperemia. It was significant, and because of that and a total occlusion of something else, we decided to send the patient for bypass surgery. So then it was a question of, does the surgeon need to graft the circumflex? It had an intermediate lesion. I put the wire down the circumflex. The PDPA was above 0.8, but I gave a little squirt of contrast to document wire position, and I saw that the PDPA went down to something like 7.8 or 7.7. And so I knew right away that that FFR would be positive if we did turn on the adenosine. And so in that case, we were able to tell the surgeon, yes, it needs to be grafted as well in the circumflex. So it was a way of guiding care and speeding up that case.
Any more questions? So, okay, so I guess it's time for coffee break, and the live case will start in about 15 minutes at 3:30. Thank you.
All right, if everyone could come in and get seated, I think we're very soon going to go live to just down the street to the Semmelweis Hospital. He gave us hand washing, right? Isn't that one of the contributions of Dr. Semmelweis? Yes, and then he later went insane and committed suicide. Do I remember that story correctly? Did he later commit suicide and go insane, or? No, he didn't. Okay, I'm sorry, I must be mixing it up. But so he gave us probably one of the most important tools in medicine, which was washing our hands. So that's still good medicine today. All right, are we ready to go live? All right, good afternoon, everybody. This is Nils Johnson in the panel. Can you hear us well over there? It sounds a bit like we have some feedback. We can hear you well. Can you hear us over here in the conference room? Yes, please, give us the history of the patient.
Yes, please, can you have the PPT, please? Okay. 1 second. And if everything goes well, we should be seeing a short introduction.
Not yet. We still see... Now it's black?
Yeah.
Not yet. That's still the video of the cathlab.
Yes, thank you very much. I see that.
Now we see the slides. Yes, we see it now.
Next slide, please. Now, subject is a 43-year-old male physician who has been admitted to our clinic 2 days ago on the 19th of September following a 12-hour inferior segment ST line. He's a rather tall and slim individual with a BMI of 19. He's a chain smoker who has a positive family history in terms of cardiovascular disease, but does not take any medication regularly One presentation in 2 hour clinic, the patient still had chest pain on the intensity of about 5 on a scale of 10. Therefore, immediate coronary angio was performed on the subject, done by none other than someone who should be sitting or standing right next to you somewhere. The next slide, please. Now, this is the initial angio that was done during ST elevation MI. This is the left branch of the patient that you see. But here you see proximal LAD stenosis, which on the first one doesn't look really bad. I'd say that, well, this may or may not be a significant lesion. This may or may not cause some problems to the patient, but it's definitely not something that if this was an elective case, I would start jumping at. The next slide, please. And this is the right corner of the subject that we see right now. On the left side of the picture, you'll see that it is occluded. And the right side is after successful PCI using the implantation of a resolute type drug-eluting stent, which will start right now. We achieved nice flow inside the right coronary artery, and we decided to end our procedure right here. The next slide, please. On this chart, a few post-operative parameters of the subject. As I told you, PCI was performed using one drug-eluting stent. His echocardiography showed an ejection fraction of 46%, atrial hypokinesis, which is of course due to this infarct that he had right now, with no relevant valvular dysfunction. Also, which is good to note that he achieved full resolution of the ST7 dilation in inferior knees that we see, and the patient was without complaints. Last you see right now, the patient has mild anemia, very renal function, serum glucose levels within a tolerable measure. His cholesterol is slightly elevated, but his enzymes, especially CKMB, are significantly elevated. This is almost a 10-time rise. In our 24 units per liter is the upper normal limit, and this subject measured an activity of 203 units per liter. LDH concentration was 519 with an upper limit of 460, so that wasn't really elevated. So this not our onset may not even have been 12 hours, but much less. And the last slide, please. And doing our CAT right now, which is I remind the panel and everyone in the audience, is exactly 2 days after the initial PCI of the right coronary artery. We will now evaluate the LAD stenosis of this lesion with a new offset system, and already we posted a few potential questions to the panel, which will be the method and way of introducing a medicine to the subject, or if this is needed at all, or if only a contrast flush will be necessary to obtain the needed hyperemia. And now I'd like to show you the angio that Dr. Pilot has performed just now. Now, this is the left coronary branch. This angio was done about 5 minutes ago. You can see the LAD stenosis right here. When we saw this angio right here, we were a bit surprised with Dr. Pilot because this looks significantly worse than it did 2 days ago. We kindly asked for something from the panel as to this lesion right here.
Well, yeah, what I would say is as you're proceeding to get set up and do the FFR, I think this is a great case, in some ways similar to the one that we saw from Imperial, and this really reflects the amount of non-culprit disease that we see in ST segment elevation MI and the open question of what to do with it. Now, I'll bring up a discussion point. Since you're doing this case now 2 days after the initial STEMI, the question is how long to wait before doing it. And I'll just start with my perspective. I finished a year just recently in Eindhoven, where our practice was to bring patients back to the lab during the same hospitalization. So much like the patient that you have here, it would be 2 or 3 days later to evaluate non-culprit disease. And then now, as of August, I'm back in Texas, and there our practice is to not do that, and it largely hinges upon reimbursement issues in the United States. And I'm sure Dr. Gilchrist can speak to this point too, that if you do another angiogram PCI within, I think it is 30 days, this counts as a black mark against you. And so for that reason, we've typically let patients, unless it has very subcritical disease, leave the hospital and then return as outpatients. But I'm sure, because there's no answer to this question, that we'll see quite a bit of variation. Olivier, what's your practice in Quebec City?
I think it's pretty the same as in Europe. I mean, we will probably reevaluate the patient within the same hospitalization.
For those of you who do FFR and non-culprits routinely, how many of you do them during the same hospital course? That is, maybe during the first 3 to 5 days afterwards. Yeah, how many of you then who are doing routine FFRs bring them back as outpatients? Yeah, so it's probably more like a 70-30 split. That is, the vast majority do what you are doing there at the Semmelweis Hospital, bringing the patients back as inpatients for evaluation. Yeah, Dr. Curzon, please pass him a microphone. We'll get his comments.
I mean, this is one of the fascinating areas of interventional cardiology, that we do have 3 randomized trials now that all show that there is benefit to the patient of doing non-culprit disease as early as possible. In fact, the majority of patients in these trials were done at the index, but even so, none of us believe it. Isn't it fascinating that we like randomized trials? We've got 3 trials that all show that complete revascularization is beneficial before the patient goes home, probably by doing it at the index. And there's hardly anyone in the room who does that, including me.
Now, I think you're going to be able to give us some data over the next few years. Do you want to talk us briefly about the type of data you're going to hopefully be able to present in a few years regarding timing? Isn't that part of the prime time study?
Yeah, I mean, I was one of the culprit investigating team, and I think in retrospect, and this is a personal opinion, not for the other people on the steering committee, I think despite a power calculation saying that 300 patients was enough, it clearly isn't. And if you look at the difference in endpoints, you had sort of 11 in one side and 4 on another. We can't change our practice, which is a bit counterintuitive on those numbers. So we're designing Prime Time, which is a very much larger trial, and it will try and answer all the questions you want to know in one go. So it's very ambitious, but one of the things it will randomize to is complete revascularization on the index admission or staged a few weeks later, because that latter strategy is the one that intuitively appeals to most of us, I think. Not many people. There are some. Keith Oldroyd, for example, has no problem at all with taking on a really complex non-culprit lesion when he's just reopened a STEMI vessel. But for me, I'm a bit of a wimp, so I like to just get the STEMI vessel open, get the patient safe, settle down, and then do it again. So I think we're going to look at that, and hopefully that will give us an answer to whether staged is as good as in hospital.
Well, should we then proceed with FFR? And while you're doing this, I'll turn the question that you asked us back around, intracoronary versus intravenous adenosine. What's your strategy for this case? Just a brief note before you do this so we can see it a bit better. Is it possible for you to switch from showing us the angio, which takes up a large amount of the screen, to just focusing on you so we can see how you set up the wire and the console? Perfect, perfect. There it is. Thank you.
Yes, thank you. So now, this is how the device looks like, just like that of the sterile container. So this is how the physician receives it in hand. There's one small plastic lid that I need to pop off, and with this I'm done. Now you see two connectors right here. One is real wire, one is wireless. Now all I need to do is pass this on to my colleague right here. There's one connector right here, and the other one, and we're going to switch the camera. And this is how you insert the two devices. You see a yellow blinking light, which will start blinking green, and when it's full green, like such, the system is ready to be used. Now, as I have heard and understood, the system has a self-sealing method, and if I'm not mistaken, we can flush it right now, and then it's ready for use. And I'll show you this again. Very good. So this is the system right here. Insert the tube, flush it with normal saline, and it's basically ready to go. The tip, I'll show you in a minute.
Now, just to highlight some differences that you've already done in your setup, first you connected and then you flushed. Is that your standard practice just for the Opsens wire, or is that something that you do with the other products?
No, this is standard practice for the Opsens product. We received specific instructions to do it this way, because this is the design feature of the product.
And then second is you connected the wire port there. I think I heard the machine beep and zero itself. It wasn't easy for you to zoom up on the screen, but as I understand, up in the upper left now, it is already zeroed already. That's not something that you need to manually hit a button as on some of the other consoles.
No, the system is totally automatic. We plug in the two adapters, and then the system, as you said, beeps, zeroes itself, we flash it to stay line, and it's ready to be used. If I can get a close-up right here, zoom, please. This way, that's easy. And one more bit of zoom, please. Okay,
Yeah.
You see it, but it's a standard 35mm long radio back edge of the wire, similar to the same product. It's very comfortable, it's very, very easily shapeable, and as you understand, and I've tried it out myself, it has excellent torque response, this device. So, as we spoke, I'll give it to my colleague now.
And just to highlight another difference that you mentioned right there, and that's that this portion of the radiopaque tip is 35 millimeters long in contrast to the 30 from the other. Sometimes I certainly use that radiopaque portion to judge stent length when I have the wire in the vessel, and it's just important to remember that instead of being 3 centimeters, now it's 3.5 centimeters in case you use that for gauging stent length.
Yes, exactly. This is the same use. Now, I've asked my colleagues to show us the angio.
I would like to highlight one of my points. For the piezoelectric wires to work, there are 3 electrical cables within the wire. In this wire, we only have 1. And that runs exactly in the very center of this wire, surrounded in a complete 160-degree circle by machinal. And this makes this wire highly portable, and this is probably one of the advantages. As they say, it's pretty much like a low-cost wire. Of course, it is light-based, and it can only measure pressure. It cannot measure temperature. As compared to the same wire, which is capable of interrogating microvasculature, do IR measurements for the nerve. This is only for pressure measurement. But anyway, that's the most important interest for all those measurements. I took a needle, I shaped it. And one important and one big point is that I can disconnect and reconnect as many times as I want. It's light-based, optical, and therefore we do not fear the loss of signal. It's very stable. So,
Thank you, please.
In terms of technical and design, I mean, this is obviously a small new company on the field. I mean, this wire was first launched as an hydrophobic coating, and the company developed an hydrophilic coating to increase the, I would say, talkability properties and trackability properties. So now everybody in the world has the hydrophilic version 2 type of diopter wire.
What we do now is standard practice. We will equalize two systems.
Can we see the screen of the diopter monitor, please? Because it's nice to show how it is fast. And can we?
So again, we see the same features as we always see with pressure wires. There are two systems, this time one in red, one in green, and of course they do not measure the same pressure a priori, and therefore we'll have to make them equal. This is called equalization, and it should be done at the very tip of the diaphragm, preferably in the ascending aorta. I didn't think in the left main because it's completely normalized, I think, so I'm not afraid of doing any wrong measurement there. One nice feature is that I can disconnect at this point, or even before, and I can remove the needle, and I can negotiate the wire much easily.
Maybe while you're negotiating the vessel, Zolt, if someone could zoom down and just show us the end where you disconnected from, just to show us how that happens technically. I have this wonderful movie that I made in Eindhoven where we inject all kinds of blood and saline into the connector and you're still able to reconnect immediately. And so unlike some of the other products where a lot of attention has to be given to keeping that connection dry and clean, this one seems to be a bit more resilient.
The second aspect technically is that I do know that there was emphasis. When you connect, you immediately hear a sound. So you don't have to try to be very cautious. You just connect and you hear the sound. So it's very user-friendly.
Yes, that's true. And immediately we have the figures on the screen. Guys, see?
Yeah, so now it says no sig, which means no signal because you've disconnected so that you can wire the vessel. So that's the clue that the monitor gives you that you've disconnected. While you're wiring the vessel, what was going to be your approach for hyperemia? You'd ask the question IC or IV. What's your practice there?
For me, the fixed principle says IC. But of course, if you wish to have IV and embassy will be on board, so we can do it.
That's really both available because we are anticipating the question, and to be on the safe side, we prepare both. We have an IV and also an IC.
The question is relevant because if you take on a small branch, so if you pay close attention to the LED, it's not only one discrete bridge, but also a bridging, which might be seen in the mid portion of the LED.
Just for the sake of demonstration, so can you just disconnect and reconnect so you're going to see how it's speedy and how they can hear the sound?
Disconnect it now. Reconnect it. The lag is less than 1 second.
And what we have now is the rest, PD on PA and rest, without nitro, without contrast, without anything. It's 0.87. So this time we always take a shot to see where we are actually, where we're making the measurements. It's actually
That's my best position, I think.
I would go more distal.
You see that the contrast FFR already is 0.80. I'd like to have your comments on that.
It's, I think, a wonderful demonstration. So we already know that this lesion is going to be significant. The contrast FFR has got us to 80, so you know that adenosine will at least get you to 80, if not lower. So if you were simply interested in a yes-no question, you've already answered your question. And you can see how fast that happened. And typically my own practice is to document wire position anyway, so that when I go back to the films, I can understand where I made the measurement. And you probably gave an injection of how many cc's there, Jolt? Yeah, so with 5 cc's of contrast, you've answered the question. Now, I think it's useful for this demonstration purpose to go ahead and measure the FFR, but
Focus,
it's slightly out of focus. It looks like you're in the 70s.
It's 0.76 right now.
And now it's coming back. So again, I think this is a perfect demonstration of something like contrast FFR. We knew that it was going to be significant. Now you could say, was it going to be 76? Was it going to be 62? You can't predict that, but what you can predict is which direction it's going to go. So again, we had the green light before with just contrast FFR. Now that green light has gotten even greener with the adenosine. You know, I think it's good to repeat it. I think that's good practice to make sure that you've got a good measurement. Another useful part of contrast, and again, full disclosure, I did the contrast study, so you know it's something that I've had some passion for. But let's say you do contrast FFR and you say, okay, it got down to 80, and then you give adenosine and you get a value like 83. Well, what that suggests is that most of your adenosine didn't go down the coronary artery. It maybe went through side holes or went into the aortic root. So in a way, it's another double safety check of which direction things go. If contrast gets you to a certain level and you don't get there with adenosine, you probably need to repeat your adenosine with proper technique to make sure that it all got delivered into the coronary artery. So in that way, it's nice to have consistency, and you need to look for that with all of the measurements.
And we just started our second measurement.
You know what? I think this is wonderful. You've repeated the value. You got 76. You got 75 the first time. So within plus or minus 0.01, that's absolutely stable. Oh, now it's 74. All right. So now it's the other side.
And that's again a reassuring feature. If I make a difference of more than 0.03, I think that something is wrong with me. Usually.
In terms of features, I think that Nico pointed this morning, which is very important, because the same system, when you start to inject, you start to record, and then the machine will automatically jump on the lowest value. You have to make sure sometimes to correct yourself, and you are in the plateau phase to make sure, because the machine can be, let's say, a little bit over-optimistic, jump on the first value, and sometimes, because when you do IC, it's basically too fast.
Well, and again, you Yes, and I would say that in the interest of time, we're going to move ahead here with the afternoon series of lectures. I thank you for showing us this great portion of the FFR case. You're going to go ahead with PCI, and maybe we'll come back to you after the session, and you can show us the final results, maybe even a post-PCI FFR, since that's one of the topics that we're going to be talking about. And we'll come back to you then. So we're going to give you a round of applause. Thank you, and we'll look for the follow-up.
Thank you.
All right, so we'll move right ahead with the session. Dr. Curzon's going to come up to us and continue his discussion of FFR-CT with a view to the future.
So these are the potential conflicts of interest, and they're all potentially relevant to imaging, coronaries, and physiology. So just to recap what we know so far, that in patients with cardiac chest pain, knowing the coronary anatomy is useful, but the target for revascularization is patient-level and lesion-specific ischemia. So multiple studies have shown a consistent modifying effect on the angio-guided management when invasive FFR data are available. Despite all of this, penetration for the use of invasive FFR is low. Otherwise, there wouldn't be a need to have a day like this. And the question really is, why is the penetration of invasive FFR low? The data are absolutely convincing. So maybe one thing that will change in the future is that we do less of this work invasively, and we have done more of it before the patient ever gets to your cath lab in the first place. And that's where the future probably lies for a lot of patients. Certainly we may well be able to triage patients so that they don't need an angiogram to tell us that you guys who are interventional cardiologists aren't interested in them. We could have avoided you ever having to meet them. So the last talk, we know that CT angiography is increasingly accurate in people who are suitable for it. And the recent development of FFR-CT allows for the derivation of FFR from a supercomputer modeling system whose accuracy is quite well established. And the platform data shows great promise that at least you might be able to wean out the patients who turn out not to have coronary disease so that they don't go to a cath lab. And this may be a cost-effective way of screening new patients. In the UK, we have a system called rapid access chest pain clinics, which occur in all hospitals, where patients with new onset of possible angina have to be seen within 2 weeks. And in those patients, the number of people who turn out to have significant coronary disease is around about 13%. So you certainly don't want 100% of them going for an angiogram. You don't want most of them going for a test because, as Colin said, it takes weeks to get them a stress echo and then a result and then an angiogram. So this is, in principle, very attractive. But there are other things that are attractive about being able to tell someone's anatomy and whether they're ischemic from a single non-invasive test. Take the case you've just seen. I guess that patient, before he had the plaque rupture in his right coronary, would have been walking around with that LAD just like that for a few years. Why is it now that we're suddenly interested enough to bring him back to the cath lab and see whether it's causing ischemia? We weren't interested a week ago before he had his STEMI. So why are we interested now? Do we actually know that someone who's never had any symptoms from this artery has any prognostic outcome association with that LAD? Not really. In fact, interestingly, in culprit, we did 2 sub-studies, one an MRI study, and every patient in culprit had a nuclear perfusion scan. And the spooky thing was, even though there was a clear benefit from complete revascularization of the non-culprit vessels, there was no difference in the extent of ischemia between the group that just had the culprit artery done and the group that had complete revasc. So it doesn't look like this is driven by ischemia, this difference. So the point I'm really making is, there's just so much we don't know about having coronary disease and being ischemic by virtue of it. In fact, some people in the audience must have some quite bad coronary disease. But the scary thing is none of us know it. And certainly no one could point to any particular member of the people in this room and say, that person's going to have a heart attack and that person is not. But imagine if we had such a good non-invasive system that we would one day be able to tell which of you are sitting there with bad coronary disease, but also which of you have ischemia, and whether or not that predicts whether you're going to have a heart attack and you're not. So we know what we already know, but we need to work out what we don't know. And what we don't know is whether FFR-CT actually works. We need to know whether it affects decision-making and management in a similar way to FFR that's done invasively. And we need to know whether it's associated with clinical outcome. That's all. So there's quite a lot that we need to know. Now, one of the things I was interested to do when I first heard about FFR-CT was to see whether it did the same thing as invasive FFR did if you did it routinely at diagnostic angiography. So with the help of an unrestricted grant from HeartFlow, I repeated the ripcord study in a non-invasive population. So I took 200 cases from the NXT trial, which I showed you before, and we did exactly the same thing as we did in ripcord. Now, you will remember this. The basis of why invasive FFR changes our management is because it highlights this single fact, which I hope is now ingrained in your mind, that when you look at an angiogram, a tightish-looking lesion doesn't necessarily mean ischemia, and a mild or moderate lesion doesn't necessarily mean no ischemia. That's a simple fact of life that's very well established. But is it true if you do CT angiography and FFR-CT? So this study, which was called FFR-CT ripcord, asked that in the assessment of patients with stable chest pain, did the availability of non-invasive FFR-CT, in addition to the coronary anatomy from a CT scan, lead to a change in the interpretation of lesion level significance, and therefore did it lead to a change in management as we had seen in the invasive ripcord study? The primary endpoint was the difference in management between the CT angiographic data alone and the FFR-CT data derived from the CT angiogram. And the secondary endpoints were the correlation between angiographic and physiological appearances and a comparison between arteries labeled as being targets for revasc by angiogram and FFR, just like in the original study. Just to give you an idea, this is a sort of typical case that was published from the de facto study, showing an idealized version of what an invasive and non-invasive angiogram looked like, and the output from FFR-CT. And just to remind you, the trial from which these 200 cases were derived was the one that established quite high diagnostic accuracy for FFR-CT using invasive FFR as a reference. So this is how it was done. 200 cases. The CT angiogram was reviewed by 3 interventional cardiologists who have experience of doing that, but also with the availability of a specialist report from an expert in CT angiography. And by consensus, we came to a management plan for each case, assuming they all had a stable angina, which included optimal medical therapy, PCI, CABG, or more information required, which in this instance meant they should go to the cathlab and have it done invasively with an invasive FFR. And then the FFR-CT data were revealed for each vessel in each case, and we were invited to redo that management plan by consensus. So just like the invasive ripcord, we had an angiogram-derived plan and an FFR-CT-derived plan, and we compared them. Now, here is the division of the CT angiographic data for lesions by their severity on the x-axis. So 1 to 29%, 30 to 50%, etc. And then they're subdivided into white and red. Red indicates that they were FFR-CT positive with an FFR-CT of less than 0.8, and white indicates that they were FFR-CT negative. The first thing that you can see is that even in lesions that were angiographically between 1 and 29%, 2.5% of them were FFR-CT positive, indicating they were ischemic. And 6.4% of those with lesions between 30 and 50% and so on. It also means that 13% of people with more than 90% lesions on the angiogram were FFR-CT negative. So this mimics absolutely exactly the graph I showed you from all those invasive studies showing that there is indeed a discrepancy between the CT angiographic appearances and the physiology derived by the supercomputer. So the same principle. And as a consequence, the management was changed in these cases in exactly a similar type of way to what we saw invasively in 36% of the cases. We changed our management because we had the FFR-CT data. And the management, you'll be familiar with these graphs now, so right on the far side you see the original angiographic-derived decision. And then the changes that were made, and every group changed in every direction. And I can summarize the changes for you. So after FFR-CT was available, 26% of people that we felt required more information based just on the CT angiogram, we decided actually needed revascularization. 12% of those who were originally allocated to optimal medical therapy required revascularization. And 30% of the PCI patients were downgraded to saying there was no ischemia and they just need optimal medical therapy. Probably, I think the most scary thing of all, which was exactly similar to the invasive ripcord study, is that in nearly 20% of people who were allocated to PCI based on the angiogram, they stayed allocated to PCI, but it was a different vessel that represented the target. And we've seen that over and over again in this type of study invasively. So on the left here, we see more information required, optimal medical therapy, and people who were put forward for revas based on the angiogram, and just follow what happens to them. So obviously the ones who needed more information, we had the information, so they were allocated accordingly. From the group who were originally allocated to optimal medical therapy, most of them stayed in optimal medical therapy, but some of them required revasc. And a lot of the people who had been originally put down for revasc were reallocated to optimal medical therapy. This is very similar to the outcome from the original invasive ripcord study. And overall, 44% of patients had some kind of change in their assessment, leading to a proper management change in 36%. So from this study, we can say that the same mismatch that we saw invasively is now being demonstrated from a completely non-invasive model using CT angiography and FFR-CT. And that the same explanation is that there's a mismatch between what you see on the angiogram and what you see on the derived physiology. And these are completely consistent with the invasive ripcord study. And this is just proof of concept, I understand that. But it needs more large-scale trials, but it suggests that FFR-CT has the potential to be used as a screening tool, for example, in new patients arriving as outpatients to be assessed. And it could become a default assessment. Instead of doing lots of different types of stress tests and some angiograms, you've already seen its ability to reduce the number of invasive angiograms that are required. So how does this effect compare with the studies that I showed you earlier using invasive FFR to look at the effect on angiographic outcome? Well, here are the studies I showed you earlier with a 22 to 48% effect on management strategy using invasive FFR and angiography. And here's the FFR-CT ripcord trial. It sits perfectly in the middle of that range. This is a really promising result and suggests that we may be able to use this as a non-invasive screening test for patients. Bill Fearon wrote an editorial to go with this paper, and the most important thing that came out of it was this chart of the diagnostic accuracy of various different tests. Now, FFR is the one in the top right-hand corner, And you can't get better than being in the top right-hand corner. But FFRCT, these ones in orange, and it's very, very promising. As I said, the National Institute for Health and Care Excellence in the UK, which governs the way that doctors work, has done a technology appraisal of this. Now, this is not a guideline, so people will not be able to change their practice because it won't be paid for until it's a guideline. But the preliminary findings of this, which are still under review, are very, very promising for FFRCT. I feel that we now need a definitive randomized trial of the role of FFRCT as a default screening test in people who present with chest pain, and that's what I'm working on at the moment, a trial called Forecast. But what are the potential uses of a technology that tell you the angiographic and anatomical data and the physiology non-invasively? Well, it's a much, much bigger field than the one that we're looking at. Potentially it's a one-stop assessment of patients who have never had anything wrong with their heart. Could it tell prognosis in people just by seeing whether they're ischemic or not? People who've never had any symptoms. I think we're just scratching the surface of this type of technology. I have no association with heart flow, so I don't know whether it will be the heart flow system or one of the other systems. But I think in the not too distant future, non-invasive assessment of patients, and possibly even people who aren't yet patients, may well change the whole way we work in cardiovascular medicine and may change our way of assessing risk. For example, how many of us are really that comfortable with the number of patients we're now applying statin therapy to in the hope of saving some events? A huge proportion of people that you and I are giving statins or ramipril to are never going to have a cardiovascular event. They're going to die of something else. But we give it to everyone to stop the people who are going to have an event from having one, hopefully. Wouldn't it be better one day if we knew which of the people in the room were going to have the heart attack in a much more accurate way and lavish them with all the primary prevention therapy? Thanks very much.
Thanks, Dick. You know what we're going to do is we'll save questions for the end because we want to go back to Semmelweis now for a follow-up of the live case, and then we'll move on to our next lecture. Hello again. We're here. Can you hear us? We're interested in what happened.
Procedure, and we'd like you to have a look first at the angiome of our...
So this is where we left you.
Yes.
The pressure wire in place, it was significant, so we dilated it with a 2 by 20 millimeter balloon.
Can we have the angio? Can we have the angio?
Oh yeah, we will have better vision then. Just a second. So we pre-dilated the lesion.
Okay.
Can you see? Yeah. So this is where we left you. This is the next one is the pre-dilatation with a 2 balloon, and then we went on to place a 3 by 26 millimeter drug-eluting stent, second generation drug-eluting stent. I was playing a little with the system. I wanted to measure the wedge pressure. It was pretty high, actually. It was 23 millimeters of mercury. If we can switch the camera to the monitor, we recorded that too. No, it's not the last. It's 2 or 3 recordings before. Okay, so there we go. So this is the recording of the wedge pressure, and then we post-dilated the drug-eluting stent, which was placed at 12 atmospheres by a 3 by 15 millimeter non-compliant balloon at 20 atmospheres, and we arrived at an acceptable angiographic result. But of course, we, as you asked us, insist on doing post-PCI FFR, so we did. Can we go to the next measurement, please? And of course, in a large LED that runs all the way around the apex, it is our experience that the post-PCI FFR may prove to be pretty bad. And in this case, it was pretty bad. It was not 0.92 as you see, but what we measured was 0.83, and on the second time it was 82. So the post-PCI FFR can be either as bad as that, or there can be a mistake. There are 4 sources of error. First, not error, but 4 explanations for this low finding. First, it may be a tandem lesion, which we neglected so far. It may be diffuse disease. It may be under-expanded stent, or it may be drift. The only way to choose among those and to decide which one is the correct answer is to do a pullback, of course, preferably under constant hyperemia. We did a pullback, and much to our surprise, the explanation was drift. We had, at the tip of the guiding catheter, we had an PDPA ratio of 0.93. So at that point, of course, we re-equalized and re-entered the LAD, went back to the same position, and made the same measurement twice, and this time it was 0.92 and 91. So it's bad for the system. It's good for the patient to have a higher post-PCI FFR, and it's better for the interventionalist also to have a higher figure. Of course, this system is not without drift, apparently, or we may have done something wrong. I think what is important to emphasize is a thorough flushing, because we need to get rid of the contrast. It has a different viscosity from saline, but we kept flushing the system all the time. So at this time, I think we have concluded the case. It was a significant LAD, an unculprit lesion in a patient treated a little over 48 hours ago by primary PCI to the right coronary artery. The right coronary artery is widely patent, and the patient now has full revascularization guided by functional measurement. And with that, we would like to thank you very much for your kind attention.
Thank you very much indeed.
Thank you very much too.
Well, that's actually the perfect segue into the next talk of this session. Dr. Bertrand is going to come up and talk with us about post-PCI FFR measurements. The time is coming.
This is not my computer. It's not yours? No. Where's the muzzle?
The other, Olivier, do you want to swap order? We can do that if you're looking for the right laptop. Or you found it?
I thought they had uploaded my talk, but I mean, it's
okay.
I can do this. Okay, just give me. Okay, so thank you for this opportunity to discuss with you one topic which I've become more recently very much interested in. And if you had the feeling that the field sometimes can be complicated or complex, I think that since I've been doing post-PCI FFR, it may also become even more complex on a daily practice. So these are my disclosure. As you see, I've maybe been working with Absence since the early days of the wire. And I, of course, in charge of part of this meeting, but I don't get any personal honorarium or support from my chair. So I'm just going to show you one case I showed last year at ESC meeting when in fact, I became interested about FFR. And I have to admit that prior using the fiber optic system, I never did any post-PCI FFR. I was just fed up with the problem of reconnectivity, and just by learning how easy it has become, that I thought, oh, maybe we should perhaps get some more information. So very quickly, this is an old patient presenting with a crescendo angina, positive exercise test. He has, as you see, glucose intolerance, and he's hypertensive. So very, very quickly, I mean, so the guy has a moderate to severe tandem lesion on the LAD. He has a moderate lesion on the circ. You see here, so you see there is a severe lesion, there is a second lesion, and there is also some disease on the diagonal. For the sake of time, I'm just going to show you, so this is the pre. You see that the first lesion is pretty tight. And so I was interested to see also the impact of the balloon angioplasty compared to the stent technique as we use now. So I did the diagonal and the circumflex, and FFR was above 80. So I went into the proceed with the LED. This is the first FFR prior the PCI. I have to admit that whatever the baseline value, I always do maximal hyperemia using IC adenosine, or routine practices nitro plus 300 on the left and nitro plus 150 on the right. And basically, we provoke a lot of AV block, but we like it because it proves that the patient has received the drug. We ask the patient to cough, obviously, not to lost consciousness, and it works fine. So in this case, it's quite also very severe. I'm also interested to see the pressure gradient going upward after the intervention. So this is, you would agree, a significant lesion. So I pre-dilate with a 2-0 balloon. I usually go direct stenting, 5 French as much as I can, but for the sake of this case, I use pre-dilatation with a 2-0 balloon, and I did the FFR. So you see there is just mild, let's say, improvement. At the time, we had some improvement. It's obviously a suboptimal result. So there is an increase in the FFR value. So I went with a 3-0 balloon, like the old days of a balloon angioplasty, and I'm crossing the threshold, if you wish, but I mean, probably it's not considered a nice result now. So I went with a stent implantation, and so you see, obviously, as you have seen here, we use the opto wire as the PCI wire. We went with the dilatation. My routine is to use 22 atmosphere for 1 minute. I like to stay for quite a significant amount of time. It has been shown by others that you get a better geometrical result with a long inflation, and that's my result. And at the time, I must say that I was influenced by the literature, and you know that some people, and we're going to discuss, have been describing the 0.90 value that you get after FFR. So I was optimistic that I will have a very nice result. You see there is, and you will agree with me, a mild overexpansion of the stent. So for me, it was the end of it. And I would confess that without anything, I would have stopped. So these are, on two views, the results. I think you would agree it's a nice TCT-like, if I may say, stent result. And then we go with the FFR, and I have 84, sorry. So I'm at the end of my case. It's a perfect angiographic result. I'm pretty confident that my stent is well expanded, and I'm done. The patient is 84, and I think it's pretty interesting. So I was just surprised that I just get a value of 84, and you know, I was thinking, okay, there is something wrong, or what's happening. So that was the impetus for one of my PhD students to go into the literature. I think at the time, or pretty close to that time, there is a very interesting paper from Niels that was published in JACC Intervention. I would encourage you to read the paper. It's discussing, including very individual data as well as some study level data. It just showed one slide this morning. I didn't have time to repeat, but we're basically going to show the same thing. And also discussing a lot of pre-PCI FFR. It's a landmark study, so I will encourage you to read. So basically, we went into going to the literature around all the studies which have reported post-PCI FFR starting in the very early days. And these are the results. So it's pretty straightforward. You see that, in fact, starting in 95, so people have been doing post-PCI FFRs in, let's say, quite a long time now. Until, and I think that we closed the review in 2015. There has been another recent paper from Arkansas when they described the post-PCI FFR. And you see that there is a wide variation into the results. There is no trend over time. I just put the red dots, and the red dots are the balloon angioplasty alone, so the old PTCA, if you wish. And you see there is no clear trend for higher value compared with stenting. So in fact, when you look at the incidence, it's a normal distribution. And again, as it's the magical number, you get a 0.90 plus minus 0.04. But you can also see from the gray zone that, in fact, 80% of the value you will collect after PCI will be comprised between 85 and 95, 0.85 and 95. So this is some, I would say, obvious results. I mean, of course, the more you get stents into the study, remember there are limitations of the study level, so we don't have the exact value, but the more you get stenting compared to balloon angioplasty, the higher post-PCI FFR value. This is a classical question we got all the time, and this is also something we got asked by the peer review system, that is there a difference between DS and BMS? In fact, if you think for 5 seconds, I would say you should not anticipate any difference acutely between a BMS and a DS. A stent is a stent, it's providing scaffolding to the wall, and it's obviously something which might be different when you think down the road. If you go 6 months later and then you have more neointima, obviously you may have different FFR value. So like shown here, there is no difference acutely between DS and BMS. So again, we look at some of the correlations and trying to see if there is any data that could be correlated with the post-PCI FFR. And you see, again, in terms of science, you get some significant p-values, but as we have seen since this morning, in fact, it's very scattered. So in terms of the management of an individual patient, you cannot really use any of those data to predict the post-PCI FFR. I would just draw your attention on the lower right that it seems to me quite interesting that there is a relationship with the post-PCI FFR with the pre-PCI FFR. So I'm coming to the two most important graphic, if I may say. And so we'll look if by meta-regression, if there is any relationship between the mean post-PCI FFR and the risk of repeat intervention. So remember that we're basically assessing the physiology of the tubing system, if I may say. And it's quite interesting that indeed you see that the higher the post-PCI value afterward, the less risk of repeat intervention you have. So that's a very significant message. And if you do some more computation, you see that you get an odds ratio using the threshold of the 0.90 of more than 50% relative reduction in the risk of repeat PCI. So I think this is quite a quite meaningful intervention. And you have also to take into consideration the limitations of such a study. This is a study level which has been covering almost 20 years. So there is a mix of balloon angioplasty, stent technique, different types of BMS. So it's quite striking to see that there seems to have a clear message, which has been shown again in the paper from Niels and his group when he was having access to the individual patient data that basically show that the higher value afterwards, and you see that there is a relation with the risk of repeat intervention. But what may also perhaps in the future become game-changing is that it seems also that there might be a relationship with the post-PCI immediate FFR value and the risk of MACE. And in that study, we use MACE as the combination of death, MI, and repeat revascularization, which was a mixed bag, depending on the study, of repeat TVR, TLR, or vessel intervention. So, of course, we have lost some of the strength, but again, in terms of statistical significance and relationship, you see again that if you use the cutoff value that you're going to get in, let's say, 50% of the cases, because it's, as I said, a normal distribution, you're gonna get, I would say, a clinically significant message that you have a 30% potential risk reduction in the risk of MACE. And I think that that's the basis that maybe we think that we have been discussing using physiology beforehand since this morning. And I would say that I'm pretty excited that maybe someday we have to think also of using physiology after the intervention. In fact, if you think for I would say 10 seconds, it doesn't make sense to make an intervention and just by suddenly liking the oculostenotic reflex like we used to say many years ago, that so basically probably we also do need, and we would need to have something that could assess the physiology of our intervention. Of course, I would admit that the more I do post-PCI FFR, the more the field looks complicated. And I would just illustrate what we have been using in that manuscript. I think the most important, if you take apart the issue with the stent expansion, and that I'm pretty confident that in 2016 using high pressure inflation and larger balloon that we do know how to have a stent well expanded. There has been very nice studies done by Nico Pels in the around 95 or 96, if I remember correctly. At that time, we were still learning how to deploy stent. So I think we have learned this. But when you take into the consideration the lower value that you can get, like I showed you in my case, well, I mean, you have to remember that atherosclerosis is a diffuse process. So the stenting is basically a segmental treatment of a completely diffuse process. So in summary, and if like Niels was suggesting, if you think in terms of binary response, you may have two main principal scenarios. On the left side, you just have more or less a focal lesion. Probably your FFR value will be positive beforehand. And if you remove any obstruction, well, I mean, probably your FFR will be very close to 1 afterwards. But in reality, and we don't know exactly for how much percentage, if you have that focal lesion which is embedded in a diffuse disease, depending on that diffuse disease and the segmental significant lesion or angiographically not significant lesion, well, then you will probably have a range of value afterward. And that probably may explain why in this very old patient, I mean, despite the fact that you would agree that I have a very nice stent result, I cannot get to the 0.90. I just would like to be, maybe that's for the question phase, but the more I do cases, I mean, to me, it's almost impossible in the type of patient I treat in Canada to get a value above 90 in the LAD. I mean, I used to go very distal, and I would tell you that I'm very surprised when I get above 90. 90 is very easy to get it in the circumflex or in the right, but to me, in the LAD, it's very difficult. So this brings me to the future, as the talk of the topic of my talk was. And you see here is just simple pictures taken from Absorb. So, you know, nothing related with the physiology, but just to make you think as an interventional cardiologist, which as we should all be, is treating physician. And it's quite striking that in a study when you have like 1 or 2 lesions treated, and you compare two best-in-class, let's say, DES compared with the biodegradable stent, and when you look after 1 year, I mean, 30% of our patients have still angina. And in those stable patients, the only reason, as we all agree, that we put stent in to remove ischemia and remove symptoms. So it means that even in a selected population, like in this trial, after 1 year, we still have 30% of patients who remain symptomatic. Of course, these are symptoms based on questionnaire, but if you look in the same paper, which was published in Lancet, I forgot to put the reference, but if you look at the objective testing in those patients, and you see that we are talking about almost 20% at 6 months and 10 to 15% at 1 year of patients who still have objective evidence of symptoms or ischemia based on those testing. So I think that just shows that we have much room for improvement of practice. And so that's why I believe that And I'm hopeful that in a few months we're going to be able to start what I call the PREDICT registry, when we will measure, again in some practical trial, which I've been always using my all-comers trials, when we will measure the final FFR after successful PCI, depending on the standard definition. We're going to use all-comers. We don't want to have exclusion criteria. And we basically will follow patients up to 2 years. Which I would like to have the angina score as well, and the sample size, we will need around 700 patients to get enough TVR and MACE to make a meaningful conclusion. So in conclusion, I think that this new fiber optic based FFR, for the sake of being unbranded, you know that there are now the Volcano and the St. Jude system are both based on piezoelectric system. Then you have the OPSAR system, which is now worldwide approved, and you have Boston Scientific, which is also working on the fiber optic FFR pressure wire, which is becoming available. So the future is bright. I would say there is new kids on the block, and it's good for the field. Now, I mean, I think that we will have also the tool to get post-PCI FFR easily obtained, and we perhaps can move the field also to use FFR as a prognostic tool for the assessment after PCI. Thank you for your attention.
Thank you so much. We're going to, again, save all the Q&A discussion for the end. We'll move ahead now to Dr. Ruza, who's going to be talking to us about using FFR outside of the coronary circulation, in this case, looking at it in peripheral disease.
Okay, some words about peripheral circulation. As a cardiologist, angiologist, we are doing now much more pressure via measurements in the peripheral circulation than previously. So which are the potential applications of the pressure via measurements? One is supraortic vessel, visceral artery like renal artery, and lower limbs. We have only one study, one validation study with the intracranial and extracranial vessels. They were dilated, these vessels, and they saw a nice drop in the pressures, but they don't have long-term results, and I think this is only one study with 12 patients, so we need to have much more detailed studies in this field, but might be very, very important, because we know that carotid stenting in not so severe lesions might cause big problems. Renal arteries, it was much more properly investigated. We know that the indication of the renal angioplasty is bigger than 50% stenosis, uncontrolled hypertension, poor or decreasing renal function, unstable angina. But we know that from studies that hypertension improves only in small amount of the patients. Renal functions improved only 27% of the patients. We have a high restenosis rate, major complications rate, and we know from CORAL study that the 5-year results of the renal stenting are the same as the medical treatment. But now with the renal FFR, we have some positive results. We see that if the renal FFR was lower than 0.8, we had a better decrease in blood pressure. Despite this data, now in a Polish group by Kaziella, they showed that these results, if you measure the ABPM pressure, are not real, and that they don't see any positive effects in renal FFR measurements. So these results are not promising, but I hope with the better patient selection we can have more reliable and promising data. Despite this, we can see that the FFR in the renal 0.8, less than 0.8, and the systolic gradient under hyperemia bigger than 21 mercury show us that the lesion in the renal artery is significant. I show one case. It was a case with a worsening hypertension, and the patient had ischemia, but the blood pressure was more than 200 mercury with 4 drugs. This patient had a left renal stenosis and right renal stenosis, and this is the coronary angiography. It was performed 4 months before the DSA, showing a non-significant lesion in the LAD. So we checked the renal, which was not significant, but the LAD was significant. So in this patient, we done LAD stenting, and the worsening hypertension disappeared, and the patient was symptom-free in both. So we didn't do renal angioplasty after the pressure via measurement, but we have done an LAD stenting. In lower limb vessels, now there's huge progress, so we are investigating much more the pressures in the iliacs, femorals, and below the knees. Now we must highlight that the patient, the physiology was changed after the patient was walking, because we are the first animal who has the SFE. And we know that the pressures in the lower limb are much more higher than in the upper limb. This is not the same in the heart, because the heart is only 10 centimeters long. But I think this is very important. So iliac stenosis was, there was some studies with correlating the iliac pressures with the pressure wire under hyperemia and under rest, and we can see very good correlation with the post-exercise Engelbrecht index at hyperemia and at rest. The slopes are promising. In femoral artery, we have much more studies. There was a dose-dependent exam to examine which dose of papaverine is causing good hyperemia, and it was shown that the 30 milligrams of papaverine is effective in the femoral circulation. There is a paper about the peak systolic velocity, and the final FFR is a post PTA FFR, and we can see that the post PTA FFR has a positive impact in the restenosis, the same result as Olivier has discussed. Now we have a recent paper about the post PTA stent restenosis, and it was showed that the post PTA FFR showed a promising result to predict restenosis. The cutoff value was 0.92, so the values are a little bit different than in coronary arteries, but it seems that the pressure via measurement works in the peripheral circulation also. Our study, we are examining the patients with a much more critical condition, with a critical limb ischemia, which is characterized by ischemic pain, ankle pressure lower than 60 mercury, or toe pressure lower than 40 mercury. Distal perfusion results in tissue loss, infection, inflammation. The gold standard is still the angiography. We know that angiosome concept works in peripheral circulation, so each artery gives blood supply to the tissue of the foot. But when we are looking at the angiography, in short, the critical lesion is okay. We see with which is needed to dilate it, but in short borderline lesion, we don't know. In short lesions and haze is also, long multiple lesions also. Medial calcification in a patient is not easy to say. These are the typical lesions. So this one in diffuse CTO, I don't know which one to dilate. Maybe I can open all of them. Like in this case, we opened the anterior tibial artery and the popliteal one. In long lesion, we are dilating with a balloon, but I don't know the result, so I'm just doing a balloon dilatation. In focal lesions, very easy. I'm putting a stent or ballooning, but in these lesions, it is not easy to say. And we don't have any investigation, only the IVUS, but IVUS is not available in all cathlabs. Like in this our case, we stented the posterior tibial artery and the truncus. Pressure wire measurement in this part of circulation might work, but the venous part must be much more important due to the varicosity of the patients. So we excluded these patients from the study. So the aim of the study was to assess the correlation between non-invasively versus invasively measured parameters, and to assess the final distal pressure and PFFR, and to examine whether the post-PTA pressure and PFFR has a prognostic value of restenosis long-term changes. We examined 31 patients. Now we are at 40. Inclusion criteria was chronic critical limb ischemia and angiography proven significant lesion. We examined the patient with severe varicosity. We done angiography, pressure via measurement, EB 80, 2 pressure, peak systolic velocity, and laser Doppler. This is the flow chart. The laser Doppler we are using is a periflux system. We are measuring the laser Doppler perfusion unit and the transcutaneous oxygen saturation. The pressure via measurement we are doing as in coronary arteries. We are doing equalization. We are measuring before the intervention, after interventions, the delta P per the dystolic and the proximal pressure, and under Papa variant. These are the demographic data and geographic data. I will show plots. They will be much more better. Here we can see that there was a nice, the angiographic result was better, of course. Pressure via measurements, all the pressure via measurements improved after the intervention. Laser Doppler measurements, mostly the 2 pressure was improved, but the Doppler perfusion unit change was improved also. Here we can see the plots. These are the pressure via measurements. This is the resting pressure gradient. This is the resting PD per PE, and the fractional flow reserve. So all pressures were improved. Here are the laser Doppler measurements, and by ultrasonography we can see that mostly in the anterior tibial artery the peak systolic velocity has been increased. If we correlated the data with the laser Doppler, we can see that the Doppler perfusion unit change and the percentage change in the transcutaneous oxygen correlated significantly higher with the pressures, with the pressure gradient, with the PD per P, and with the FFR. We didn't investigate. We didn't make the correlation after the intervention, because these laser Doppler measurements are really getting better after months after the successful intervention. These are the correlation data between the QC and the pressure via measurements. It was a significant correlation between them. And this is the linear correlation. We can see it with area stenosis and resting PD per PE and fractional flow reserve, showing significant regression in both before and after the intervention. This is one patient. Here we can see a short lesion in the tibiofemoral trunk. It was stented directly with the stent. Here we can see the FFR measurement. It has improved after the intervention. Here is the pre and post procedural gradient. it had been decreased. The FFR increased, and FFR increased after stress also. And the percentage change in the laser Doppler perfusion unit and in oxygen saturation has been increased also. So it's a nice patient, but we must highlight that the values are totally different than in normal peripheral circulation. This is another type of patient. It's a short lesion balloon that it was stented. We had the same results, and the pressure gradient immediately decreased. The FFR at rest and the stress had been increased also. These are the laser Doppler data of this patient. So angiographic results, we have completed 90%, so I can't say that that is complete, but the patient, their clinical improvement is nice, and all procedures were done successfully. Limitation of the study is that the patient number is still low, so now we have 40 patients. We need to compare the vasodilatation effect of adenosine and papaverine because we don't have dose-dependent results. As a conclusion, we can say that pressure gradient and the change in the laser Doppler perfusion unit showed significant correlation in this patient group, but the tendency seems to be promising in all parameters. The invasive and non-invasive parameters improved in all patients after successful intervention. The intraarterial administration of papaverine caused significant change in microcirculation with change of distal pressure, but a real dose must be clarified, and further and larger patient studies are necessary. So I think this is the first step in this patient group, which is much more severe. But I think in this very diffuse disease, now with measuring the pressures, we can have an immediate result, and that's why important, which was not, we have done these procedures only by angiography. And this is a promising technique. And I think in 2-3 years, we will change the mind of radiologists to measure the pressure in the peripheral circulation also. So thank you very much.
All right, well, I'll invite the last speaker up, and then we'll have a little bit of a discussion for these talks. It's Dr. Kozeji, who's going to be discussing some of his work on fluid dynamic simulation of pressure gradients after stent implantation.
Mr. Chairman, ladies and gentlemen, it's a great pleasure for me to present some data about calculation of residual pressure gradient after stent implantation, even in this late afternoon. The first data about post-stent FFR measurement came from 2002 from the group of Nico Pies, who demonstrated that the lower the FFR, the worse the prognosis. So the adverse event was very high in case of residual pressure gradients. This data was confirmed for DES implantation also recently. So the prognostic value can be confirmed. And this said that we should measure the FFR before and after stenting. However, some questions arises, how do we exactly, just after the lesion or the stent, or as distal as possible? Of course, if we use hyperemic pullback, then we can have many data which can solve the answering the question. However, the evaluation of the data set of pullback measurement could require special consideration. I think this problem was addressed in this paper, and it can be familiar to our chair, because Olivier published this data, how affect the sensor position of the detectable FFR measurement. And of course, the more distal the sensor, the lower the FFR, but this relation can change the characterization of the FFR as normal or abnormal value. Another paper from Danish group also investigated this distal gradient in relation to the adverse event, and they found that the residual abnormal PD-PA ratio, distal trabecular stent, was an independent predictor of instant restenosis after implantation of the coronary bare metal stent. They found that in the restenotic group, it's the upper part of the diagram, there was a higher gradient distally of the implanted stent than for just after the stent, and it was significantly higher, of course, than the group without restenosis. So during the pullback, they measured the very distal FFR just after the stent and the proximal pressure. So they speculated that this distal gradient can have some effect on the flow turbulence, the flow abnormality, or this distal disease can affect the right stent expansion decision, because it is difficult to find the right reference segment. So the wall shear stress is a very well-defined factor of the prognosis. It is established that low shear stress is an adverse pro-arrhythmogenic factor. We can calculate the shear stress calculating the shear rate in a parabolic velocity profile, and we have to multiply by the dynamic viscosity. So it was said that the low shear stress is the pathological, but actually we have a case which shows that after a DES implantation with a little step-down phenomenon, when we modeled this flow after stenting, we can detect high shear stress at this step-down phenomenon, and later in the follow-up, we unfortunately noticed restenosis at this specific site. So sometimes not only the low shear stress, but in this specific case, the high shear stress was behind the restenosis. We can calculate the flow by the Navier-Stokes equations. I don't want to go into the details with these partial differential equations. However, we also have to know the exact anatomy of the vessel for modeling. For 3D reconstruction, we used the MEDIS program, which reconstructs the vessel from different projections, and we have a quite precise measurement of the length without shortening and the area, minimal lumen area, and reference area. Together with the Leiden group, we had some data for calculating the so-called image-based FFR measurement, also calculated by this ANSYS program using the Navier-Stokes equations. This method used the velocity measurement also by frame count measurements, and this was measured also during vasodilatation. So after adenosine, the frame count was determined and the velocity was calculated also for the pressure calculation. In other approach, when we know the exact pressure, then we can calculate the fluid dynamic model, in the fluid dynamic models, the velocity vectors, and we can appreciate the small vectors arrangement and the turbulence after a stenosis, how looks like, and it can detect the flow separation also. We also tried to calculate pressure gradient with other and more simple equations. We used the 3D reconstruction of the vessel, and we adapted some parameter from the 3D reconstruction for calculation the pressure gradient, and we also used the frame count during vasodilatation, and the velocity was transformed, of course, volumetric flow using the transaction area of the vessel and the velocity of the contrast. We use these classical equations for the flow description. One flow can be in the coronary the laminar flow, which is described by the Hagen-Poisson equation. In this equation, we have the lesion length and the area of the vessel, and it is related linearly of the volumetric flow. Another flow, and it can be more pathological, the turbulent flow, which is related in quadrant type to the volumetric flow, and it is also important the relation to the minimal lumen area and the distal reference area. When we calculate it with these simple equations, we get a quite similar pressure gradient than was the result from the ANSYS software, and the real measured value also was very close to these values. So we try to use this calculation even after stent implantation. We did the same calculation. However, in this case, after stenting, the turbulent flow is negligible regarding the area relations of the vessel. So practically, this will be the laminar flow, which can be calculated after stent implantation. And in this case, we calculated about 6 mercury millimeter and measured about 7 mercury millimeter with this FFR ratio. In another patient, you can see the pre-intervention lesion with an FFR 0.8, and after stenting it was 0.89. We compared the measured and the calculated values, and we got a quite nice correlation with the good Balt-Altman analysis results. However, if we go into the details, what are the relation the measured and the calculated FFR, then we can say that if we have a normal, I mean above 0.9 value FFR, of course it's a good result after stenting. But in my opinion, if we have FFR below 0.9, but the calculation also shows that it must be something which caused the pressure gradient, so it's a concordant decrease of FFR both in the measured and the calculated, I think it's also can associate a good stent expansion. However, if we have a lower measured FFR than the calculated one, it can indicate that the stent expansion is not proper. If we calculate these values but without any velocity assumption, and we produce the so-called flow pressure ratio, then we have this well-known scheme, and after, if we measure the real pressure during vasodilatation, then in this scheme we can readily read the actual flow if we know the pressure. The vasodilatory flow can be read in this scheme, so it can have also an importance. Furthermore, if we can calculate this pressure drop separately by the laminar flow and to the turbulent flow, then we have two components, presumably with different relevance to the prognosis, because the turbulent flow must be associated with the flow separation, which was described in the background of the atherosclerotic process. It was also proved in this experimental model. The hypercholestemic peaks was instrumented by a so-called shear modifying stent. And they found that the downstream segments of the LED exhibited very large plaque progression after the instrumentation. And when they modeled the flow, they found that there is a high velocity and shear stent at the site of the instrumentation, but lower the turbulent disturbed flow can be readily detected in association with the plaque formation. So it is my assumption that determining the patient-specific range of intracoronary flow by calculating the flow pressure relation and measuring the actual pressure during resting and vasodilatory state, in that case we can get the patient-specific turbulent resistance of the patient, which can have a prognostic index. Dear colleagues, I fully agree with the conclusion of Nico Pais, who said that if a stent is deployed adequately, only a negligible hyperemic gradient should be present across the stent. If a hyperemic gradient greater than 5 mercury millimeter persists across the stent, that is definitely a problem, and IVUS or preferably OCT is initiated. The opposite is not always true. Even without any hyperemic gradient, a stent can be insufficiently deployed. I think my observations in line with this previous one, and also the conclusion of the previous lecture, namely that great part of the residual pressure gradient after stent implantation with distal sensor position can be explained with the pressure gradient caused by the laminar resistance along the vessel segment. And on the other side, the significantly lower measured FFR than the calculated one can reveal insufficient stent implantation. Thank you very much.
So I think we have some microphones. If there are questions from the audience, maybe while you're developing some of those, I'll just start with you, Dr. Kuseji. So you'd brought up these two components to the pressure loss. One is the laminar viscous loss due to flow, and the other one is the separation expansion loss due to flow squared. And it sounds like, in your impression, we do a reasonable job with stents of getting rid of the quadratic expansion loss. For these post-PCI FFRs that are low, is your suggestion then that we do more aggressive post-dilatation in order to try to reduce laminar losses also? Is that the implication of your simulations?
Not exactly, because after stenting, the main source of the pressure gradient is from the laminar flow. And it can happen, it is linearly related to the length of the segment, not only the stent segment, but all the vessel. So the diffuse disease can generate high pressure gradient with a turbulent flow, and it depends how react the microvasculature. So high flow associated high gradient. And usually we can't do so much with further stent expansion because we just treat only a very short segment comparing to all the weather.
Yeah, I was so intrigued by using this concept of FFR outside the coronaries, and so I'd like to give Dr. Ruza the microphone, if we could, to answer this question of what do we use for a vasodilator. So in the coronaries, we've really moved to things like adenosine and some of the other medicines. You showed some examples in the brain, in the kidneys, in the periphery. What should we be using for good vasodilation there?
In peripheral circulation, I think papaverine works everywhere.
And you inject that systemically, or you give it locally? What do you do?
Locally, we are giving 30 milligrams of papaverine, and it works everywhere. Dopamine works in the renal, but adenosine works in carotids. In renals, adenosine makes vasoconstriction, so it's totally contraindicated to use. In lower limbs, we can give also adenosine. So lower limbs, adenosine, papaverine, renal, papaverine, and papaverine and dopamine. In cerebral circulation, papaverine and adenosine also.
And this notion of, we heard some of the discussions that Zsolt was showing us about QT prolongation, VT, when given in the coronaries. Is that ever a concern when you give it peripherally?
No, I've never examined this one, but it's very interesting. Otherwise, this QT prolongation, because we are giving papaverine in all patients with no reflow phenomenon in coronary arteries, and I've never seen ventricular tachycardia or torsade points. In patients with stable coronary arteries, I've seen one, but in papaverine is not so dangerous as it is mentioned to be dangerous in coronaries.
Yes, but because when you are in acute ischemic situation, the coronary artery, the QT is probably shortening, so it's compensated by the papaverine. But if you're in a stable situation and the patient receives some medication like amiodarone, you have a longer QT, and then you will just provoke, and then you get the VT or the. So I think it's a different clinical environment from the beginning. Yeah.
Now, Nick, I was taken by your talk and started to think about some of these trials that we've had recently that came out just to ESC, like CE Mark II and some of these other ones, where they're now, asking the question, when we as physicians say, yes, this patient absolutely needs an angiogram, looking at different strategies of upfront testing. And you brought up the hypothesis that maybe FFR-CT is the way to go. CE Mark II looked at cardiac MRI. We've had some other studies looking at SPECT, and I'm sure we'll see almost every non-invasive modality come through there. Do you see a role for head-to-head comparisons, or do you think, much like statin trials, people will kind of compare statins to placebo standard of care in order to choose among those options?
So obviously I don't really know, but they're looking at slightly different things, because the CE Mark inquiry is still about the best way to assess people who've come to you with a problem, and the best way to assess them. And we certainly don't do that particularly well. Everyone in the room might have a different way of assessing the same patient. Some would use a non-invasive test, some would use the cathlab, some would use a CT coronary angiogram. But the thing I was speculating on is the value of an imaging biomarker to say that a particular person, can we predict their trajectory towards an acute cardiac event? And I don't think that's what even CE Mark II is really doing. The reason I think that's fascinating is because it seems to me we're still pretty dumb in the sense that we wait for someone to have an event, and then we lavish them with all sorts of things like stents or bypass surgery and loads of tablets. And of course it's a shame that we had to wait till they had it. And then at the other extreme, certainly in the UK, the pressure is now on family doctors to put most people over the age of 50 on statins. And the irony of that is it's exposing so many people to a drug that over the course of all those years may well have side effects. It's certainly incredibly expensive for the health economy, and yet we don't actually know which of the people we apply it to we're ever going to have the event that we're trying to modify. So it would be much smarter if we had a way of knowing which of the population were destined to have an acute event, and then focus our attention on them. So it's slightly different concepts. And I mean, it's a little bit wacky in some ways, what I suggested, but then I was asked to talk about the future, and so it's just a bit of speculation.
I think, Nick, I heard you twice discussing this. There is still, I think, a significant caveat about the statins and the ischemia, because we use physiology and we assess the role of ischemia. What you're talking about treating the population and trying to go into personalized medicine is the problem. You die when you have a plaque rupture. And you know, I mean, you cannot use physiology or FFR to predict plaque rupture. So I think sometimes it's a bit like pushing to the extreme, in my opinion, the discussion, because I mean, we can discuss for a long time the use of physiology again to make good choices and remove ischemia. The risk of dying and doing a myocardial infarction, we are very bad for that, but because it's due to plaque rupture. And very few of our patients will have plaque ruptures in their life.
I think I slightly disagree with that. If you look at people who do have some symptoms and you do CT coronary calcium scoring, you can get some idea of their medium and long-term risk, although their absolute risk of an event in the near term is very low. Mm-hmm. But if you have someone with some symptoms and they have a very, very high ischemic burden in terms of percentage of their myocardium showing reversible ischemia, that correlates very well with their risk of having a near-term acute coronary event, which we assume is due to plaque rupture. So I think in people with symptoms, there is some evidence that the presence and extent of ischemia is predictive of an acute event. And what I'm talking about is whether in someone who's never had any symptoms, the same principle applies. And the answer is we don't know yet.
Jolta, I think you had a comment here. I just passed the mic down.
It was just one short comment.
Fresh from healing the LAD.
On papaver, I think nobody actually examined how often it happens towards the point to get tachycardia. But even if it happens once to you in a while, just a physician, I mean, doing, I don't know, say 500 cases a year, and if it happens every other year, you feel a little bad about it, because it's something that you want to avoid for sure. It's a diagnostic test, and you have alternatives which are safer. So this is why it's probably the last resort in the list that we can see. But of course, if you have it and if you feel comfortable with it, it's a perfect tool. I mean, it produces beautiful hyperemia.
Now, Olivier, I want to finish by asking you about this relationship that you showed us in your study between pre-PCI FFR and post-PCI FFR. That caught my eye as well. Do you want to speculate a little bit about why that happens between the two? Is it something that has to do, I was thinking about it, does it have to do with, some of the pre-PCI FFR is obviously due to the lesion, and some of it's due to other diffuse disease. And so maybe we take away the focal stenosis, but that gap is telling us about the amount of diffuse disease we've left behind. What are your thoughts about that?
Well, I mean, obviously, it's a very fascinating observation. Remember, the correlation is statistically significant, but it's very weak. Just because at the time I was just interested, as we were thinking about doing a registry, should we just get the final value, or maybe there is an interest about seeing the increase in the pressure compared with comparing the pre and the post. So I even asked Nico Page from his, one of the first large registry, and I said, why you didn't put the increase in the pressure? He said, we just simply didn't think about that.
Yeah, it's interesting, and what we saw with some of that individual level data is that once you know the post-PCI value, that the pre-PCI value doesn't predict MACE anymore, that somehow all of the prognostic value seems to be shifted to what happens after the procedure. And I didn't look at the change either. That's an interesting idea.
Yeah.
Well, good. Anything else from the audience?
I just, maybe, Nick, I will make one comment, and I think that everybody will agree. Two things, that when we look at your data, and if you remember, one of the saying of people willing to put stents everywhere, I would say 10 years ago, the joke was that if you want to put a stent, you do an IVUS. If you don't want to put a stent, you do FFR. I mean, your results clearly show that some details, some patients, finally, when you integrate physiology and FFR, they go into the arm of revascularization and PCI. So that's joke or saying is untrue, basically. So it means that physiology will help you also to decide, including some more intervention.
If you look at all the data from all the studies, actually, it generally shows that the amount of revasc is roughly the same, ironically. It's just that they're different patients and different lesions. So I think, for example, a lot of the studies seem to show that the surgeons have traditionally been very threatened by all this because they see us using more pressure wire and less surgery. But actually, for the studies that have already been done, they don't actually reduce the amount of surgery that much. They just change completely the patients who are committed to it. So I think we're just getting the right patient rather than the wrong amount of revascularization.
And the second comment, and maybe Niels can comment as well, there's just one point that we didn't discuss this morning in the early talk, is you also clearly show that, you know, when you get the highest stenosis, like the 70-90% that everybody will agree or will think it's significant, and you just use the FFR as a confirmatory technique. I mean, we should keep, and again, Niels is probably the right person to comment on this, that there is a relationship with the amount of muscle. So you may have 90% on a diagonal. It's not the same as having a moderate lesion on the LED, simply because the amount of myocardium is completely different. And I think this is a very basic but so much important concept to grasp. I don't know, Niels, if you want to comment.
I agree, and I think both of those things are important. It's not just about the depth of ischemia, but it's also the size of ischemia, and that's why the left main and proximal LAD are so much more vital, absolutely. Well, I'd like to conclude by having us give a round of applause to both of our hosts, both of our organizers, Dr. Bertrand and Dr. Ruza as well, and with that, we'll close the session. Thank you.
Thank you very much. So for those of you, I mean, I see you can see this, so there will be